Hey, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is kind of an interesting clinical problem. You see, I was called to do a consultation on a patient who had bradycardia. And when I looked at the nurse's notes, here are the strips that were saved. And notice one is at 7:38 and one is at 7:39. And you know Tulo's law, don't ever believe anything you read on a rhythm strip unless you wrote it yourself. But in this case, it looks like it might be accurate. It says here heart rate down to 30 beats per minute with 2-to-1 block. And when you look at this ECG, you see QRS complexes that are indeed very slow and far apart. And when you look in front of each QRS complex, there appears to be a P wave preceding each one. But looking in between the P waves, there appears to be a second P wave here and here. And you can see that indeed there appears to be twice as many P waves as there are QRS complexes. Now, in order to call AV block, these P's have to be regular. In other words, this P should not be premature because otherwise it would be a blocked PAC. You could have blocked atrial bigeminy, but indeed it seems like it is on time. You don't know how it started. You only have this piece of it. And when you look down at the second strip, which is only a minute later, here, it says 7-second run of junctional rhythm. And what you see here are QRS complexes that do not appear to have P waves in front of them. And so that, sure enough, does appear to be a junctional rhythm at 40-something beats per minute. And the nurse looks at me and says, well, are you going to schedule a pacemaker? And what you need to think about is the physiology. What causes AV block? Well, pretty obvious. Problem with the AV node. But what causes this, which looks like a junctional rhythm? And I don't see any P waves here. Where'd the P waves go? How could you have a junctional rhythm without any P waves? Yes, you can have a junctional rhythm if you went into complete heart block. Let's say if this became complete heart block, then you would see P's kind of marching on through at a faster rate than the QRS complexes, and the junctional rhythm would be an escape rhythm. But I don't see any P's. So if this junctional escape is occurring in the absence of P waves, where's the problem? In the sinus node. The sinus node, really, if your sinus node slows down, what happens is you remove the overdrive suppression on your AV node and your AV junction starts to fire naturally at a rate of 40-something beats per minute. It's all normal physiology, but what doesn't add up is the fact that how can you have AV conduction problems and sinus node problems within half a minute of each other? And that's when I asked the nurse, what was he doing at this time? And she said, oh, he was vomiting. Well, anyone who's worked on the floor should know that vomiting can be associated with tremendous increases in vagal tone. So that's the question. Is this vagal? How do you prove it? Well, that's the problem with having little tiny snapshots. When the telemetry techs just snip a little piece of the rhythm and show it to you, it doesn't give you the big picture. So I went to the total disclosure computer so I can see what happened during this entire episode. And here's what I found, and I'll have to scroll across so you can see the whole thing. But I blew this up so you can see all the details. So here at the top, you can see the patient appears to be in a normal sinus rhythm, and then suddenly a P wave occurs on time and is not followed by a QRS complex. And then you have one that conducts and one that blocks and one that conducts and one that blocks. And sure enough, it looks like you have 2-to-1 block initially. But let's scroll across and see what happens. So sure enough, this 2-to-1 block continues because this one conducts and then this one blocks and this one conducts and this one blocks. But now what's happening is you have a QRS complex here without a P wave in front of it. So it could be that the AV junction started to fire as an escape rhythm. But wait a minute, where are the P's? Well, here's one and here's one, but I don't really see one in between. Well, here's one that conducts, but even if there is one in between, it would seem that the sinus rate has slowed down dramatically. Of course, you can see down here that there's a significant junctional rhythm with no P waves, and as I scroll across towards the end of it, you can see that suddenly the heart rate picks up dramatically, and now, even though there's a lot of artifact, it looks like a sinus tachycardia. So I printed out those first few seconds of the arrhythmia, take out a pair of calipers, and figure out what's happening with the sinus node. Because the key to understanding a vasovagal event is that the vagus nerve influences both the sinus node and the AV node, sometimes simultaneously and sometimes one and then the other. So I set my calipers for the sinus rate. I put it at the QRS complexes, and you can see that the P to P interval is about the same. And as we move these calipers over, we can see that initially the P to P interval looks fairly stable, but this P that blocks appears to be a little bit later than it should have been. And as we move it down, we see the next P wave again is a little bit slow. So we have AV block occurring, but the sinus rate is slowing down a little bit. Now, how slow does it get? Well, let's keep marching these calipers through, and you can see that the P's are occurring later and later, meaning they're getting slower and slower. And if we come down here, we can see indeed it's quite slow. This P is occurring later, and then it's slowing down even further. And look at here. If we look for a P that's following this one, it's non-existent. So clearly something is going on with the sinus node. And when you see simultaneous AV block and sinus node dysfunction, you have to think of something extrinsic that's affecting both structures, because they are different structures, aren't they? The most common cause is a vasovagal episode, and if not, then you have to think of other things like metabolic problems, acidosis, hyperkalemia, hypoxemia, sleep apnea. It's very common to see this in the middle of the night when someone is severely hypoxemic because of sleep apnea. So keep this in mind when you see AV block and sinus node dysfunction at the same time. And just as a footnote, this patient did not wind up getting a pacemaker. We felt it was entirely vagal, and being a transient and reversible cause, it was not an indication for a pacemaker. Well, I hope that was helpful. We don't see this too often, but when you see it, you need to be able to recognize it. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is kind of interesting because we're going to see a series of ECGs that I think you'll enjoy. But starting with this one, this is the last in this series, and I was reading ECGs for the hospital, and this came up on the computer screen, and I said, oh boy, this guy's in trouble. In fact, I saw these QRS complexes practically sinusoidal, meaning that they look like a sine wave. It's almost like you can't tell the QRS from the T wave. And even where you can see the QRS, you can see there's a little tiny bit of an R and then a very, very wide S wave. And here I think is the T wave. But you can see that it's tremendously wide and bizarre. And the T wave is so bizarre that I actually read this as possible hyperkalemia. I really thought that this was some kind of metabolic disturbance, because clearly the QRS complex is so beyond abnormal. But I decided to explore the chart, and so why don't we take a step back? This is actually a 57-year-old gentleman with a long history of diabetes, hypertension, severe peripheral vascular disease, end-stage renal disease. He's on dialysis. He's already had bilateral below-the-knee amputations, and he came in the hospital with GI problems as well as an infected necrotic stump with evidence of gangrene. But this was his ECG on his last admission. And in fact, somebody named Dr. Nick actually read the thing. And what we see here are much more normal-looking QRS complexes at a rate of just over 75 beats per minute. There are nice P waves in front of each QRS, so it's a normal sinus rhythm. The QRS looks a little bit wide and somewhat bizarre, but let's get a sense of why. What's causing this delay in the interventricular conduction system? The axis is about minus 15. It's halfway isoelectric in lead 2 and lead AVF. Just remember, lead 2 is 60 degrees above the horizontal, and so that would give you an axis of minus 30, but AVF is pointing straight down, and that would give you an axis of 0. So we interpolate between the two, and we get minus 15, which is still sort of within the normal range. But let's look at the QRS complexes here in the precordium. They're a little bit wide, so of around 120, 130 milliseconds, and you have a huge amount of voltage here in V2. And you also have more than 11 small boxes in AVL. Not only that, but the ST segments exhibit evidence of strain. That means that the STs are deviating in the opposite direction from the QRS complex in almost every lead. Here in lead 3, where the QRS is mostly negative, you have a little bit of ST elevation. In V1 and V2, the STs are a little elevated, whereas here in V5, when the QRS is mostly up, the ST is depressed. Now, clearly, this widening of the QRS complex does not follow any particular bundle branch pattern. So some people would call it a nonspecific interventricular conduction disturbance, but I put it together as there being evidence of LVH with strain and widening of the QRS complex, so there's actually a choice on our computer for LVH with QRS widening and repolarization abnormalities, and that seemed to cover the whole entire thing. So now let's see what happens after that. This ECG was the first one obtained on this admission. There's still a lot of voltage here, but the axis has shifted. I think at this point, AVL is most isoelectric, which means that the axis has now shifted downwards to about minus 60. The QRS looks a little bit wider than it did before, but it still doesn't follow any particular bundle branch pattern. Out here in the precordial leads, you now have some very marked ST depression, which wasn't there before, and the QT interval looks a little bit longer than before as well. Well, what's interesting is that the cardiologist who overread this ECG called it a right bundle branch block. Now, normally in a right bundle branch block, you would see some kind of anterior forces, either an RSR prime, or sometimes it'll look like this, but this kind of doesn't go along with a right bundle branch block, even though that's what the reading says. So remember, even official readings may be incorrect, and you really should take it upon yourself to learn to interpret these 12 leads on your own. Well, the patient is running into more trouble. He's becoming septic, and actually you can see his underlying heart rate now is just about 100 beats per minute. He still has similar QRS abnormalities, although the ST segment depression isn't quite as bad. But you can still see a lot of voltage, and the QRS is only a little bit wide. But the interesting thing is that the attending cardiologist who read this ECG called it a left bundle branch block. Now, I would not agree with that because in a left bundle branch block, you expect to see in 1A AVL a very slurred up stroke with a delayed intrinsicoid deflection and notching. And you would also expect the intrinsicoid deflection in the anterior precordial leads to be delayed. In other words, you may have a little tiny R wave in V1 and V2, but the slope of that signal is going to be dramatically prolonged, and the point where the QRS reaches its lowest point is going to be at least 60 to 80 milliseconds after the onset. So this really is not a true left bundle branch block pattern, even though the confirmed ECG said so. So again, you have to be very careful looking at an ECG interpretation because they're not always correct. Well, finally, the patient deteriorated, was tremendously septic, hypotensive, and then he became bradycardic. And this ECG was obtained just before he coded. His creatinine was up at around 3.5, and his bicarb was down to about 12, which are both very abnormal. But what do you think his potassium was? It was 6.5. Now, in my intermediate course, I go over why hyperkalemia results in widening of the QRS complex. And that's a really good video to review because it goes over a whole variety of electrolyte disturbances. But very briefly, during depolarization, the sodium ions rush into the cell, and during repolarization, potassium ions rush out of the cell because of a concentration gradient, since the concentration of potassium inside the cell is much higher than the concentration of potassium outside the cell. But what happens is when you have more and more potassium building up outside the cell, this electrical gradient isn't as great. And when the cell repolarizes, it doesn't always get back down to the resting membrane potential. Now, the resetting of the sodium channels has a lot to do with resetting of the resting membrane potential. It's a voltage-dependent phenomenon. And so the sodium channels don't reset themselves properly. So now there's less sodium channels to be available to recruit when the next depolarization comes along. And with less sodium rushing into the cell, the action potential becomes very slurred, and conduction velocity through the heart muscles slows accordingly, which is why you have such a wide, bizarre, slow, sinusoidal QRS complex. If you want to go over that in a little bit more detail, go back and watch that video in the intermediate section, because it's good to review these electrolyte disturbances every now and then. But until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and I've got a great chalk talk that's very basic, and I wanted to show you how to approach this strip from a physiologic standpoint. How does an EP doctor look at a strip like this? Well, this is pretty simple and a common problem, and when you glance across the rhythm strip here, you can see that you have what's known as an RSR, right? Really slow rhythm. Just kidding. But the QRSs are very far apart, and they look to be somewhat regular. You can count off a rate because this QRS lands on a heavy line, and let's count it off. It's 300, 150, 100, 75, 60, 50, and then two more boxes would make it 40. So it's less than 40 beats per minute. And if you have a pair of calipers handy, there's a more precise way to measure these slow rates is take the calipers, place it on the R-to-R interval, and then place one point on a heavy line, and you can count the milliseconds in between beats. Each large box is 200, so that's 2, 4, 6, 8. That's 1 second, 2, 4, 6. So that's about 1,640 milliseconds. We get out our handy-dandy calculator and take 6 divided by the interval, and that gives you 36 beats per minute. Now that works because 60,000 is the fudge factor, and that's equal to heart rate times the interval. So that means the heart rate is equal to 60,000 divided by the interval, and we just use 6 and ignore all the decimal points to get the right answer. So this is very slow, isn't it? But is it regular? Because that's really key. If we move our calipers over and look at some of the other R to R intervals, this one is exactly the same, and this one is exactly the same. And so it does not appear that any of the R to R intervals are different. So you have a regular ventricular rhythm here. Well, now it's time to look for P waves. And when you glance across, it seems that there is a P wave here, and there's one here, and there's one here, and they seem to have a fixed relationship with the QRS complex, at least for the time being, except if you look very carefully, this PR interval appears to be a little bit longer than the first one. And when you look across, this one looks like it's getting even longer, and even longer still, and the final one is very, very long. So the question is, well, is this some kind of weird winky back or something? Well, remember, when you have bradycardia, you're either dealing with a sinus node problem or you're dealing with an AV nodal problem. It's either sick sinus syndrome or it's AV block. Well, if the PR is getting a little bit longer, you might think that you have some kind of AV block problem. And then what's the sinus node doing? Why does the sinus node appear to be so slow? Well, it turns out that unless you look very carefully at the ST segments, you might miss the fact that there's a second P wave present. Notice that this ST segment has a bump towards the end of it, and this one does also, but the bump is coming a little bit earlier on the ST. And this one, the bump is even earlier still. And so this bump is not part of the ST segment or the T wave. That bump is another P wave. You can't see it on this first beat because it's kind of on the upward deflection of the T wave. So that bump is kind of moving gradually closer and closer to the QRS complex, so therefore it is separate and distinct from the QRS. And if you use your eyes very carefully, you can see that these bumps seem to fall right in the middle of the P waves that we've already identified. That's a good reason to pull out your calipers again. This time we'll resize the caliper to the P to P intervals. So let's move it down to this one P wave. And so now when we move our calipers around, we can see that the P to P interval appears to be regular as well. Now we can measure the atrial rate here, and it's a little bit easier to count off this time. 300, 150, 100, 75. It's a little bit faster than 75. Maybe it's 78. So if the sinus rate is about 78 beats per minute, we said the ventricular rate was about 36 beats per minute. But if you notice, that's not exactly a multiple of 2. And remember, we said that the PR is getting longer, and so there's not a fixed relationship between the P and the QRS complex. There are situations where you have 2-to-1 AV block, where the atrial rate is exactly twice the ventricular rate and every other P wave is conducting. But in this case, what you have is sinus rhythm is 78 beats per minute, and you have no fixed relationship between the P's and the QRS's. And so your atrial rhythm is regular at one rate, your ventricular rhythm is regular at another rate, and there's no fixed relationship, so what you have is complete heart block. And it just so happens that your escape rhythm, which appears to be a narrow complex junctional rhythm, is almost kind of sort of 1/2 the sinus rate, but not quite. And it gives the impression, outward appearance initially, that there's a relationship, but there isn't. You can see the PR is getting longer, these P's are not conducting, and it's just a coincidence that the sinus rate is almost twice the ventricular rate, but clearly it's not. So the answer here is normal sinus rhythm. Remember, you should always mention what the sinus node is doing, so there's no problem with the sinus node. You have a normal sinus rhythm with complete heart block. Now, the QRS is a little bit wide, but that's not uncommon for junctional rhythm. There does seem to be a little notching here, but it's more of a nonspecific IVCD, and you have secondary T-wave changes. But when you're dealing with a junctional rhythm, it's very hard to make definite diagnoses like that, because the IVCD can throw your STs and Ts off. The important thing to bring away from this is how to analyze the relationship between the P's and the QRS's and establish the right diagnosis. Well, I hope that was helpful to you. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and I have an example of a chalk talk that I like to call In the Trenches. Yeah, these are really tough ones because of the quality of the ECG that you're dealing with and the fact that actually this was a Holter monitor that was faxed to me. So it's a little challenging just to get through all the artifact and the noise and the poor resolution. But here's how you'd approach something like this. Okay, so you obviously have a very rapid heartbeat. This is a wide QRS tachycardia. The QRS duration is at least maybe 140 or 150 milliseconds. If you take the onset of the QRS here in this lower lead on top of this heavy line, and where does the QRS end? It's probably here someplace, depending upon which lead you look at. So it's at least 3.5 small boxes, so we're talking about 140 milliseconds in width. When you have a fast rate like this, it's kind of hard to interpolate between heavy boxes, but what I like to do is count off 2 QRS complexes. So if we look at this next one, it actually lands close to this heavy line. And if this was 1 R-to-R interval, we'd count off 350, 100. And since it's 2 R-to-R intervals, that gives us a heart rate of about 200 beats per minute. So we have a wide complex tachycardia, 200 beats per minute, and it looks pretty bizarre. And you have to wonder if it's VTach or not. The one thing you need to look for is evidence of AV dissociation, because that is the hallmark of ventricular tachycardia. The problem is that when you have such a nasty looking EKG that it's just such poor quality, it's very hard to tell whether there's AV dissociation or not. Some people would look at this bump here at the beginning of the ST segment and say, well, it doesn't look like I see it here, but it does look like it's there, and it's certainly here. And so it's there more often than it's not, and I don't really get that as definite evidence of AV dissociation. But really, when we see a wide complex tachycardia like this, what's the most important thing to look at to help us figure out where it came from? The onset. How did it start? And luckily this was a Holter monitor, and the patient actually was lightheaded at this point. And so I asked them to send all the strips over. And I found the strip that started this episode. And here it is. So we have this wide complex tachycardia on the right-hand side of the strip, and on the left we see what looks like a normal sinus rhythm with P's in front of every QRS, and we're conducting 1-to-1 with a little bit of a first-degree AV block. Maybe the PR interval is about 220 milliseconds or so. And then you start with this wide complex tachycardia. Now, here's the thing. When an arrhythmia starts with a very long interval and is suddenly very wide and bizarre with no P wave in front of it, there's no reason for this first beat to be classified as aberrant because, number one, there was plenty of time for the conduction system to recover, so it's unlikely that this beat encountered refractoriness in the interventricular conduction system. And of course, the key is to look for an absence of a P wave. In fact, it's really cool if you actually see just a little bit of a P wave peeking out at the beginning of that QRS, kind of like that, because that tells you that the P occurred on time and the QRS didn't come from the P, so it must be ventricular. But let's examine how exactly this started. So here's the P wave, and then it conducted to the QRS, and here's a sinus P wave, and it conducts to the QRS. And then you have this wide beat, which is the first beat of the tachycardia, and it's early. Does that tell us whether it's ventricular or atrial? No, because you can have a PVC that's early, but you can have an aberrantly conducted PAC that conducts aberrantly because it's early. So the fact that it's early doesn't help us, but what we need to do is look to see if there's a P wave in front of it. How do we look for P waves? We examine the ST segment and the T wave of the previous couple of beats and get a sense of what they look like. It's a nice flat ST and it's a very smooth T wave, and this looks very, very similar, and we don't see any P wave there, do we? But that's not the only lead we have to look at. Look at this lead up here. There's a flat ST and a little bit of a T wave, flat ST and a little T. But now examine carefully right there that ST segment. Now I'm going to show you an enlarged version of the same strip there. Okay, so here's the first beat of the tachycardia, and let's look at the ST and the T of the beat before, and now let's look at the ST and the T here. Do we see anything? Yes, we do. Look at that jiggle right there. Now, most people wouldn't look for it there just after the previous QRS complex, but that's clearly a P wave. It has a very rapid jiggle to it. It has high frequency components, and it's clearly different from the previous two ST segments, and it conducted with a bit of a first degree AV block, and it gave rise to this QRS complex. Now, this QRS complex must therefore be aberrant because it's premature and the conduction system, one of the bundles, hadn't recovered from the previous beat, and you have a functional bundle branch block. Well, the rule is that if the first beat is wide and all the other beats look the same, then it's almost certainly SVT with aberrancy. And if you notice that there's this high-frequency jiggle after every QRS complex, which suggests that these could be retrograde P waves, and that this is some kind of reentry pathway possibly involving the AV node because it's so very regular. This is the key that unlocks the whole story, that P wave right there that initiates the tachycardia. Now, I've gone over this before in previous Chalk Talks, and I even put together a video that I added to my basic course at the very end. There's a video dedicated to diagnosing wide QRS tachycardias. But yet you'd say, wait a minute, I don't know. That looks so much like VTach. I'm not sure. Maybe that's just noise. Maybe Dr. Nick's just trying to pull our leg. I don't know. Are you sure? Well, the same patient during the same Holter monitor did this. Now you see a narrow complex tachycardia at just about the same rate of 200 beats per minute, and it does start with the same high-frequency jiggle there on the ST segment, but this time it didn't conduct aberrantly. The QRS complex looks virtually the same as the underlying complex, so this is obviously PSVT at the same exact rate as what we saw before. So I think that proves my point, that this wide complex tachycardia is supraventricular indeed, and it just happened to catch the bundle in a refractory period. Well, I hope that this edition of In the Trenches was helpful to you. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead with an interesting rhythm. And when you glance across at the forest, that you can see group beating. Here's a group of 2, and then there's a pause, and 2, and a pause, and 2, and 2. So they're groups of 2, and so it's some sort of a bigeminal rhythm. Well, of course, people will immediately think of some sort of wanky-back phenomenon, but let's look a little closer. If we look at this first beat, it appears to have a P wave in front of it, with a fairly normal PR interval. The second beat, on the other hand, does not appear to have a P wave in front of it. But following the pause, we see that the P wave is back again, and then the P wave appears to be absent. And then it's back, and then it's absent, and so forth. So the beats that follow the pause are preceded by a P wave. This P wave occurs at a fairly slow rate compared with previous QRS complex. Count out boxes is 300, 150, 100, 75, 60, 50, and then this next one is at 40. So the sinus node seems to be firing at somewhere around 40 beats per minute, quite slow. If you've taken a look at the QRS morphology, it appears to be fairly normal, and if we glance at the precordial leads, the R-wave progression is appropriate. So the question is, what is this QRS complex? Where is it coming from? Now, if you look carefully at this QRS complex, it actually looks a little bit different than the conducted QRS. The QRS morphology looks a little bit taller in some leads than others. You can especially see that in V1 down here, where you have a fairly deep S wave on the beats that have a shorter R to R interval, and a rather small S wave in the conducted beats. But overall, the QRS looks very similar, and so it must be following the normal conduction system for the most part, although there seems to be a slight aberrancy in the conduction that's responsible for the slight change in the QRS morphology. Now, we're still looking for a P wave, aren't we? Where did this QRS come from? We don't see any P in front of it, unless you're saying that it's superimposed on the T wave here, but I don't see any high-frequency jiggle in the T waves in any leads. Remember, P waves have a very high-frequency component. They look very sharp and pointy compared with T waves. But what I do see is a very high-frequency component following the QRS complex. It's easy to see in V1, but it's a little bit more difficult to see in any of the other leads. And so if we look at V1, we see this very sharp deflection here. And so if we think that this high-frequency deflection in V1 is a P wave, then it's coming after the QRS complex, a QRS that looks like it followed the normal conduction system. So where did the QRS come from, and where did this funny-looking P wave come from? It certainly does not look the same as the sinus P wave. And so what you have here are junctional premature contractions arising from the AV node. And so here in the conduction system, if a beat arises from the AV node, it should follow the normal His-Purkinje system and give rise to a normal appearing QRS complex. But it will have the opportunity to travel in a retrograde fashion and give rise to a P wave. And the relationship between the P wave and the QRS has a lot to do with where in the AV node the impulse arises from. If it arises from high up in the AV node, it doesn't take very long to get to the atrium. And so high nodal beats will often have a little bit of a P wave peering out from behind the front end of the QRS complex, whereas beats that arise from the low part of the AV node take a long time to traverse the AV node to get to the atrium, and those beats tend to have a P wave that occurs after the QRS complex is finished. Now, there are two reasons why this junctional premature beat has a slight aberrancy to it. One is that it is occurring somewhat earlier compared with the previous beat, and so there may be a very slight rate-related functional aberrancy below the His bundle that's giving rise to the change in the QRS morphology. It's also conceivable that the beat is arising from somewhere below the His bundle, and so it has to travel northward slightly before it can get to the AV node and emerge as a retrograde P wave, but then is able to turn around and at the same time go down the rest of the His-Purkinje system. But what that does is allow the branch that it arose from to be activated ahead of time compared with the other two branches. And so in effect, these other two branches are delayed slightly, perhaps enough to deform the QRS complex in this manner. At any rate, the final diagnosis here is sinus bradycardia with nodal or junctional bigeminy, a very unusual arrhythmia indeed. It's conceivable that the very slow sinus beat removes the overdrive suppression that normally keeps the AV junction from firing on a regular basis and encourages the emergence of these junctional ectopic beats. Well, I hope that was a useful discussion for you. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is kind of a back-to-basics sort of discussion. Here's a strip that I found on the telemetry unit, and it's the kind of strip that people wrestle with every day when telemetry techs and nurses come upon a wide complex tachycardia in a patient who may or may not have symptoms. Really, symptoms don't help you when it comes to figuring out whether this is coming from the atria or the ventricles. So you have to use basic physiologic principles in determining what this is. So here you have this rhythm strip, and if you look at the forest, you see that it does seem to be irregular. You've got long and short and longer, and then the QRS clearly changes from a narrow upright morphology to a downgoing, wide, slightly irregular appearance. And then on the other side, you have, again, a narrow, irregular rhythm that looks similar to the beginning. So how do you approach this? First, figure out what's the underlying rhythm. What's the patient doing? And at this point, you want to be looking for P waves or any kind of evidence of an organized atrial rhythm, like flutter or tachycardia or something. And so looking in front of each QRS complex, you're looking to see whether there's something that looks like a P wave or a flutter wave or something. You can see very fine fibrillatory waves here. So it's irregularly irregular. There's no discrete organized atrial activity. So atrial fibrillation seems to be the best answer as far as the underlying rhythm. So then you have this wide complex beat, and people will think, is this aberrantly conducted atrial fibrillation, or is this a run of non-sustained ventricular tachycardia? People in their mind will run through a number of criteria when they're trying to decide what it is. One of the things is, well, does the QRS look markedly different? And yes, it does. Although some people argue that the initial part of the QRS is going up just like this part of the QRS is going up. So maybe that helps, maybe not. They'll look at the total width of the QRS, and here it looks like about 140 to 160 milliseconds. And, that may or may not help. They'll look at the irregularity, and that's a clue to some people. Okay, so the fact that this is irregular in here will often tip one's hand to think that maybe this is AFib. Because after all, AFib is irregular, and this is irregular, so maybe this is AFib. And then some people will look and they'll say, well, I think I remember Dr. Nick is saying there's a short and a long, so maybe this is Ashman's. Well, after all is said and done, what did the nurse actually put? Well, it looks like she was kind of non-committal there. It says 10 beats of non-sustained VT versus aberrantly conducted AFib. Well, talk about putting your nickel down, huh? Well, there are ways to figure out what this is, and what you need to understand is what makes aberrant conduction. And this goes back to my discussion in the basic course, or level 1, on interventricular conduction disturbances. It's functional aberrancy that we're talking about, because interventricular conduction disturbances can be there all the time, or they can be there sometimes. And when they're there all the time, it's really easy because, patients have a bundle branch block, and it's there all the time, and those are really easy to diagnose. But it's the functional bundle branches that are here sometimes, and it has to do with rate and whether the interventricular conduction system has recovered from the previous beat. And it also has to do with refractory period, again, where the left bundle may recover slightly sooner than the right bundle. And if the AV node lets a signal down right at this moment, then the left bundle will be able to conduct, but the right bundle has not recovered from its refractory period, and it won't conduct. And that's how you get bundle branch blocks with premature beats that are precisely timed so that one bundle has recovered and the other hasn't. But the point is that this is related to rate, and short intervals are necessary to encroach upon the refractory period of the bundle branches. So that's how you get a rate-related bundle. But let's take a look at this strip down here. Now, you have a short interval here in this first beat, and this narrow beat was happy to go down both bundles. When you take a look at the first beat of this wide tachycardia, you see that the interval is much longer. Well, you have to ask yourself, why would this beat conduct aberrantly? It doesn't follow the rules. It's not rate related. It's too long of an interval. If this conducted aberrantly, well, then this should have also. Well, some people would say, what about Ashman's? Well, Ashman's usually occurs in an irregular rhythm, like atrial fibrillation. And it's characterized by a long interval followed by an aberrantly conducted beat that is coupled with a short interval. Then you say, why isn't this just rate related? Well, the point is that you'll find other beats that are coupled the same distance and they're conducted normally with a narrow QRS. The point is that the long interval preceding the aberrant beat causes the refractory periods to stretch out and become more heterogeneous. So it's the long interval that encourages aberrancy when the AV node allows the next beat to come down quickly. Looking at this, it's kind of backwards. You have a short followed by a long, so it definitely does not follow Ashman's phenomenon. And so we get back to the question of why would this beat become aberrant? And if you ask yourself that question, then it leads you to the obvious answer that this, in fact, is ventricular. This has to be a run of non-sustained VTAC. Irregular, yes. Slow, yes. But ventricular arrhythmias can be that way. They're not always fast and regular, but they are arising from a focus in the right ventricle. And it comes back to mechanisms of arrhythmia. This is probably a focus in the ventricle that's firing irregularly, as opposed to a re-entry circuit where the signal is stuck going round and round in a circle. Those tend to be more regular and rapid. So it gives you a clue as far as the mechanism of the arrhythmia. You have re-entry versus a focus that just starts firing and takes over the rhythm. So in the end, if you think in terms of physiology, you have the tools necessary to correctly diagnose an arrhythmia like this. So in a nutshell, if you have a wide QRS that occurs long after the bundles should have recovered, then it's likely ventricular. And if that first beat is ventricular, then they all must be. I hope this kind of puts things in perspective and will help you next time you come upon a wide complex strip like this. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is getting back to basics. I wanted to talk about how to approach a rhythm strip like this, so let's get to it. These two lines are continuous, And I always talk about looking at the forest first before you start looking at the trees. So if you glance across the top strip, it seems to be fairly regular, but somewhat fast. So here's a QRS that lands on a heavy line, and if we count off 300, 150, the next QRS lands just after that heavy line. So you'd think the rate is maybe 148 or so, but when you look at the next QRS, you'd expect it to march away from that line, but it doesn't. Look at that. It's the same distance from the heavy line, and the next ECG is the same distance from the heavy line. So it almost seems like it was 148 here, but then it stabilized to 150. This is 150. But now when you count off the next QRS complex, that interval is much longer, 400, so it's more like 480, like 500 milliseconds. So this is like 120. If you look at the next R to R interval, it's even longer, and then it becomes shorter again. So you have this irregularity, although at times it may be subtle, at other times it's grossly irregular. The bottom strip seems to be quite regular in the beginning, but then at the end there seems to be a bit of a pause. So now you have to start looking at the baseline to see what's the atrium doing. But you've already kind of made up your mind that this is probably not a normal sinus rhythm. And so there's likely some sort of atrial tachyarrhythmia going on. Now the hunt is on for organized atrial activity versus disorganized atrial activity, because organized atrial activity would include things like sinus tachycardia, atrial flutter, or some kind of SVT, where the atrial rate is regular, and you can actually map out P waves at a regular rate. Or is the atrial rhythm disorganized? And by that I mean atrial fibrillation. There are other disorganized arrhythmias like multifocal atrial tachycardia, but there again, you have discrete atrial events. In other words, discrete P waves in front of each QRS. So now you have to kind of analyze the baseline in between the QRS complexes, and the best way to do that is just ignore the QRSs. Now, sometimes it's hard to do when you're just starting out, but the best place to start is looking in front of each QRS to see if you see something that corresponds with it. So when we look at the first couple of beats, we see there seems to be a negative deflection in front of these QRS complexes. So that would suggest something organized and perhaps not atrial fibrillation. So that seems to be fairly consistent, except in front of this QRS, what happens is you see a signal like this, but the distance between that signal and the QRS is longer than it is in this beat here. So the relationship has changed, and some people would think, oh, maybe that's a P wave with like a growing PR interval. Maybe this is some kind of winky back kind of a thing. And you're not too far off when you see this changing relationship between the atrial event and the ventricular event. But when you look at this longer R to R interval, and usually it's in these pauses where you'll find the most information, what you need to be able to recognize is the fact that these negative deflections are not flanked by straight lines. In other words, you don't have isoelectric areas in between these negative deflections. What you have instead is more of a gradual decline in the electrical signal, and then it pops back up again. So you see this slopey appearance, and you have it again over here. So this diagonal kind of appearance, this slopey baseline, should immediately trigger a thought in your mind that this is flutter. Now that you've seen those flutter waves, look for some more pauses. And I mentioned that there are some pauses down here. So lo and behold, when you look right in this region, it appears that that sawtooth appearance of atrial flutter is indeed present. So why is it hard to see it in this part of ECG? And that's because what you have here is 2-to-1 conduction, and so it's hard to see the second flutter wave. But in fact, if you look down here, you can see that it's not hard if you know what you're looking for, because if you look right in between those negative deflections, you can see that at the tail end of the QRS complex, there is a negative deflection. And so now that you know it's flutter, it becomes very easy to see it. And if you come back up to the top strip, just to prove my point, is that a lot of people thought that this negative deflection might have been part of the QRS complex, like a right bundle branch block or something, where you have a deep negative S wave. But if you look at this QRS complex and compare it to this QRS complex, look at the difference. You don't have that negative deflection anymore. It disappeared, and that's because this QRS complex landed at a different portion of the atrial flutter cycle. In other words, instead of this flutter wave landing right after the QRS complex, it actually landed in between. So if you map out the flutter waves, you realize that there's a flutter wave right in the middle of the QRS, and then there's one that comes after. So you can see that negative deflection disappeared. So that's a subtle clue that the negative deflection is not part of the QRS, but rather it's the second flutter wave. So when you start looking carefully at the trees, you can recognize these little subtle cues that help you absolutely nail this diagnosis. Anyone with experience on a telemetry unit or anyone used to looking at ECGs would recognize this right away as atrial flutter. But some of the beginning students would have a little bit of a hard time, and what I'm trying to do is get you to start looking at these little subtle details, because you won't always have these long R to R intervals where the flutter becomes very obvious. Sometimes it is subtle, and you have to use your imagination and look at the details as you're examining these strips. Well, I hope this was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy and this week's Chalk Talk, which came from a Holter monitor. And again, we're sort of going back to basics, but I just want some of you new subscribers to understand how you approach a strip like this. So there's actually 3 different ECG leads that we're monitoring in this Holter monitor. And I always teach people, look at the forest before you look at the trees. And you can see that there are a number of normal-looking beats with Ps and QRSs and T waves. But then there's a couple of wide QRS beats here, and then there's one over here that you can see. And the question is, what are these things? And most people will say, well, these are wide, bizarre beats, and they're kind of like sandwiched in between 2 normal sinus beats. So maybe they're ventricular premature contractions, and since there's 2 of them together, we would call it a couplet. And the truth is that, yes, these are what I refer to as FLBs. That's right, they're funny-looking beats, and they are fast, coupled together at a rate of about 175 beats a minute, and they're premature. So the question is, yes, did they come from the ventricle, or are they aberrantly conducted atrial beats? The problem is that people start relying on pattern recognition in their head. They say, well, this looks like a PVC because that's what it looks like in the book. Same thing with this one. That's clearly a PVC. It's wide and bizarre. It's premature. It looks completely different than the normal underlying rhythm, so therefore it must be a PVC. And what I try to get you guys to think about is the physiology. Why is this QRS wide? You can see here the normal AV node and his Purkinje system. So a PVC arises from somewhere in the myocardium and does not follow the normal conduction system. And so it's wide because the signal has to very slowly make its way through the myocardium in a cell-to-cell propagation instead of the rapid Purkinje system. That's a much more efficient way of getting around the ventricle. So that's what makes them wide and bizarre. But it's not enough to say that it looks like a PVC to call it a PVC, because what you have to figure out is, what are the atria doing? And if you have a normal sinus rhythm with normal atrial beats coming down, then the PVC will not have a P wave in front of it. What you'll see is a normal sinus rhythm, and then the PVC will occur and there will not be a P wave in front of it. Now, sometimes PVCs occur only a little bit premature, just in front of where the normal QRS would be. So let's get rid of this heart and let's just pretend that this PVC came a little bit later. Now, where would the P wave occur? Well, the P wave would occur on time right about here. Remember, you look for the T to P interval or the QRS to P to R to P interval to say whether this P wave is occurring on time. So this P wave occurs on time, but a PVC occurs just a little bit earlier than the normal QRS would be. But what you should notice is that the PR interval is very short or non-existent. And that means that this QRS complex did not come from this P wave, rather it came from the ventricle and it just happens to have a P wave in front of it. The point is that when you're dealing with PVCs, the key is that this P wave should occur on time. If it's not on time, if it's premature, then that means something happened up here. And then all of a sudden you have to start thinking about a premature atrial beat that landed at a point when the interventricular conduction system, the His-Purkinje system, was refractory, and this gives you aberrant conduction. Aberrantly conducted PACs occur all the time. But if it's an aberrantly conducted PAC, what's the bottom line? That this P wave would be early. So let's look at this strip here. Now, you have to ask yourself two questions. Number one, is there a P wave in front of this first wide QRS beat? And then the second question is, if there is a P wave, is it early or did it come on time? And that's the bottom line. You have to logically approach this problem, and that's how you can absolutely make this diagnosis without any doubt whatsoever. Well, how do we look for P waves? P waves generally have very sharp appearances because they have a lot of rapid changes in voltage. What I like to say is they have very high frequency components because the voltage changes rapidly, as opposed to T waves that generally change voltage very slowly. So they have very low frequency components. This is all in my course. Okay, so anyway, is there a P wave in front of this QRS complex? The best thing to do is look at this T wave and compare it with the previous normal T wave. And I think it's really plain to see that indeed there is a P wave superimposed on this T. You can see it in all three leads. Look at how tall this T wave is compared with this smaller T wave associated with the normal beat. So clearly there's a P in front of it. And is the P premature? It sure is, because it landed on the T wave. It's very premature. So you have a premature beat. The PR interval associated with this PAC is a little bit longer than the normal PR interval, and that makes sense because a premature atrial beat will encounter some delay in the AV node because the AV node doesn't like premature beats. It slows down a little bit. So that means that this first QRS complex indeed is an aberrantly conducted PAC. And what did we say in previous chalk talks? If the first beat of the tachycardia is aberrantly conducted and the second beat looks more or less the same, then we can say that both of them are aberrantly conducted. Now, the funny thing is after these two premature aberrantly conducted beats, there's a third atrial beat that conducts normally. But more than likely, this was not a sinus beat because it occurs too soon after this PAC that resulted in the second QRS complex. So this is not a sinus beat. Rather, this is the third PAC in a row. So you really need to consider this an atrial triplet. That's 3 PACs in a row. The first two conducted aberrantly and the third one conducted normally. Well, the next question, of course, is what is this first beat? And I think the obvious answer is this is also a PAC with aberrant conduction. And if you're not sure, you can just look at what the normal T wave looks like and then look at the T wave of this previous beat, and you can see how tall the T wave is in comparison because there's a P wave superimposed on it. So by approaching this strip in a logical way, looking for premature atrial beats in front of wide QRS complexes, in order to figure out where did the premature event occur. Did it occur in the atria or did it occur in the ventricles? It's actually pretty easy to figure these strips out, and you should never make that mistake again. Well, I hope this was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and it's back to basics again. Here's a strip that I found on the unit, and if you show this strip to most people, they'll look at it and say, well, it's a wide complex tachycardia, and it looks like VTach. But the question is, are you sure? How can you be so sure? How can you verify? How can you prove that this is ventricular tachycardia and nothing else? Well, first of all, look at the forest, and you can see that on the left-hand side, you have a couple of what looks like normal sinus beats at a rate of about 75 beats per minute. And then you have this wide complex tachycardia that's going at a rate of maybe 120 beats per minute. And how do you figure that? Well, here's a QRS that lands on a heavy line, and you can count off 300, 150, 100, so it's in between 150 and 100. But look at two QRS complexes. Sometimes that's a little bit more accurate, because if you keep on counting, 75, 60, this QRS lands on a heavy line, and it's just exactly 1 second, which would be 60 beats per minute. And so since there are two cycles in there, the heart rate's 120. And the QRS is fairly wide. It's about maybe 160 milliseconds compared with the normal QRS, which is clearly narrow. And then it seems to end and then you have 2 normal beats again. So how do you approach it? Well, seeing how it begins is the most important thing. So if the telemetry tech just gives you this much, it's sometimes hard to figure out exactly what it is. So you have to see how it begins. And the question is, does it begin with a P wave? Because if it begins with a P wave that's premature, then chances are that the atrium is driving the rhythm. And then you have to ask yourself, well, why is it wide? Is there a reason? Is it rate related? Is there a bundle branch block? Do you have Ashman's phenomenon? You have to have a reason for aberrant conduction in the ventricles that would explain the widening of the QRS complex. So all these things are looking for SVT with aberrancy. But if you don't find them, then you have to start looking for VT. And with VT, what is the hallmark of VT? AV dissociation. If you can prove that AV dissociation is present, that means that the ventricular rate is faster than the atrial rate. Then you know the ventricle is driving the rhythm. All right, so let's take a close look at this. Now that we've looked at the forest, let's examine the trees. Okay, so here are your 2 first sinus beats, and when you look at the first wide complex beat, it's got a P wave in front of it. Whoa, look at that. So your first impulse might be to say, maybe this is SVT with aberrancy. But if you look at that P wave, and if you take a pair of calipers, so we'll place the calipers on the P to P interval, and then move it over. And if you notice, look at that. This P wave occurs on time. It's not premature, so it's not a PAC. Well, if it's not a PAC, why would it conduct aberrantly? And the other thing that you need to notice is that this PR interval of this wide beat is shorter than the normal PR interval. Well, when you see a short PR interval, most of the time it means that this QRS complex did not come from this P wave. That means it came from below. So it's likely a ventricular beat. You'll see a short PR interval with a PVC because the beat arose by itself from the ventricle and did not come from the P wave. I mean, the exception to that rule is intermittent WPW where the PR gets shorter, but that's pretty rare. Well, if this is a ventricular beat, so chances are they all are ventricular and that it's a run of VTAC. But let's prove it. Let's look in front of the next beat, and the question is, do we see a P wave there? No, we don't. And if we look in front of this beat, do we see a P wave there? Now remember, you have to look at the T waves to see if there are any deformities that would be P waves superimposed, and we don't see one there. Well, just for the heck of it, let's look at the next beat. And what do we see? We see a bump on the ST segment. Now that looks like it could be a P wave, and it's present there, but it's not present anywhere else. So here's what we can do. Let's take our calipers, and from this P to P interval, let's move it over and see where the next P wave would have landed. It looks like the next P wave would have landed here somewhere in the middle of this QRS complex. So if there is a P wave there, well, we wouldn't see it. But let's now move it over again and look at that. The P wave that we see on top of this ST segment seems to be at a point in time where you would have expected. Well, let's keep on moving to the right and look at that. Now we see a signal in front of the QRS with a very short PR interval, but clearly there's a P there that is not present here. Fascinating. So what we're finding is that the P waves are marching through the arrhythmia, and the atrial rate is slower than the ventricular rate, and that's AV dissociation. So it looks pretty convincing that this is VTAC, doesn't it? Well, let's move across and see what happens afterwards. If we move those calipers over, the next P wave lands right here, right after the QRS finishes, and you can see it. And the next P wave, right at the onset of the QRS. And if we keep on going, there's the next one on top of the ST segment. And so it's really easy to map these P waves out. We see the P's continue to march on through. Here's the next one. And the next one's in the middle of the QRS. And the last one here lands after the VT is over. And when we map out the following P, it's on time. So let's go back to the wide view. And so the fact is that you can map these P waves out, and that essentially proves that what you have is ventricular tachycardia of the presence of AV dissociation. Now here's one last thing that proves that this wide complex rhythm is coming from the ventricles, and that is that the first beat there looks a little bit different from the second beat. It looks a little bit more narrow, and you have a P wave in front of it with a PR interval that's only slightly shorter than the normal PR interval. So what kind of beat is this? It's a fusion beat. It's a fusion beat because that P wave penetrated part of the conduction system. So you've got the sinus beat here in the right atrium, and it gets to the AV node, and it starts to travel down the His-Purkinje system. And right at that moment, a PVC arises from somewhere in the ventricles and begins to propagate through the ventricles. So what happens is the signal essentially meets halfway, and the QRS complex is a combination of the two. It's more narrow than the rest of the VT beats, but it's wider than the normal sinus beat. So it's a fusion beat. It's fused between the two. So next time you see a wide complex tachycardia like this and you think it might be VTach, go through these exercises. Look for P waves, try to map it out, see if you can discern whether AV dissociation is present, because this was an easy one and it kind of looks like the book, but you'll often find other strips that are more challenging, and that's why having these tools and this knowledge of the physiology is helpful for you when the strips get to be more challenging. And that's what these Chalk Talks are all about. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a little bit of a departure. It's a 12 lead, but it's not about the rhythm. It's about interpreting the morphology. And it's something that we see now and then, but it's not too common, so I thought I would share it with you. So, of course, look at the forest first, and as you look at the rhythm strip down here, you can see that it appears to be fairly regular, and each QRS complex seems to be preceded by a P wave. Now, look at the limb leads first and get a sense of where the P waves are coming from. They are up in 1 and they're up in AVF. And so the P wave axis appears to be normal down into the patient's left. And the rate, 300, 150, 175, is just about 75. So we would have to call this a normal sinus rhythm. Look at the QRS axis. Which lead is most isoelectric? It looks like lead 3. So if you recall, lead 3 is 60 degrees above the horizontal, pointing down towards the patient's right. And that makes the axis plus 30, which of course is normal. But as you're glancing at the limb leads, you may have noticed that there appears to be some ST segment elevation. I mean, there should be a baseline, and the P wave comes off the baseline, the QRS goes above and below it, the ST should be at the baseline, and the T wave should be all lining up like this. But if you look at this beat, you can see that the ST segment is elevated and it's consistent with every beat. It's up off the baseline. There's a little bit of ST segment elevation in lead 1, maybe a half a millimeter. We don't see it in lead 3 or AVL, but we do see it in AVF. So you're thinking, is this some kind of acute MI? Maybe it's an acute inferior wall myocardial infarction. You have 2 out of 3 inferior leads with ST segment elevation. But then how do you explain lead 1? Lead 1 is lateral, so maybe it's inferolateral. Well, let's look at the precordial leads. Glancing across and evaluating the progression of the R wave, we see there's a QS pattern in V1, but V2 has a little R wave. In V3, the R wave grows, so you have normal R wave progression. But look at that, there's more ST elevation here. Certainly present in V4, V5, V6, that's lateral. But we also see about a millimeter in V2 and V3. So when we look at ST elevation, we want to think in terms of anatomical regions. So V2 and V3 are anterior. V4, V5, V6 is more lateral. 2 in AVF is inferior. So it's almost like every anatomical region is affected by this problem. So it's unlikely to be ischemia. So then what else causes ST elevation? Well, you have to think in terms of normal variants like early repolarization. But with early repolarization, you often will get sort of very exaggerated T waves as well. So I think most cardiologists would look at this tracing and read it as at least possibly consistent with pericarditis. Now, what are the findings of pericarditis? You see diffuse ST segment elevation, but you might not see it in the leads that are isoelectric. Here, like lead 3 is isoelectric, so you wouldn't necessarily see it in those leads. The other classical finding is PR segment depression, and you can see that in some of the leads. Now let's take a look at V6 a little bit more closely. Okay, now where is the baseline? The baseline is considered to be the segment between the T waves and the following P. So really the baseline is right about here. And when you look from beat to beat, it looks to be consistent. The patient's not moving, and there's no electrical drift. So if we take that as the baseline, where does the PR segment wind up in comparison? And I think you can see that the PR segment is depressed. Not to mention that the ST segment is elevated. And that's present here in V5 as well. If we take this as the baseline, the ST is up about a millimeter and the PR is down about a millimeter. So these changes are actually relatively mild. Now, I've seen pericarditis where you have 2 or 3 millimeter ST elevation and it's very impressive. This was actually a patient who had a pericardial effusion, but she didn't have the symptoms of acute pericarditis like pleuritic chest pain. So the ECG findings are relatively subtle. But it's fairly easy to recognize, and it's something that you shouldn't miss. Well, that's this week's Chalk Talk, and until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a very basic one for those beginners who need some practice measuring intervals. So this is just a rhythm strip, and lead 2, remember, goes from the top down and left to right, 60 degrees above the horizontal. And then lead 3 fills in the rest of the circle, and that's 60 degrees above the horizontal going in this direction. Remember that when we're talking about P waves and QRS complexes, most of the time the signal is traveling down and to the patient's left. So lead 2 becomes a very important lead because most of the signals are going to be upright in lead 2 because they're all heading in that direction. So when you see upright P waves and upright QRS complexes in lead 2, chances are that the signals are going in the correct direction. Now, remember, look at the forest first. You can see these QRS complexes. Just glance across and get a sense of whether they're regular or not, and they do look pretty regular. We don't have one that lands nicely on a heavy line, but this one's just to the left of a heavy line, and so is this one, and so is this one. And so they seem to be pretty consistently lined up just to the left of a heavy line. And if we use the technique of counting off boxes to figure out the heart rate, we would get 300, 150, 100. And that's pretty consistent, 300, 150, 100. Remember that every large box is equal to 200 milliseconds. And so that means 3 large boxes would be equal to 600 milliseconds. Remember, there are 60,000 milliseconds in a minute. So you take 60,000, divide that by the R to R interval, and you get 100 beats per minute. So the heart rate is just about 100 beats per minute. And the P waves, where are the P waves? Let's look. Well, most people will look in front of the QRS complex to look for a P wave. But in this case, we don't see a P wave obvious in front of the QRS complex. Well, again, looking across the forest to make sure that the signals all look consistent, what happens is that here we suddenly start to see a bump right there, which is in front of the QRS complex, but at a bit of a distance, isn't it? It's a lot further than we'd expect. If it is a P wave, it should be separate and distinct from the previous T wave. So we have P and we have QRS and we have the T wave is here. And if we look at that bump there in relation to the T wave, we see that they're quite far apart on this beat. But as we look to the left, we can see that they're actually coming closer together. And in this first beat, you can barely see that P wave because it's almost blended together with the T. Almost looks like this T wave is just got a little hump in it. But if you look from beat to beat, you can see that that hump is separate and it comes out from the T wave. And we can see that, in fact, it's not part of the T wave, that in fact is the P. So if this bump right here is the P wave, it certainly looks upright. And so I would say this is simply a normal sinus rhythm, but the PR looks kind of long. Well, that's the question. How long is it? Could there be a first degree AV block going on? So we'll get out a trusty pair of calipers and we have to resize them. Find the P wave that's kind of separate from the T wave, and you put one point at the very beginning of the P wave, and then you resize the calipers so that the other point is at the beginning of the QRS complex. And what you can do is kind of check from one PR interval to another. So let's try this one. And this PR is about the same. And if we go back, we can see that this PR is about the same. Well, you take your calipers and you place one of the points on a heavy line, and then you look to see where the other line is, and we can see it's right there. Each small box is 40 milliseconds, so you have 200 for the big box, plus another 40, gives you 240. And that's the PR interval. Well, anything over 200 milliseconds is abnormal, and we can make a diagnosis of first-degree AV block. All right, what else can we see? The QRS complex looks to be quite narrow and normal, within normal limits anyway. Now, what's the other interval that we need to worry about? Well, that would be the QT interval. We measure it from the beginning of the QRS complex until the end of the T wave. Now, where does the T wave end? That's the problem in this tracing, is that you've got this P wave on top of the T, and it may be a little bit harder to figure out where the T wave actually ends. And so sometimes it's necessary to kind of guess where that T wave would end by simply extending, like in the second beat, if we sort of extend the trajectory of the T wave to where the baseline is, we can get a sense of where that T wave ends. Well, let's grab those calipers again. Put one point on the beginning of the QRS complex, and the other point you kind of have to figure out, well, where's that T wave going to end? We'll see right about here, but we'll measure from beat to beat and see if it's consistent. And that looks about right. So, if you're off 10 or 20 milliseconds, it's not that big a deal. That's why don't get too preoccupied with intervals. The important part is understanding what you're looking at and trying to figure out the rhythm, which is actually the most difficult part. We've gotten the QT interval, and we'll bring the calipers down, put one point on a heavy line, and we can read this off. So this is 200, and this would be 400, but it's a half a box short of 400. So it's 380 milliseconds is the QT. The rule is that the T wave should not extend past the midpoint between two QRS complexes. In other words, take a line halfway between them. The T wave really should not go past that line. That's kind of like the line in the sand that suggests that the QT may be a little bit long. Remember that the QT interval is going to vary depending upon the rate. At faster rates, the QT interval will be shorter, and at slower rates, the QT interval gets longer. And so there's a formula for that, and it's been around for a long time. And it's Bizet's formula, and that is the corrected QT interval is equal to the QT divided by the square root of the R to R interval in seconds. Take the QT interval that we measured, which is 380, and divide that by the square root of the R to R interval. Now, the R to R interval we said was 600 milliseconds, and in seconds, that would be 0.6. So we take 0.6, and we take the square root of that, and then if we hit the equal sign, that completes the division problem and gives us a corrected QT interval of just about 490 milliseconds. Well, what's the normal QTC? Well, the upper limit of normal for males, some people say 420, some say 440. And for females, the normal QTC is a little bit longer, about 440 to 460 milliseconds. Regardless of whether this patient is male or female, this QTC is definitely prolonged. So what we have is a normal sinus rhythm with a first degree AV block and a long QTC. And I think with practice, it gets a lot easier to measure these intervals. Anyway, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead, but a simple one. We're just going to go through the steps of how to approach a 12 lead to get some practice. This is a relatively simple exercise. So remember, always look at the forest first. Best thing is to come down to the rhythm strip. It's lead 2. And we can get a sense that the QRS complexes are pretty regular. Let's figure out what the rate is. Here's a QRS that lands on a heavy line, and it's pretty regular, so you can count in either direction, 300, 150, 175, 60, 50. So it's in between 50 and 60, about 55 beats per minute. There are P waves in front of every QRS complex, and they seem to be consistent. The PR is consistent. So let's get a sense of where those P waves are coming from. They are up in 1 and they're up in AVF. And so the P wave is traveling down into the patient's left. And with a rate of 55 beats per minute, it seems reasonable to diagnose sinus bradycardia. Now we figured out what the sinus node is doing. Let's make sure the AV node is happy. I'm going to zoom in on the PR interval here, and we can take a look at lead 2. You can eyeball the PR from here to here. It's not exactly on a heavy line. And if you don't have your reading glasses on, sometimes it's helpful to get a pair of calipers. So with one point at the beginning of the P wave, we resize the calipers to bring the other point to the beginning of the QRS complex. And then we can bring it up to the scale, and we can see it's just a little bit less than 200 milliseconds, maybe 190, but that's kind of splitting hairs. But it would appear to be in the normal range, even if we did call it 200. Okay, let's get a sense of the QRS axis. The most isoelectric lead here is lead 2, and lead 2 is down and towards the patient's left 60 degrees above the horizontal, so your axis would be minus 30, so there is actually a left axis deviation. And then that should trigger some thoughts in your mind. Why is there a left axis deviation? When you look at the inferior leads, you get a sense that they're markedly negative. And even when you look at lead 2, it looks like there's a Q wave there. And you might even get a sense that there are Q waves in 3 and AVF. So that would maybe mean an old inferior myocardial infarction. Well, what else could it be? Again, concentrating on the QRS complexes in the limb leads and thinking about things that cause left axis deviation, you might think about possibly LVH. Well, the criteria for LVH vary, but left axis deviation is one of the criteria. And then you're looking for a certain voltage. Well, if you add the R in 1 plus the S in 3, you don't have 25, which is one criteria. But if you look at the R wave in AVL, it's about 11 millimeters. That is a kind of a borderline criteria for LVH. One last thing is looking at the QT interval. It appears to be normal, and all the ST segments appear to be isoelectric. The T waves all go in the same direction as the QRS complexes, so that's not abnormal in this particular tracing. All right, let's turn our attention to the precordial leads. You look at lead V1 and always look at the P wave because that's where you'll find things like left atrial enlargement. We don't see that here. That would be supportive of the diagnosis of LVH, but you have a little R wave and a deep S, which is normal. And then you see that the R wave and S are the same size in V2. So there's a little bit of early transition, but that could be just simply from lead placement. So you do have healthy R waves here across the precordium, and looking for voltage criteria for LVH, it's absent. And then you look at the STs and Ts, and these look to be pretty normal. Okay, so we have sinus bradycardia with left axis deviation, and possibly borderline criteria for LVH, but we're left with this idea that could there be an old inferior MI? And again, here's where you have to pull out your reading glasses. Let's zoom in on those inferior leads again. And let me remind you guys of the normal QRS naming conventions because one of my subscribers brought this up in an email to me. Okay, so when it comes to naming the QRS complex, the naming convention of what's the Q, what's the R, what's the S centers around the fact that the first positive deflection is always going to be the R wave. R's are always positive, and that's the one thing you have to remember. Now, if there is a negative deflection before the R wave, by definition, we call it the Q. And if there's a negative deflection after the R wave, we call it the S wave. Sometimes there isn't an S wave. Sometimes you'll have a QR pattern with no S. Sometimes you'll just have an R wave and an S wave with no Q. Well, I've drawn these R waves pretty large, but sometimes the R's are small, especially if the axis is going away from the lead that you're looking at. So you could have a signal that looks like this. Now, we said the first positive deflection is the R wave. And so this becomes the R wave, and this becomes the S. And that's how we name it. Now, when we're writing down these configurations, sometimes it's helpful to use uppercase and lowercase letters to give people a sense of which wave is larger. So this QRS would have a lowercase r because it's small and an uppercase S because that's large. This would have a small q and a tall r. This, of course, would be a very large r and a small s. What are some other QRS configurations? Well, what if there's no R wave? What if you just have a downward deflection with no R wave at all, nothing going up? Well, by convention, we refer to this as a QS pattern. And of course, if you have all three waves, it's simply a QRS. Okay, so let's look at lead 2. We see the first upward deflection is the R wave, so that's the R, and that means that this negative deflection is a Q. So there's a Q, and it's at least 50% the size of the R, so that becomes a significant Q wave. And Q waves, you know, can indicate the presence of infarction. So this definitely is a Q wave in lead 2, and that raises an eyebrow that you might have an old inferior MI. There is a little tiny S here just for you guys. Oh, what if you have a second upward deflection? What if you have an R wave and then an S wave, and then the signal goes up again? Well, you should know what that is if you're an intermediate subscriber. This is known as an R, S, and the second upward deflection is known as an R prime. And we'll see that most frequently in a right bundle branch block in lead V1. All right, let's look at the other two inferior leads now. Here's lead 3, and when we look very carefully with our reading glasses, or a magnifying glass, if you will. Here's the P wave, and here's the PR segment. Which way does the QRS go first? Does it go up or does it go down? It goes up. There's a little tiny upward deflection in front of this, and it's very consistent in front of every beat. So what is that? That is the R wave. So this QRS starts with an R wave, and it has a very, very deep S wave. So it fits the RS kind of morphology. A Q wave would be going down first. And so there's no Q here. And if we move over to lead AVF, we see again a little tiny R wave. Some people call it a micro R wave. And that's pretty consistent as well. So these are not Q waves, they're not QS patterns. It's a small R or a micro R with a big deep S wave. And remember, to call it inferior infarction, you really have to have 2 out of 3 inferior leads showing Q waves. And so this is not an inferior MI, it's simply a manifestation of the left axis deviation. Well, I hope this was helpful to you. Until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is somewhat basic, but it's a little unusual, and I'm going to show you why. So this was a recording from Holter monitor. So we have 3 leads that we're monitoring simultaneously. And if we look at the forest, we see it's really quite irregular. There are short intervals and there are longer intervals and there are even longer intervals and then shorter ones and very short ones. As you're glancing across the forest, you need to take notice of the trees. And you can see that there are normal looking beats, normal sinus beats with a P wave and a QRS. And then you have these premature beats, these FLBs, as I like to call them, funny looking beats. And when you have premature beats, you kind of have to examine the morphology and figure out where they're coming from. Are they coming from the atria or are they coming from the ventricles? Well, these two, this one and this one, look very much the same. However, you can see that this premature beat looks different. How does it look different? Well, it actually resembles the normally conducted beat here, whereas these very wide beats do not at all resemble the normally conducted beat. Now that you're looking at the trees themselves, let's try to map this whole thing out. We see that there's a sinus P wave here and a QRS, and then you have a normal T wave, and then right here you see a bump, and it's a very large bump. In fact, it's even larger than the intrinsic sinus P wave, and that's a giant PAC. It's a premature atrial contraction. It came early, and it conducts to the ventricle fairly normally. Although if you look at the PR interval of this premature beat, it's about 5 or 6 small boxes. So it's at least 240 or 260 milliseconds. Compare that with the normal PR interval, which is clearly less than 200, maybe 180. So what happens with a premature beat is it hits the AV node, and the AV node is not very good at conducting premature beats because those cells depolarize with calcium currents. You remember the action potential looks kind of like this, as opposed to sodium-dependent tissues like the atrial and ventricular myocardium and the bundle branches in his Purkinje system, where they have sodium rushing into the cells at very rapid rates. But the AV node depolarizes because of calcium currents, which are much slower, and as a result, it has this characteristic known as decremental conduction. And that means that with a premature beat, a PAC, it takes a little bit longer to get through it, and if it's early enough, it won't conduct at all. So you have this first degree AV block with the premature beat. But so far, everything's normal except for the fact that you have this very easily identified PAC. Okay, so you have a normal sinus beat, then a PAC that conducts with a slightly long PR interval. Then you have a normal sinus beat, and then you have this wide beat. What you need to ask yourself is this wide beat also a PAC that encountered an interventricular conduction delay in the ventricles because it was premature? In other words, does this represent aberrant conduction of a premature atrial beat, or is it coming from the ventricles? And the key is to look in front of it. Is there a P wave in front of it with a normal or prolonged PR interval? And that's where you have to look at the T wave. You look at this T wave and compare it with this T wave, and they look virtually the same. Come down here, you see a little tiny bump of a T wave in the second rhythm strip. And here in front of this PVC, it's virtually identical. And the same thing here and here. So these T waves all look the same. So there does not look to be a P wave. There's no P here. And in fact, if you look carefully at the morphology, it's very wide. The QRS is at least 200 milliseconds wide. And there's a very rapid deflection at the tail end of it, which very well could be retrograde P wave. The point is that this patient has PACs and they also have PVCs on the same rhythm strip. I think that's kind of cool because a lot of times when you're looking at someone's rhythm strip in the hospital, the idea is that, okay, what is the problem with this rhythm strip? And the assumption is that there's only one problem. But this guy's got 2 problems. He's got premature beats from the atrium and he also has premature beats from the ventricle. All right, so let's just finish it up. We have a normal sinus beat here, a normal sinus beat here, and this looks like another PVC because you've got no P wave in front of it. In fact, you have a very rapid deflection at the end, which is probably a retrograde P, and there's a rather long pause following it, which normally occurs after PACs and PVCs. Well, the other thing I wanted to show you was this next rhythm strip. And this will be easy because we know what these beats look like. So here's a normal beat, here's a normal beat, here's a normal beat. Now, this is cool. Look at this. This is a wide beat. It kind of looks wide and bizarre like the PVC, but here's the thing. Look at the T waves. See, here's a relatively flat T wave. Here's a flat T wave. Now look at that. Whoa, isn't that cool? There, right on top of the T, is the premature atrial contraction. That's the premature P wave that gave rise to this beat. But this P wave came so early that the beat managed to get down the AV node and then encountered an interventricular conduction disturbance. So it's an aberrant premature atrial contraction. If you compare it with this one's really wide and bizarre with a retrograde P. But this one's not quite as wide. It's still bizarre and it still has a big, large R prime, but clearly there's a premature atrial signal in front of it. So this patient happened to have regular PACs, aberrantly conducted PACs, and PVCs, all coming around the same time. And I thought that was cool. So just remember how you identify premature beats, whether they're atrial or ventricular, and understand how the AV node and how the Purkinje system may behave when they're hit with a premature atrial contraction. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is another episode of In the Trenches. That's right, these are strips that are not so pretty. Maybe they're kind of spotty and poor resolution, maybe a fax that someone sent you, but you can still figure out what's going on. And so when you look at the forest, what you can see here are groups of 2 QRS complexes, and each QRS looks a little bit different. There's one that's kind of tall and a little wide, and there's one that looks much shorter. And this is a repeating pattern all through this strip. So we have to figure out what this is. So anytime you have group beating, and this is one of my favorite things to talk about, bigeminy, because it looks like every other beat is kind of funny. So with group beating, you're either dealing with some kind of block, or you're dealing with some kind of premature beat that's just simply disturbing the rhythm. Now, the block may be AV block, or it may have something to do with the sinus node giving you an irregular sinus rhythm, something called sinoatrial exit block. And the premature beats could either be bigeminy, or sometimes you can have blocked or non-conducted trigeminy. So that's what you have to figure out. So this is a little bit complicated. It's not exactly basic, but let's try to figure out what's going on. When you examine these couplets, the best place to look for P wave is after a pause, right? Because then you kind of know what the atrium is going to do. And we can see that there's a very, very nice distinct P wave in front of each of these wider beats. So they're all very consistent. And the PR interval looks relatively short. We can measure it from the beginning of the P wave to the beginning of the QRS complex. And it's a little bit more than 3 boxes. So it's maybe 140 milliseconds. And it also looks consistent with every beat. So let's turn our attention to this funny looking beat here. Do we see a P wave in front of it? That's the first question you have to ask yourself. And if there is a P wave in front of it, it's going to be somewhere superimposed on this T wave. Now remember that T waves are usually very smooth and P waves are usually more spiky. And so what you're really looking for is a high frequency jiggle or a notch or a bite in the T wave that tells you that there's a P wave superimposed on it. And sure enough, we do see something that looks like that. There is a little notch in the T wave here. Most of the time, T waves don't have notches. And so you have to figure that this sort of double bump that you see here, this complex looking T wave, has to be a T wave plus a P wave jammed in together over there. It's very consistent. And sometimes you can actually see those notches changing from one beat to the next. And so then you can say for sure that there's a P wave. But in this case, they all look the same, but they all seem to have a P wave in front of them. And if you grab a pair of really tiny calipers, and I set that up to be equal to the PR interval of this beat, if you measure back from the QRS complex onset of this beat, you can see it sort of corresponds with the second bump. It's possible that the first bump is the P wave, but for sure the PR isn't short. If anything, it's normal or perhaps a little longer. Okay, but the bottom line is there does appear to be a P wave in front of each of these funny beats. Now here's where you have to ask yourself, is this a PAC, or is there another P wave in there that's blocked? And here again, you have to start to look very carefully. So if you have a P interval here, and then you have another P here, you would expect that there would be a P here someplace, or at the very least, out here, that is non-conducted. In other words, if you had second degree AV block, whether it be type 1 or type 2, there has to be a P somewhere that's not conducted, right? This is what you're looking for. You're looking for a blocked P wave. And for the life of me, I don't see a blocked P wave in here anywhere. So the T waves are very smooth, and the segment in between beats has no P waves. So I don't see a blocked P wave here anywhere. I would not call this second degree AV block. Beside the fact that to call true second degree AV block, the P to P intervals have to be regular, and here they clearly aren't. So could this be anything other than a PAC? Well, it's coupled at an awfully short interval compared with the sinus P wave. Normally, SA exit block gives just a slight difference in P to P intervals, so that you have groups that are separated not so far as this. So it's looking more and more like we're dealing with PACs, but at every other beat is premature, so we call this atrial bigeminy. Now, the last thing we have to explain is, why does the QRS look funny? And that has to do with the interventricular conduction system. Remember that from the AV node and the His bundle, you have a right bundle branch, but then the left bundle splits into two hemifascicles, and there's other smaller branches besides. So if this premature beat came down at a point when only part of the conduction system was refractory, then what can happen is it can go down most of the conduction system, but there may be one branch that's blocked, and so that small part of the myocardium has to be activated separately. And so it changes the appearance of the QRS complex without widening it excessively. And one beautiful example of this is lefty anterior hemiblock, where the lefty anterior fascicle is blocked, so the signal has to go to the apex through the posterior medial papillary muscle, and then it winds up causing a shift in the axis upwards, but not a widening of the QRS. So this is simply an interventricular conduction disturbance, you can call it, instead of a delay. But a rate-related or functional IVCD doesn't have to make the QRS look wider, it just has to make it look funny, because the signal is just simply taking a different path, and sometimes it's just a change in the axis that you notice. In lead 2, the normal beats have an axis that's going down and towards the patient's left, but the premature beats, the axis shifts leftward and now is more isoelectric to lead 2. And that's why the QRS looks smaller and equal sized above and below the baseline. So the final diagnosis here is atrial bigeminy, but the PACs are conducting with a functional IVCD, a functional aberrancy, because they're premature, so it's a rate-related aberrancy that results in a shift in the axis and basically just a change in the appearance of the QRS complex without a significant degree of widening. Well, I hope this was helpful to all you potential ECG experts out there. And until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a company that provides event monitors for my patients. These are monitors that patients wear for a week or two, and then if the monitor detects an arrhythmia, they fax us a copy of the strip. So let's take a close look here. You have what looks like a fairly regular rhythm at a rate just below 100 beats per minute, and there do appear to be P waves and QRS complexes, so the top strip looks to be fairly normal. But the second strip is continuous with the first, and there's a little bit of slowing here, and then suddenly what looks like a pause, followed by a very strange looking signal. And if I just move up to the next continuous strip, we can see this strange signal then resolves, and it looks like you're back in a normal sinus rhythm again. So the question is, what caused this pause to occur, and should we be concerned? Well, it looks like there was some kind of weird-looking QRS complex in the middle of this, and if you look very carefully, there seem to be smaller signals here that could be perhaps P waves. So the question is this AV block, or could this have been some kind of a sinus pause? But the first question you should really ask yourself is it real? Because this part of the ECG clearly does not look like a normal P, QRS, and T wave. You have these very strange looking signals that really don't look like a regular ECG. And depending upon the monitor company, these crazy signals are like calibration ramps. You can see them in monitor systems, and it's essentially an electronic signal that the monitor creates when it doesn't know what's going on, or if you lose the signal. For those of you who work on telemetry units, you may have even seen one of these on your monitors. So if you've never seen anything like this, you might be tempted to think this is some kind of wide QRS thing, but it's not. It's not a real QRS complex. It's not a real signal. So this much you can get rid of because it's not real, and it raises a real possibility that could this be some kind of artifact. In one of the early sections of my Level 1 course, I talk about a make and break artifact, which is kind of referring to the electrical circuit that's supposed to be present when you're recording this sort of a signal. If the signal is broken because a wire came loose or some other kind of external noise gets in the way of a clean recording, you can usually tell because the signal will not look real. Instead of having the usual amount of baseline jiggle, you'll see what looks like a completely straight line. And we know that biological signals do not look like a line that was drawn with a ruler. And so it's pretty easy to recognize a make and break artifact. But that's not what we have here. What we have are these little tiny signals that look like the tiny low voltage artifacts that we see commonly. We have what looks like an organized signal that they could be P waves, and we have this crazy thing that looks like it could be a QRS complex. So is it real? Let's get a pair of calipers and see if anything maps out. So I set these calipers for roughly the rate of the QRS complex, and there's a little bit of variation in here. But when we come to where the QRS would have been, we don't see anything. And if this is a P wave, it came early. And it's hard to say whether there's anything there or not. This sort of kind of maps out, but the next P wave does not occur on time if that's what it was. And this just, it's hard to know for sure, except for one thing. One clue made me decide that this was artifact. And here's where I talk about looking at the trees. Once you examine the forest, you have to look at each tree. You have to look at each QRS complex and decide whether they look alike or not. And most people will miss this, but this QRS looks exactly the same as the previous QRS, but we have a very nice tall T wave that's consistent with every single one of these beats. And look here, the T wave is missing. Well, how could the T wave just disappear? And that's why I think that right at this point here, a wire came loose, and that's why you don't see the T wave that would have been there normally. And that's the main reason why I decided that this was just junk. Because a T wave would just not simply disappear. And the fact is that after this several seconds of junk, you have this ramp signal that clearly tells you the monitor is unhappy and is not seeing a signal. It's letting us know that there's no signal until this point where the wire must have gotten reconnected or the loose connection resolved itself. In cardiac systems that rely on radio transmission, like telemetry boxes and some of the new cardiac telemetry units that people walk around with that utilize cell phone technology, this kind of ramp artifact can mean that the radio signal was lost. So sometimes it's just a subtle clue like a disappearing T wave that allows you to just ignore junk like this without having to feel like, ooh, am I missing something? Well, I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy and this week's Chalk Talk. I found a 12 lead with some very common abnormalities, and I wanted to go over it with you. So as you can see, the heart rate is kind of fast. You can find a QRS that lands on a heavy line here, and the next one is 400 milliseconds over. So if you round out the heart rate, that's 300 and 150, so 150 beats per minute. The next one is a little bit to the left of the line, and so is the next one. And so the QRS is marching away from the heavy line. And if you actually measured it in milliseconds, it's probably 149 or 148 beats per minute, but close enough. If we come down here to the rhythm strip and look at the forest, the QRS complexes are small and they look a little funny. So it's hard to get a sense of the regularity, but I think looking at most of the leads, it looks to be very regular indeed. So when you have a regular tachycardia at 150 beats per minute, there are only a few few things that it could be. But we'll figure out what the rhythm is after we look at the QRSs. The QRSs are clearly narrow, and if we look at the frontal axis, it's kind of an odd QRS morphology because it almost looks isoelectric in every lead. Some people would be tempted to call this an indeterminate axis, but it's clearly more negative in AVF. So the axis is somewhere in the upper half of the circle. And that makes sense because it's positive in AVL. As I mentioned before, the QRS looks very, very small in lead 2. It's nearly isoelectric, but I would say it's just a little bit more negative than it is positive. Well, lead 2 goes down into the patient's left, and that would give us an axis of somewhere around minus 30. But it's going to be above minus 30 because lead 2 is negative, and that means it's going away from lead 2. When we look at AVR, it's nearly isoelectric as well. And we know that AVR defines an abnormal axis where we consider things like anterior and posterior hemiblocks. So if it's isoelectric in AVR, it's actually minus 60. And it looks to me like the axis is up there someplace. If we look at the R wave progression across the precordial leads, we see that the R wave grows nicely in V2, but then it stays very short all the way out through V6, with a big residual S wave in V6. Some people would consider this possibly due to RVH, but if RVH was present, you'd expect a lot of anterior forces here going towards V1, and we don't see tall R waves there, and we also don't see a right axis deviation. So this is not RVH, but rather just simply late transition, which is commonly seen when you have interventricular conduction abnormalities like hemiblocks. So looking at this whole entire 12 lead, I would say with this axis that's markedly leftward and the late transition, that I would really be tempted to call this left anterior hemiblock. You do have little tiny R waves in the inferior leads, so these are not Q waves. It's not an old inferior MI. But it is somewhat odd and not a classic anterior hemiblock because the QRS has this sort of late upgoing deflection, and some people would actually label this as a nonspecific IVCD, given the fact that the QRS looks kind of funny. It's not wide, so in that case, it's an interventricular conduction disturbance, not so much a delay. All right, well, I've sort of skirted around the issue of the rhythm. And to figure out what the rhythm is, you have to figure out what the atrium is doing. So let's take a closer look at the limb leads. So here's actually lead 1 and lead 2. And there's a lot of artifact in lead 1. There's all this jiggly stuff, very high frequency artifact that makes it difficult and obscures the atrial activity. But the cool thing about lead 2 is that the QRS complex is very small. And so what do you think the atrium is doing underneath here? Well, there does seem to be a very sharp wave here, but it does not look like a typical P wave with an isoelectric interval before and after. And it looks a little bit too sharp to be a T wave. And what you really have to do is notice the fact that this has a very, very slopey diagonal appearance to it. And it's actually very consistent. And if you use your imagination a little bit, you realize that there's a rapid upstroke and then a slow downstroke. And this is actually a pattern that's repeated throughout. So if you're going to read this ECG properly, you need to be able to recognize this as atrial flutter. With the atrial rate that's about 300 beats per minute, and you have 2-to-1 AV conduction. Taking a step back, it is difficult to see the flutter waves in most of the leads. Because the atrial rate is fairly rapid, the second flutter wave happens to be in the middle of the QRS complex. You can recognize that sort of fluttery pattern here in AVF, but lead 2 happens to be the best lead in this ECG to see that typical sawtooth pattern. Let me show you a close-up of AVF here. It's not as easy to see because the QRSs kind of get in the way, but if you use your imagination, you can actually tell that this is atrial flutter, and as a cardiologist reading this, there's no doubt in my mind that I would read this as 2-to-1 flutter. Why is it so important? Well, it's important because these typical downgoing sawtooth flutter waves in the inferior leads are consistent with common atrial flutter, which is caused by reentry around the tricuspid annulus, which is a very easy arrhythmia to treat with catheter ablation. I'll talk about this more in one of the advanced level sections, but I get very excited when I see common atrial flutter like this because the likelihood of curing it with catheter ablation is extremely high. Indeed, a comparative study between ablation and antiarrhythmic drug therapy shows ablation is far superior. So keep your eyes peeled for these sawtooth flutter waves, and when you see rates of 150 beats per minute and irregular tachycardia, keep flutter with 2-to-1 conduction high on the list of your differential diagnosis. Well, until next time, this is Dr. Nick with the ECG Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk reviews a very common problem that we see on telemetry units. It's that wide complex tachycardia. So is it VTach or is it supraventricular with aberrancy? So we have 3 continuous strips that I got from my telemetry unit. And in the beginning, you have what look like normal beats with a P wave and a QRS and a T wave. And then what happens is the QRS complex seems to change. First of all, it becomes fast, and it also seems to change its morphology. It looks different than the underlying beats with P waves in front of them. At the very end, as you can see, that funny rhythm stops, and then you're back to what looks like a normal rhythm again. Well, the normal beats, the QRS appears to be awfully wide. It goes at least 4 boxes, so it's probably 160 to 180 milliseconds. So there's already some sort of interventricular conduction disturbance that's going on even with the normal beats. The heart rate from this first beat here is 300, 150, 100, 75, 60. This would be 50, so it's a little bit faster than 50, maybe 52 beats per minute. So you could say that there is a sinus bradycardia with some sort of IVCD. But then we have this crazy thing over here. And always try to look at the forest first, and what you see is it starts off fairly slow at a rate of maybe 90 beats a minute, and then it gets faster, but it stays kind of irregular. It kind of slows down again over here, and it becomes quite fast, and then slows down a bit before speeding up at the very last few seconds and then petering out. So it's irregularly irregular. There's no pattern to it, and the nurse who reviewed the strip decided to put her nickel down and say 24 seconds of rapid atrial fibrillation, and was very kind to label this atrial fibrillation all through the strip, and then the patient converts back to sinus rhythm. It reminds me of that old game show, The Hollywood Squares. Now I'm dating myself, right? And Peter Marshall was the host of the show, and there was a tic-tac-toe board with a bunch of movie stars and Hollywood celebrities. And there would be kind of a trivia question that would get asked, like, according to recent research, the most popular method of getting to sleep at night is... And the star would then answer the question, but often they would make up something really, really funny, or sometimes the true answer was kind of crazy and unbelievable, but often the stars would bluff, and the contestants had to decide, are they telling the truth or not? They had to decide whether they agreed or disagreed with the star they picked. And so here we are with this rhythm strip that the star, whoever this happened to be, decided to call it rapid atrial fibrillation, and you have to decide if you agree or disagree. Well, I guess I'm breaking my own rule because remember Dr. Nick's law. Never believe anything you read on a rhythm strip unless you wrote it yourself. So let's try to figure out what this is without getting distracted by what the nurse wrote. Well, we can take a closer look at how it starts. So now we have those first 3 sinus beats, and then here's the first beat of the tachycardia. What I'll do is I'll take my calipers here, and I'll place them on the very beginning of the P wave. Sometimes, if P waves are smooth, it's hard to figure out exactly what the middle is. So we'll place the points on the beginning of the P wave, and then we'll move it over and see how regular our P to P interval is. And that's pretty good. It's actually fairly regular. Well, now let's see what happens when we move this over again. Well, that's interesting. We actually can see a P wave that lands where it's supposed to land. So right there is a sinus P, but following that P is this very wide QRS complex. Now what can we say about the PR interval of this first beat? How does it compare with the normal PR? It's much shorter, isn't it? Now, if you've taken my basic course and you've gotten to chapter 15, which is on ventricular tachycardia, I have a couple of bonus videos in there talking about how to analyze wide QRS tachycardias. And this is where the answer lies, because beat number 1 here, the first beat of the tachycardia, could not have come from this P wave because the PR is too short. So the P wave really didn't get a chance to get down the AV node and take some weird aberrant path. This QRS must have been ventricular, and it looks the same as all the other QRS complexes, and so they all must be ventricular. So the indisputable answer to this question is right here on the first beat. The fact that the P wave is on time, but the QRS starts early, it tells you without a doubt that this is ventricular tachycardia. Now, the only exception to that would be in someone who had intermittent pre-excitation. In other words, Wolff-Parkinson-White syndrome, because in that case, the PR does get short. But then you would expect to see a P wave and a short PR interval in front of each and every one of these beats. And I think instead what you see is if you map these P waves out, that the next P wave lands right on time here. And there's proof of AV dissociation because the P waves are actually marching through this tracing. And the ventricular rate is faster than the atrial rate, which meets the definition of AV dissociation. And that, of course, is the hallmark of ventricular tachycardia. At the end, this irregular ventricular tachycardia stops, and that allows the sinus rhythm to take over again. So don't be fooled by irregular rhythms, and don't assume that any change in the QRS complex might be aberrant conduction unless it makes physiologic sense. Well, I hope that was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip that was a little tricky, but still pretty basic, and I wanted to go over it with you, but this is actually the third time I'm recording this Chalk Talk because I wanted to make sure that I got across my approach to an irregular rhythm strip like this. So I'm going to start like this, but then I'm going to zoom out because the whole strip really kind of tells the story. You can see that it's irregular with shorter intervals here and a couple of longer intervals here and short, but the best place to look for P waves is in those longer intervals because that's where you have enough space where P waves become apparent, and you can even see one here on the left-hand side. But when you look in front of these QRS complexes that occurred a little bit early, it appears that there's a P wave here. So you have to wonder if this is a premature atrial contraction. And with this QRS complex, there's another one here as well. Well, if we take a pair of calipers and bring it down to that first P to P interval, we can measure a heart rate that's about 80 beats per minute. But as we move these calipers across, it appears that the P to P interval is regular, and the P's are marching on through at 80 beats per minute, whereas the QRS complexes are considerably slower. And we can see these P waves superimposed on the T, and there's no QRS following those P waves. So some of these P waves are blocking. And here was the next one that we found with our calipers, and that blocks as well. So some of the P waves are conducting and some are not. And the first question you have to ask is, are they PACs? Because premature atrial contractions can land at a point when the AV node is refractory, and they may be blocked because they're premature. But that's not what we found here. The P to P interval here is really quite regular, and therefore we can diagnose second-degree AV block. Now here's where I'm going to zoom out a little bit and show you the whole entire strip. So since there are more P waves than there are QRSs, the atrial rate is faster than the ventricular rate, so AV block is present. We would not call this AV dissociation, but rather AV block. And the P waves appear to be regular at a rate of about 80 beats per minute, and you can kind of eyeball the fact that they are regular and marching on through the strip. And the QRSs are irregular. If the QRSs are irregular, you know that complete heart block is not present, because in that case, you would have an escape rhythm, which would not be influenced by the P waves and therefore would be perfectly regular. So now it's a matter of figuring out what kind of second-degree heart block we have. And it's pretty simple to tell because either your PR changes, as it does in type 1 second-degree AV block, or the PR is constant and a P wave fails to conduct without preceding PR prolongation. But don't forget the third category, and that's high grade or advanced AV block. And that implies that you have 2-to-1 or 3-to-1 second-degree AV block where multiple P waves may block, but some are still getting through. Most people who've looked at ECGs before will glance across at this strip, look at this whole forest, and begin to pick out patterns that you can easily recognize. And the best place to start is at one of those longer R to R intervals like this one, where the P wave is very clear. The PR interval starts out kind of long at about 300 milliseconds, but the next P wave seems to conduct with a much longer interval, and then this one blocks. So even though this PR interval is about 500 milliseconds, nevertheless, we can still say that it conducts because this QRS follows it and occurs earlier than if we had mapped it out. If we had mapped out the QRSs, the next QRS, if it wasn't influenced by the P wave, would have landed here. But the QRS came earlier because it was influenced by the P wave. It was conducted. And basically what you have here are 3 P waves with 2 QRSs, and you have 3-to-2 block, and the PR is getting longer, so it's really quite obviously type 1 second-degree AV block. But let's see what happens after that. Because after this P wave, the next one occurs on time. It conducts with a shorter PR interval of 300 milliseconds or so. But then this P wave appears to block. So you don't have two PRs in a row that conduct. You have 2-to-1 block now. And then as we glance across, we see that 3-to-2 pattern returns with progressive PR prolongation consistent with type 1 second degree AV block. But the interesting thing about this strip is that from here to here, you actually have 2-to-1 AV block. You have a brief period of high-grade AV block that's flanked on both sides by type 1. And the point that I want to get across here is that there's this misconception that 2-to-1 block is the same as type 2, and it's not. It very clearly does not equal type 2, because here you have type 1 AV block, and then it briefly goes into 2-to-1, and then goes back to type 1 again. So remember, 2-to-1 block does not mean type 2. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead that has an interesting arrhythmia on it. And it's, again, one of my favorite topics is bigeminy. Because when you look down here on the rhythm strip, you see that there is a regular irregularity. It's not throughout the whole strip, but you can see a couple of beats here and then a pause, and then a couple of beats here and then a pause, and a couple of beats here and a pause. So let's start to pick this apart. There do appear to be P waves in front of all the beats, but as you glance across, it appears that there's a P wave here that is perhaps not conducted. And then you have another P wave, and then there appears to be another P that doesn't conduct. So we have a short period of 2-to-1 conduction here. And so it's similar to the ECG that I went over a couple of weeks ago. But here you have a P that conducts, a P that conducts, and then it blocks again. And then we have this 3-to-2 pattern. And with group beating in 3-to-2, a lot of people will start to think, is this Winky back? Well, it's worth reviewing second degree AV block. It is second degree after all, because some of the P waves clearly conduct and some don't. So is it type 1, is it type 2, or is it high grade or advanced? And we do have a very brief period of high grade, but remember 2-to-1 AV block is not the same as type 2 second degree AV block. 2-to-1 is neither type 1 nor type 2. It's actually more advanced because the AV conduction system is failing to pass every other beat. But in this case, maybe we can figure out where the level of the block is, because ultimately the level of the block is the most important thing clinically, because infranodal block, or block below the AV node, is much more serious than block within the AV node. Well, if we just turn our attention to the QRS morphology, the QRS appears to be a little bit wide. It's about 3 small boxes, which gives us 120 milliseconds, and it has a classic left bundle branch block pattern with a slurred upstroke and 1 in AVL notching of the QRS in these lateral leads, and then a deep S wave with poor R wave progression in the anterior precordial leads. So seeing a left bundle branch block should make you think that it's more likely to be type 2, because type 2 is leveled below the AV node and is a much more serious problem. Well, let's take a closer look at the PR interval to see if it's changing or not. All right, so let's take a pair of calipers, and I've set these calipers up for the first P to P interval, which is equal to the first R to R interval. And if we look at the rate, it's a little faster than 75, it's maybe 78 beats per minute. When we move this over to the next P to P interval, we see that it's about the same, but when we come over to the fourth P to P interval, it looks a little bit longer. So why would this P wave come a little bit late? Well, it's only 40 milliseconds late, and that's a normal degree of sinus arrhythmia. Now let's keep moving and see what happens. And this one's a little bit later as well, and then this one is really late, so what's happening is the atrial rate is slowing down slightly. So it kind of makes our job a little bit harder, but we can still figure it out. Well, let's get the little brother up here and look at the PR intervals. Okay, if we carefully measure the PR interval here, and I would say that the first upward deflection of the QRS complex is the beginning of the QRS, because that corresponds with this QS pattern in lead 3. So the QRS is starting about 1.5 small boxes after this heavy line. So the PR here is about 190 milliseconds. Well, let's look at the second PR. Well, it's about the same. isn't it? So the PR does not appear to be changing. And if we come to the PR interval after the pause, it's about the same. It may be 10 milliseconds difference. Well, let's move over a little bit, and we'll take our caliper and look at the PR interval here, and it's the same 190 or 200 milliseconds, and this one is very similar. We'll come across and look at this last pair. The same PR as before, and this PR is virtually the same. Now, the other characteristic of type 2 second degree AV block is the length of the pause, because the P to Ps are not changing. In other words, this P wave here that blocks is not a blocked premature beat. It's not a non-conducted PAC. And so the pause should be about 2 times the previous R to R. Now, because we have a little bit of sinus slowing here, we have to resize our calipers a bit. Okay, so we'll fit it for the R to R interval. Let's move on over, and we can make a little mark here. And then moving the calipers over, we see that the pause is almost exactly 2 times the previous R to R. So after all of that, I think we've established once and for all, without a doubt, that this is type 2 second degree AV block with an underlying left bundle branch block and one brief run of 2-to-1 block right in here, where the block became advanced but then went back to a pattern of 3-to-2. Now it's interesting because type 2 second degree AV block is much less likely to follow fixed patterns like this 3-to-2 or 4-to-3. It's usually a more random phenomenon. But here's one example where it can throw you off. Well, this patient did go on to receive a permanent pacemaker and did fine after that. Well, I hope that was helpful to you, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from the medical ICU. I was called to see a patient with a funny heart rhythm, and this is the strip that they showed me. Now, it looks pretty messy, so let's see if we can go over this very carefully, one step at a time. When you step back and kind of look at the forest, you can see that there are some signals here that look like downgoing QRS complexes, and yet there are also some other signals that seem to be going up. So you've got 2 separate populations of QRS complexes here. So let's look at each one individually. The ones that are going down appear to be somewhat wide, but it almost appears as you glance across that some of them are wider than others. For example, out here, the signal is very wide, and this one's sort of intermediate in width, and then this one's a little bit more narrow, and this one is very, very narrow. So there's a variable width to this signal here, and there's also a variable rate. It seems like it starts out rather fast at about maybe 180 or 200 beats per minute, but then starts to slow down, and there are long pauses, especially at the very end. It slows down to a rate of about 80 beats per minute. Now, what about these other beats, the ones that go upright? You got this one here, and then you glance across, and here's one. And then looking across, you see one here, and then one here. And all these QRS complexes seem to be relatively narrow. If you notice something, though, they seem to be more regular. And if we take a pair of calipers, we can move it across and see that's a little bit shorter, and that's a little bit longer, and it's a little bit shorter again, and that's right on time. So they're pretty regular, except for just some slight variations. They're all pretty narrow. They don't vary in width like the other complexes do. And now it's time to start looking at the trees. If you take this first one, we can see that it's almost sandwiched in between 2 beats here, and it almost seems to come on top of the T wave of this beat at an almost impossible rate, like 300 beats per minute, and then the next one comes in at another 300 beats per minute. So right there, that should make you kind of wonder about this whole thing. Now we have a couple more of these wide beats. Then again, you have a narrow one that comes right after the wide one at a rate of maybe 240 beats per minute. It's only about 6 small boxes between them. What you have to think about is that perhaps the best way to describe this is that one rhythm doesn't really seem to be affecting the other. And this third beat comes a little bit after, but then you have a wide complex signal that literally lands on top of the narrow one. You need to start to wonder if there may be something wrong here. In other words, this may not be a physiologic rhythm. How can you have one QRS complex so soon after the other? The ventricle has a certain refractory period, and it just can't fire that quickly. And what I'm getting at is if this kind of a situation is not physiologically possible, then perhaps you have to figure something in here is not real. There must be some kind of artifact, So with that in mind, as we glance across at the rest of the rhythm, and as this wide QRS signal starts to slow down, you have a little bit more space in between. And you notice that this beat actually seems to have a P wave in front of it. You couldn't see the P wave very well in the prior beats because it was on top of the T. But looking at the next one, it really does look like a P wave and then a QRS. And then this signal clearly looks like artifact because it's coming literally on top of the QRS complex. And then look at this. At the end, you have a normal QRS. And that pretty much nails it that these upright signals are the real ones. And these wide downgoing signals of variable width is, in fact, artifact. You just have to remember that principle that this kind of two beats coming right on top of each other is literally impossible. So when you see stuff like this, where one type of beat is sandwiched in between two other kinds of beats, like you have here and like you have here, you have to start picking it apart and getting very critical about what's real and what's not. And I'm happy to say I was able to go into the patient's room and reassure him that no, he did not have a serious heart rhythm problem, everything is fine, and nothing else needed to be done. Well, I hope this discussion was helpful to you so that next time you look at a rhythm strip that looks this crazy, you'd be a little bit more skeptical about whether it's real or not. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a Holter monitor, and I thought it would be fun to go over this. So when we look at the whole strip and looking at the forest, we see it's very irregular. There are a couple of beats over here, and then sort of a run of something crazy, and then a couple of slow beats. And so getting down to the details, let's start looking at the trees. The first beat, obviously, it is a sinus beat. We have a nice P wave in front of it. So what do you think this beat is? First thing to do is look at the QRS complex and figure out, is it the same as a normally conducted QRS? Because if it is, then you have to think it's an atrial premature beat. But it looks a little bit different. I mean, compare this beat here in the middle lead with that one. It's really wider. It's in the opposite direction. But here in V5 and V3, these leads label that way. It does kind of resemble the intrinsically conducted beat, except just wider. So it does raise the possibility of whether this could be ventricular or not. And then when you look at this run, it looks like there's a lot of wide complex beats, and they're sort of maybe getting smaller and then getting larger and smaller again. And a lot of people would be tempted to call this torsade de pointe. Yes, torsade, that polymorphic ventricular tachycardia that you see with the long QT syndrome. Well, let's go back to that first beat and look at it a little bit more carefully. You have to figure out if the ventricle is beating prematurely, then what's the atrium doing? Normally, we would see a P wave after a ventricular premature beat, but if we look very carefully at the T wave, we see it's got a bump in it here. Certainly, if we look for a normal beat, we would find this one here, and looking at the T wave, it doesn't have a bump in the bottom lead. And in the middle lead, you see it's very smooth. But here on this first beat, we see very, very clearly that there's a P wave superimposed on the T. And the PR interval looks to be comparable with the first beat. And so we have to call this a premature atrial contraction that's aberrantly conducted. Does that make sense? Of course, if a beat starts in the atrium, then it must be an atrial premature beat. But the QRS is wide and bizarre because it came so early. The AV node let this beat down the conduction system that part of the interventricular conduction system, part of the bundle branch system, must have been refractory. And so the signal kind of took a detour and took a little bit longer to get around the ventricles, and that's why the QRS looks so wide. Well, what about this run here? It looks wide and ventricular and nasty looking, but what we see is the same P wave that initiates the run. Look at that. There's still a P wave in front of this first beat. Even though the first beat is very wide looking, very bizarre, even more bizarre than this first wide beat. Nevertheless, it originated in the atrium with this P wave. And in fact, if you look very carefully at the T, you can see another sharp deflection, which is likely the atrial event that gave rise to the second QRS complex. But why does the second QRS look different than the first? Well, Obviously, the signal took a little bit more of a detour or a little bit less, but these 3 beats were interesting to me because they look to be atrial, but the aberrancy on each beat is a little bit different, which is what makes them look polymorphic. You see how this beat is mostly up and this beat is mostly down? So if you think about the conduction system as having multiple branches, then what must be happening is it's going down one branch and coming around, and then it's going down a different branch and going in a different direction, which is sort of unusual because aberrancy most often just takes the same shape. It takes the same bizarre distortion of the QRS complex, but here it seems to change with each beat. Now, what about this wide beat? This is an interesting beat, I think, because first of all, it looks completely different than all the other beats. It's even wider. It's about 4 boxes wide. And if you look very carefully in front of it, I honestly don't see for sure that there is a P wave. Now, there could be, but remember, what causes aberrant conduction? Aberrant conduction occurs when the action potential that defines the refractory period of part of the conduction system has not yet reached the baseline, has not yet gone back to the resting membrane potential, and a beat comes down the AV node and lands at a point where the cells are not excitable. And when that happens, that part of the conduction system fails to conduct, right? But it has to occur fairly early. The rate has to be fast because most of the time aberrant conduction is rate related. But take a look at the intervals here. This interval is relatively long compared with these 2 intervals. It was almost like there was a little bit of a pause, and so you'd expect that the conduction system would have recovered. So I have a sneaking suspicion that this, in fact, is ventricular premature contraction. I just think that if you look at the next beat has just as much time, and this one conducts down the normal conduction system. So this is normal conduction. So it's conceivable that you had 3 rapid beats hit the ventricle, and maybe that kind of zipped around somewhere in a reentry circuit in the ventricle, giving rise to a PVC, before this last atrial beat comes down the conduction system in a normal fashion. But it's pretty obvious that all the other beats in this run are clearly atrial, as is this last beat over here, where again you have a P wave and it conducts with an aberrant pattern that's very similar to this first beat here. It's clear to me that the vast majority of these wide, complex, very strange, bizarre-looking beats are actually atrial with aberrant conduction. It's just that the aberrancy appears to be polymorphic. And so that's why I thought this would make an interesting Chalk Talk. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is kind of an interesting 12 lead. The 12 lead is presented in a slightly different format with the limb leads at the top and the precordial leads at the bottom. So let's give you a little history on the patient. This is a 45-year-old man who went to his doctor's office for a routine physical, and when they put the blood pressure machine on the patient, his heart rate was 40. The patient had no symptoms whatsoever, so they ran this cardiogram, and here's what we find. So when we look at the whole cardiogram, we see that there's some kind of bigeminal rhythm going on. There are normal beats followed by kind of a wide complex beat, and normal and then wide. And so every other beat seems to be a wide QRS complex beat. And it's also early because if you look at these 2 normal looking beats and find the midpoint, you see that the wide beat is early. So let's figure out what's going on here. First, let's concentrate on the normal beats. The PR interval looks normal, and the QRS certainly appears normal. It's isoelectric in AVL, so that gives us an axis of about plus 60. There are no pathological Q waves, and when you look at V1 through V6, there's a normal R wave progression across the precordium. So these normal beats with the P wave in front of them are completely normal. There's no problem with them at all. So let's take a closer look at these wide beats. So here I zoomed in on these first 3 leads, 1, 2, and 3, and we can see a very clear P wave in front of these narrow beats, but then you have these wide ones. So are they ventricular or are they atrial with aberrancy? Well, you have to figure out what's happening with the atrium. Where is the P wave associated with this beat? If you see a P wave in front of the beat, then that means it's a PAC with aberrant conduction. But when you have a bigeminal rhythm, it's kind of hard to know for sure if there's a P wave because there may be one superimposed on the T, but you can't tell because you don't have a normal beat that's not followed by a wide beat. So you can't really compare a normal T wave with one that has a weird beat like this. But what you can see is that there are differences in the ST segments from one beat to the next. Look at this one here. Now, ST segments and T waves should not really change from beat to beat. And so if you see a change, that means that there must be a P wave that's superimposed on it, and that this bump over here is not part of the ST segment. So since the P wave is coming after the QRS complex, then this is clearly not a PAC. It's a ventricular premature contraction, followed by a sinus P wave, or perhaps it's even a retrograde P wave, or some fusion of the two, because that would explain how there's a variable relationship between the QRS and the P wave. Well, at any rate, these are clearly ventricular, and what you have then is ventricular bigeminy. Now, the thing about ventricular bigeminy is that depending upon the coupling interval between the normal beat and the premature beat, the left ventricle may not have enough time to fill up properly. And so you compromise rapid ventricular filling, and then you also lose your atrial kick that can be responsible for as much as 15% of your cardiac output. So these normal beats that are followed by a pause are going to give you a very large pulsation, but the PVCs may give you such a small pulse that you don't feel them, and blood pressure machines will commonly miss them. And that's why the patient's heart rate appears to be 40, because the machine is only picking up these normal beats, it's not picking up the PVCs. Okay, so now let's talk a little bit about the PVCs. Where do you think they're coming from? Well, that's where we have to start analyzing the morphology of the PVC itself. If we go back and look at the wide view, we can see that in V1 through V3, you have a very characteristic appearance of the PVC. Looks like a left bundle branch block pattern in V1 through V3. In fact, it looks like in V5 and V6 as well. That's our first clue about where these beats are coming from. The second clue is the frontal axis of the PVC. If you calculate the frontal axis of the PVC, you see that lead 1 is most isoelectric, and 2, 3, and AVF are markedly positive. In fact, lead 1 is a little bit negative. So the axis of the PVCs is actually here, or maybe around plus 100 degrees. It's definitely going towards the feet because 2, 3, and AVF are so positive. Now, if you had to imagine where in the heart these PVCs would be coming from, if you look at the outside surface of the heart, you've got the right atrium here, and then here's the right ventricle. With the tricuspid valve inside, the blood enters the right ventricle, and then has to go out and then has to exit the pulmonary artery through the pulmonic valve. And it's just below the pulmonic valve where these extra beats arise from. This region of the heart is known as the right ventricular outflow tract, and it's a very common place for PVCs to arise from, even in people with no underlying heart disease. The PVC arises from this area of the heart, spreads down towards the feet, and then gets to the left ventricle, and then causes this left bundle branch block morphology, because it's traveling down slow intramyocardial pathways, just like it would if the patient had an underlying left bundle branch block. So very characteristically, in V1, you have a left bundle branch block morphology, and in 2, 3, and AVF, you have a markedly positive QRS complex. It's telling you that the majority of the signal is headed towards the feet. This is the most common place for PVCs to arise from in people with normal hearts, and people can have thousands of these every day and they may not even feel it. It's clearly an electrical disturbance arising from that part of the heart, and as long as there's nothing else wrong with the patient's heart and they have no symptoms, it doesn't even need to be treated. So I hope you found this to be an interesting topic and give you some food for thought when you're looking at these PVCs and trying to figure out where they're coming from. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a monitor strip from one of the ICUs. The nurse showed me this strip, and I thought I would share it with you to get you to start thinking about tachycardia mechanisms. So what we see here is a rapid rhythm. If we try to figure out the rate, this Q wave lands on a heavy line, and if we count off, we get 300, 150. So it's between 150 and 300. So sometimes I like to take 2 beats and figure out what that rate would be and then double it. We get 300, 150, 100, 75. It's about 90, which would actually give us a heart rate of about 180. Now, of course, the more precise way would be to look at the R to R interval. So from here to here, it's actually easy to see. This is 200 and then another 120, so that's 320 milliseconds. The fudge factor is 60,000 because there is 60,000 milliseconds in a minute, but you can just take the number 6 and divide it by 320 and move the decimal point over. You get 187.5 beats per minute. It's pretty fast. The QRS duration is fairly narrow. Here's one QRS that lands on a heavy line, and so it's really only about 80 milliseconds in duration. So what we have is a narrow, complex tachycardia. And what are the possibilities when you have 187 beats per minute? And it's obviously quite regular. What's the most likely mechanism? Of course, most people will just call it SVT for supraventricular tachycardia. But if you want to be an ECG expert, you have to be able to think more in terms of mechanisms. What type of supraventricular tachycardia is it? The QRS complex does have a Q wave and an R wave, but no S. And then you have this T wave here, and you have to ask yourself, well, where are the P waves? What's the atrium doing? Because it's conceivable that this is some kind of 2-to-1 atrial flutter, although it's a little fast for that because atrial flutter is usually about 220 to 350 beats per minute. So at the upper range of that, you would get about 175. So 187 is a little bit fast for 2-to-1 flutter. It could be a form of paroxysmal supraventricular tachycardia using the AV node, like AV nodal reentry tachycardia or AVRT, using an accessory pathway, or it could be an atrial tachycardia where the AV node is passively conducting the impulses to the ventricle. We call that a bystander AV node. Well, I just want you to look for subtle differences in these beats and try to get a sense of what the atrium is doing. Well, there doesn't look like there's much difference between these beats, and that is if you look at this first beat, you have the QRS, but then you have this sizable ST segment followed by this T wave. Looking at the next beat, there doesn't look like much difference. But let's look at the other end of this rhythm strip. Compare the ST segment here. It looks shorter to me. There may be a change in the length of the ST segment. Well, how could that be? Here, let's take a pair of calipers. If you put the calipers on the QT interval on this beat, moving to the next beat, we can see there's not much difference, but if we move to the last beat, we can see that the T wave, or at least what we think is the T wave, is ending sooner. How could the QT interval get shorter? And so that's your clue, that in fact this bump here is not the T wave, but it's actually the P, because it's moving independently of the QRS complex. The QT interval can't get shorter when the heart rate is stable. This wave right here is moving closer and closer to the QRS complex, and so it can't be part of the QRS, and it's not the T wave. It must be the P. So just based on this strip, we can call it atrial tachycardia. What you have to do is prove it. So really what you have to do now is look at the rest of the rhythm to try to prove what you believe now to be atrial tachycardia. And that's where you have to go back to total disclosure or pull another strip out or watch the patient further until you can establish exactly what's happening. So here's another strip that's on the chart. You have normal sinus rhythm and a sudden onset of SVT. But how does it start? Where's the first beat of the tachycardia? Well, here's the first beat of the tachycardia. Look in front of that beat and examine the interval and compare it with one of these normal beats. Ah, now you see it. This signal right here is not present here. So this must be the P wave that gave rise to this QRS complex. And the PR was relatively short for this beat, but then you see the next P wave conducts with a little bit more of a first degree AV block. Then you see this P wave is practically on top of the previous QRS complex because what's happening is the PR interval is getting longer. The P to P interval is remaining fairly constant, but the PR is getting longer because the AV node is having a hard time keeping up with this atrial tachycardia. So the PR is getting longer, the R to P is getting shorter, the P to P interval is regular, and actually if you map back you can see here, look at that. Here's a P wave that actually blocked in the AV node. It was a PAC that didn't get down the AV node, and that's probably the first beat of the tachycardia that just didn't conduct. And when we come down to this strip, we can see those P's are still there, they are regular, and each one's conducting except now the PR starts to get a little bit longer, and this P conducts with a very long first degree AV block, and then you can see that there is a P wave here, and that one blocks. And so that's like Wenke back because the next P occurs on time and that conducts with a short PR again. So what you have here is atrial tachycardia with mostly one-to-one conduction, but every now and then a P wave blocks. So some people will call it PAT with block. It's a form of Wenke back or type 1 second degree AV block because the atrial rate is just a little bit too fast for the AV node to handle. And so every now and then a P wave fails to conduct conduct, very often this cycle of atypical winky back will continue. So essentially what you have is an atrial ectopic focus that's firing rapidly, and the AV node is doing its best to conduct every impulse, but every now and then fails to conduct a beat. So I hope this discussion of arrhythmia mechanisms is helpful to you the next time you see an SVT. Try to think about what kind of SVT it is. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is one of those in the trenches, because it's kind of a lousy quality tracing, and it came from an event monitor that was faxed over to my office, but I thought it was pretty interesting. So there are actually two separate strips. This one's from about 12:30 in the afternoon, and this one came about 5:45 in the evening. Well, let's look at the top one first. Remember, look at the forest. Get a sense of what's happening with the regularity of the rhythm. And you can see it's pretty fast. As you glance across, it looks a little bit regular, but sometimes you get these longer intervals and then shorter intervals. So it is a little bit irregular, and there's no particular pattern to it. But when you look at the average distance between beats, the average is about 2 big boxes or 150 beats per minute. I would say most of the beats are a little bit faster than that. Now remember, there's a better way of measuring an average rate when you have an irregular rhythm, and that's counting off 6 seconds. This strip is exactly 6 seconds across. And that's pretty common for one of these event monitors. So let's look at the total number of R to R intervals that we have. And there you go, about 15 and a half. So that gives us a rate of about 155 beats per minute. The QRS looks pretty narrow, and the QT interval looks reasonable, so let's try to figure out what the rhythm is. The best place to look is where the R to R interval gets a little bit longer, because then you can see a little bit more of what's going on in between beats. And it does seem to be an atrial rhythm that's rapid. And over here you might be tempted to call it atrial flutter, but here it looks even faster than that. It looks more disorganized. And I think it would be more correct to call this atrial fibrillation with a rapid ventricular response. That one's pretty basic, but in the bottom strip, it was labeled as having a 2.4 second pause. And you can see these QRS complexes here, and then there's a very long space in between them. And if you count up boxes 1, 2, 3, 4, that's 1 second. 1, 2, 3, 4, that's 2 seconds. 1, 2, so that's about 2.4 seconds. Remember, during atrial fibrillation, the ventricular rate is determined by the AV node, because the atrial rhythm is very rapid and disorganized, going all over the place, but it's the AV node that passes those impulses down to the ventricle. And so when you have a long pause here, you have to wonder whether AV block is going on. Certainly in the beginning of this strip, you can see this disorganized atrial rhythm, more than 300 beats per minute. And it's not exactly consistent. You can see these waves are kind of going up a little bit, and these waves are kind of going down a little bit. So we still have atrial fibrillation. And if you had a 2.5 second pause during atrial fibrillation, that would be due to some degree of AV block. But what happens here with this flat spot? Did the wire fall off the patient? Well, the answer is likely no, because here now you have a P wave, an isolated, very clear P wave in front of this QRS complex, followed by a T, and then look, there's a second P wave. So it looks to me like this atrial fibrillation converted to a normal sinus rhythm. Now with the atrial fibrillation breaking right here, it always takes a little bit of time for the sinus node to wake up again. But once the atrial fibrillation stopped right at this moment, how long did it actually take for the sinus node to fire? Well, that's 1 second, and look at that, it's only 1.2 seconds, or not even. So this sinus pause that occurred after the end of this tachycardia, we call it a post-tachycardia pause, was really only 1.2 seconds. That's really normal. It just so happened to occur at a point when the AV node was taking a little bit of a nap, and in all probability would have conducted another impulse right around the time that this atrial fibrillation stopped. You don't know for sure, but certainly this 2.4 second pause was a combination of a slowly conducting atrial fibrillation that then stopped, and then you had a fairly normal duration sinus pause of 1.2 seconds. It's just that they added up to something that looked very impressive. But in fact, that long pause is not a reflection of severe conduction system disease. It was just one of those weird coincidences that make for a good Ecg Academy Chalk Talk. Well, I think what's also interesting is that after this second sinus P wave, it looks like there's a PAC in here someplace, and then it looks like the patient is back in atrial fibrillation again. So I just thought that this was an unusual circumstance, and the 2.4-second pause might have actually triggered a phone call from the monitoring company, but in fact, when you take a close look at it, it's really not a big deal. So I hope this helped you get tuned in to what you should be looking for when you read these monitor strips. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip that I got from the telemetry unit at my hospital. It's pretty basic, but it's worth going over again because a lot of people will miss this one. So when you look at the forest, you can see for the most part, the rate seems to be pretty fast and fairly regular as well. Let's try to measure the heart rate. This QRS lands on a heavy line, and you can see that this would be 150, and it's a bit slower than that. It's about 135 beats per minute. If you wanted to be more precise, you can measure the milliseconds. It's about 460 milliseconds, so take 6 divided by 460, and then ignore the decimal point, you get 130 beats per minute. And it mostly looks regular, but remember, look at the forest first and get a sense of whether the rhythm is consistent throughout. And what you can see is all the way on the right-hand side, it starts to slow down. So it's mostly regular, but on the right side, it gets slower. So now let's take a look at the trees. The QRS complex is a little bit wide. This one seems to start on a heavy line, and the J point, which is the very end of the QRS complex where the ST segment starts, looks to be a little bit more than 3 small boxes. You'd have to call it about 130 to 140 milliseconds. So the QRS is a little bit wide, but now let's try to figure out what the atrium is doing. If you look in front of the QRS complex, you see a signal that could be a P wave. And it seems like it's fairly consistent, at least for these few beats. But it looks like a weird P wave, doesn't it? Normally, you'd have a discrete P wave, and then a short PR segment, and then you'd see the QRS complex after that. But it's almost like there is no PR segment here. The QRS starts a little bit early, and the PR interval here is a little on the short side. Again, a little bit more than 3 small boxes, maybe 140 milliseconds. So that's the first clue that you have to look a little further. You have to dig a little deeper. And if you only had this to go by, you'd really kind of suspect that, why is the heart rate so fast? Why do we have 135 beats per minute? A lot of telemetry techs would look at this and call it sinus tachycardia. But unless the patient is running up and down the stairs, it's unlikely that this heart rate is sinus. Granted, if someone is critically ill and they're on intravenous pressor support, you might be able to whip the sinus node into a rate this high. But if we keep on looking, we can see this consistent signal in front of the QRS complex starts to get a little bit further away from the QRS. It's almost like the PR is getting longer over here. But now when the R to R interval opens up, we see the one clue that gives us the answer. And that here's what we thought was a P wave, but it has a very slopey appearance to it, and then it goes back up again. So what do you think this is? It's atrial flutter. You can see it on this cycle very nicely. That sawtooth pattern, characteristic of atrial flutter, can be seen when the heart rate slows down. So remember, during atrial flutter and fibrillation, it's the AV node that determines the ventricular response because it's being pelted by rapid signals. But if the AV node slows down, then fewer signals get to the ventricle, the heart rate slows down, and you can start to see what the atrium is doing in here. Of course, there are other things you can do to block the AV node, like carotid sinus massage, or even giving a drug like intravenous adenosine or diltiazem. But sometimes all you have to do is wait a little while, because if the patient lies down or maybe takes a nap, then the rhythm becomes very apparent. It now becomes irregularly irregular, and you can see pretty classic sawtooth flutter waves marching on through this rhythm strip. They tend to hide over here, but you can still see them. So pretty much this is atrial flutter through and through. Up here, you had 2-to-1 conduction. And remember, atrial flutter has a rate usually between 220 up to maybe 350 beats per minute. So when you see ventricular rates of 110 to about 175, you have to wonder if this ventricular rate might actually represent 2-to-1 flutter. It really is a very common arrhythmia, so have a high index of suspicion. When you see heart rates in this range, try to find those flutter waves. Look for a spot where the R to R interval opens up, and quite often you'll see why I like to call this the Black and Decker syndrome, because it looks like a cross-cut saw running through the rhythm. Well, that's it for this Chalk Talk. I hope that was helpful for some of my new subscribers. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a Holter monitor. Now, this was a patient who'd complained of some palpitations, and my partner ordered the Holter to see what was going on. And it turns out that there's some really crazy stuff in here, so I thought I'd share it with you. So when you look across at the forest, you can see that there appear to be two different populations of QRS complexes. You can see that there are two that look like this that are fairly narrow, and you have one more here on the right side. And then you have this run of what looks like a wide complex rhythm. And of course, there's another wide complex beat here. So if we look at these two narrow ones, it's pretty clear that there is a P wave in front of each one, and even though the P wave looks fairly small in amplitude compared to the QRS complex, the PR interval appears normal at around maybe 180 milliseconds. When you look carefully at the QRS duration, you can see that this beat very conveniently lands on a heavy line. And when you look at where the onset is, it's actually to the left of the third row, which gives you more than 120 milliseconds, perhaps 130. So there does appear to be an underlying IVCD going on here. The QT interval appears to be normal. We measured it at about 400 milliseconds, and clearly it's less than half of the R to R interval. There happens to be a U wave here, if anybody noticed it. It's an upward deflection that follows the T wave, but it's not particularly prominent, so I wouldn't make much of it. But we do see it right here, that U wave, following the second normal beat. And then there's this wide complex rhythm. When you look very carefully in front of that first beat, I really don't see a P wave. So those of you that thought that this was possibly aberrant atrial fibrillation are just ignoring the obvious, and that this first beat starts early and there's no P wave in front of it, and so you have to presume that it's ventricular. Well, if this is ventricular, would you call it ventricular tachycardia since you have a bunch of these beats in a row? Well, the problem with that is the rate. At least out this way, it's less than 100 beats per minute. And even though this first beat is maybe at about 120, it immediately slows down, becomes irregular, and then just stops. And so this is more correctly classified as accelerated idioventricular rhythm. And the reason it gets its name is an idioventricular rhythm usually arises from the Purkinje system because ventricular myocytes have very poor automaticity. But Purkinje fibers can fire. But normally Purkinje fibers fire at rates around 30, maybe 35, 40 beats per minute. And so with an idioventricular rhythm, you expect to see these rates. So when you see rates of 80 or 90 or 100, that's where the accelerated part comes in. So it's an accelerated idioventricular rhythm. And look at how irregular it is. Sometimes it helps to think about how these beats arise, what mechanism is responsible for these kinds of beats. So if you think about the ventricles, and we know there are Purkinje fibers that run through them, well, in patients who have, let's say, a scar on the heart, with perhaps a very, very slow conducting reentry circuit somewhere on the edge of the scar, reentry VT usually occurs because of an ectopic beat that maybe arises someplace else and gets into that reentry circuit and then starts going around in a circle. And if the tissue is sick enough, it may be a rather slow circle. So you can get slow ventricular tachycardia due to reentry. In that case, what happens is the first beat of the tachycardia looks a little bit different than the rest of the beats because it came from someplace else. And the other thing is, since it's a reentry circuit, it tends to be very, very regular. So in the case of slow reentry, due to terribly slowed conduction, it tends to be regular, and the first beat often looks different than the rest of the beats. On the other hand, what we have here is that the first beat looks exactly the same as all of the other beats, and it's very irregular. So most likely what we're dealing with is an automatic focus. In that case, somewhere in the Purkinje system, there perhaps is a clump of cells that starts sending out waves of depolarization because of a disturbance in the action potential and perhaps either an abnormal threshold because of a cellular disturbance, or sometimes what we see is an abnormality in slow diastolic depolarization that causes the cell to leak more sodium than usual and fire at a more rapid rate. I mean, clinically, if we call this AIVR, you'd be absolutely 100% right. But as far as treating it, you have to start thinking about why this is happening, what's the electrophysiologic mechanism, and that will give you some insight into what therapies would be available for this patient. Well, it turns out that she had some other runs of this AIVR, but it was quite infrequent, and her echocardiogram showed normal left ventricular function. So we recommended a conservative approach to this because AIVR tends to run a benign course. It doesn't usually progress to rapid runs of ventricular tachycardia in patients with normal left ventricular function. So with a whole bunch of reassurance, this patient was happy with not having to take medications. Well, I hope you enjoyed this discussion. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from a Holter monitor. There are 3 leads here, and when we look at the entire strip, we see that there are a couple of normal-looking beats, and then there's this run of a tachycardia. It lasts about 4.5 seconds, and then it seems to break, and then we're back to what looks like a normal rhythm again. You can see P waves in front of each beat at the beginning and at the end. With a PR interval at the upper limits of normal here, it's about 200, maybe 210 milliseconds. The QRS starts out fairly normal, maybe 100 milliseconds long, but then you've got this rapid rhythm. Now, when you look at the QRS complexes during this tachycardia, they do look wider and a little bit different than the underlying rhythm. The width of the QRS actually seems to vary a little bit. These are wider, these are a little bit more narrow, but none of them look exactly the same as the underlying rhythm. So the question is, what kind of tachycardia is this? And the 2 most obvious choices are, is it non-sustained ventricular tachycardia, or is it some kind of supraventricular tachycardia with aberrant conduction? Now, unfortunately, a lot of people who work on telemetry units use the wrong criteria to decide between these 2. They often rely on pattern recognition, and sometimes they'll just say, well, it just looks like it. Sometimes they'll take a look at the rate and say, well, it's fast, and so maybe that goes along with ventricular tachycardia. But then they'll say, wait a minute, it's a little irregular. Look in the beginning here, you've got a rate of about maybe a little more than 150, maybe 160 beats per minute. But then it gets a little bit faster here. Maybe it goes up to about 170. And then what happens is it starts to slow down. And over here, it's more like 150 beats per minute until the last beat that kind of speeds up again and then slows. So it's irregular. And a lot of people will say, well, if it's irregular, then it must be AFib. And they'll look at the QRS morphology and they'll say, well, it's different, but the initial deflection seems to be the same. All 3 leads seem to have this small R wave that goes up. And during the tachycardia, the QRS seems to have a small R wave that goes up as well. And you have a similar axis. This is kind of down, and this is down a little bit more, and this is down as well. And all 3 of these leads are down. Although the difference is, during this tachycardia, the middle lead is the smallest, whereas during a normal rhythm, the middle lead is the largest. So the QRS looks similar, but not exactly the same, so maybe it's aberrant. And then people will try to look for AV dissociation because we know that AV dissociation is the hallmark of ventricular tachycardia. And we'll look at the ST segments and the T waves to see if one looks different than another, and, well, maybe they all look alike, but some of them, see, this one looks a little bit taller than this one, and if you look at some of these leads, this looks a little bit more jiggly than this one does, but it's not really clear. So there's lots of different ways that people try to distinguish between VT and SVT with aberrancy. And I bet if I showed this to 10 telemetry techs or 10 telemetry nurses, they'd be split 50-50. Well, I would say that there are 2 ways to prove one or the other. I mentioned that the hallmark of VT is AV dissociation. So if you see AV dissociation, which means that the ventricular rate is faster than the atrial rate, and that you can see dissociated P waves kind of coming through at a slower rate than the ventricular rhythm, then pretty much you can say that it's definitely VT. But how do you prove that it's atrial? What's the one finding that really kind of clinches this diagnosis? What one thing points to it being SVT with aberrancy? It's not the rate, it's not the regularity, It's not the QRS morphology, because you can have all sorts of bizarre bundle branch blocks and it will look completely different than the underlying rhythm. And it's not so much the QRS duration. What you have to do is look to see how did it start. That's the key. You want to know, did it start early? Was it premature? Or did it start fairly late in the cycle? Because if it started late in the cycle, if it wasn't very premature, then why should it be conducting aberrantly? I mean, aberrant conduction is all about beats getting through the AV node at such a rapid rate that they encounter refractoriness in the bundle branch system and you wind up with an interventricular conduction disturbance. But we see that this first beat of the tachycardia did come fairly early. So that would support aberrant conduction. In other words, if you had a normal sinus rhythm and then the first beat of the tachycardia starts late, perhaps even with a short PR interval, that tells you it's ventricular because there's no reason for that beat to conduct aberrantly, and plus the PR interval is short, that tells you that it came from the ventricle. Sometimes you won't see the P wave there, but the QRS still starts late enough that aberrancy was unlikely because you had plenty of time for the conduction system to recover. But the fact is that this came early, and that supports it being aberrant. And the other thing to look for is, did it start with a P wave? And that's what people forget to look for. And that's where you have to look at the T waves of the prior beat. This T wave is pretty smooth right here, and this T wave is practically flat. But when we look at the first beat of the tachycardia, do we see a P wave? And the answer is yes. It's right there. You have a clear bump on top of this T wave that in the previous beat was perfectly flat. You've got this very sharp, spiky looking signal here in the top lead that's not present in the previous beat, and you can even see it in this bottom lead. So the fact that there was a P wave that occurred prematurely, then it makes all the sense in the world to say that this was a PAC with aberrant conduction that triggered this tachycardia to occur. And if the first beat is an aberrantly conducted atrial beat, then it follows logically that the rest of the tachycardia is of the same mechanism, especially since the QRSs are all fairly similar. But this right here is the one detail that most people miss. They're blinded by the bizarre appearance of the QRS complexes, and they don't look at that first beat. What really is frustrating is when the telemetry techs hand you a strip that looks like this, with no beginning and no end. And when you just have this to go by, it's much more difficult to figure out what it is. So the most helpful thing that you can do is when you're going to grab a strip to put on the chart, make sure you catch the beginning and document that in the chart, because really that's the most important thing you can do. So I think this was a pretty basic talk, but it's a problem that nurses face quite frequently, and I hope that I've helped to make some sense out of it all. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is pretty simple. It comes from a Holter monitor, and as you can see, the time here was just about 10 p.m., so the patient was sort of relaxed and had no symptoms at the time. But when we glance across at the forest, we can see something irregular is going on. The QRS complexes are going along, and then there's a pause, and then it seems to pick up again. So when you're evaluating pauses, you have to figure out, is it a sinus pause, or does it have to do with AV block of some sort? So you have to start to look for the P waves and establish a relationship between the P's and the QRS complexes. So looking in front of the QRSs, we do see what looks like a very obvious P wave, and those seem to be marching along at a fairly regular rate. And as we continue to examine the strip, we see a P wave here that's not followed by a QRS complex. But there is a P wave out this way. So we want to make sure that these are perfectly regular, because one of the most common mistakes is thinking that you have second-degree AV block, whereas in fact what you have is a blocked PAC, because the AV node does not do well with rapid rates and premature beats. So sometimes a premature atrial contraction may land at a point when the AV node is refractory, and as a result it fails to get down the AV node. But under the right circumstances, it can look like second-degree AV block. So the first thing you want to do is make sure that your P waves are regular. So we'll grab a pair of calipers and come down to the first P to P interval, and we set the calipers up fairly closely to that. We can measure the rate by putting a left point on a heavy line, and these lines are 1 second apart, so we can see it's a little bit faster than 60 beats per minute. But as we move the calipers over, we can see the P to P interval looks to be quite regular. And in fact, this P wave that does not conduct is on time. Therefore, it's not a blocked PAC. The P wave comes perfectly on time, so it's a sinus P wave. And the next one is on time as well. So these P's, the atrial rhythm here, is perfectly regular. So we can now say without a doubt that second degree AV block is present because some of the P waves conduct and some don't. We know it's not complete heart block because if it were complete heart block, the QRS complexes would be perfectly regular because in complete heart block, the ventricular rhythm is an escape rhythm and is not being influenced by any of the P waves. None of the P waves conduct perfectly regular. So it's not complete heart block, it's second degree AV block. So now we have to figure out, is it type 1, is it type 2, or is it high grade, which includes 2 to 1 and 3 to 1, and it's obviously not that because it appears that there are several sequential P waves that do conduct to the ventricles. So now you have to decide, is the PR fixed or does it seem to be getting longer? I think once you've started to read ECGs and once you get used to reading ECGs, you start to be able to see intervals with your eyes. You can train your eyes to measure things, and you don't always have to resort to pulling out a pair of calipers. But I will show you what happens to the PR interval here. It starts out, if we lift this up and bring it to a heavy line, it starts out at about 380 milliseconds. The next PR interval is obviously longer. It's about 200 milliseconds. The next PR interval is again about 200, but when you come to the fourth one over here, it suddenly jumps to about 280 milliseconds. Now this next beat is blocked, and then the PR becomes quite short. It's only about 240 or 260 milliseconds here. And then it kind of goes back to where it was at around 280. So essentially the PR is variable. It's getting longer prior to the dropped beat, and then it seems to get shorter again. So that tells us it's classic type 1 second degree AV block. What doesn't fit that diagnosis is the fact that the QRS complex is relatively wide. This one here starts on a heavy line, and you can measure a good 140 milliseconds. There is some sort of IVCD going on. And if you remember my discussion of AV block, the idea is that you have to try to figure out where is the block occurring. Is it occurring in the AV node itself, or is the block occurring down low in the bundle branch system? Now, when you have a bundle branch block or an IVCD, it suggests that there's some disease down here in the bundle branch system, and that's commonly seen in type 2 AV block. However, here the PR is clearly getting longer, and it follows a pretty classic pattern of type 1. So why is the QRS complex wide? Well, you can have conduction system disease in more than one place. So in this case, the patient's AV node is exhibiting abnormal behavior because here it is exhibiting second degree AV block at a heart rate of only 60. But at the same time, down here in the bundle branches, there's some disturbance in interventricular conduction that's causing the QRS to be widened. So that suggests that there's conduction system disease in both regions. Now here's a little food for thought. This PR interval following the pause is really very short compared to all the others. And the QRS also, curiously, looks a little bit different than most of the other QRS complexes. So I want you guys to start thinking in terms of whether this QRS complex might be a junctional escape. And the reason that would occur is because you have such a long period of time in between these two QRS complexes that the AV nodal tissue may decide to fire because of the removal of overdrive suppression that would be seen during a normal sinus rhythm. So after this long pause, the AV node may decide to wake up and fire, and often these junctional escape beats will have a very short PR interval, much shorter than the rest of the PRs. and often they'll have a slightly different QRS morphology. Now, it's very difficult to tell if this truly is a junctional escape just based on this one tracing. And you would have to kind of compare PR intervals after several different pauses to see if the AV node is consistently behaving in this manner or whether intermittently there's a junctional escape beat. Some of my earliest chalk talks dealt with second-degree AV block and junctional escape beats that result in very short PR intervals following the pause. You might want to go back and check those out. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead with some interesting rhythm problems. So let's take a look at the forest. Down here on the rhythm strip lead 2, it looks irregular. There are obviously some shorter intervals like this one and that one, but most of the ECG is really quite slow. And when we look at these slow QRS complexes, they don't appear to have any P waves in front of them, but the QRS complexes look identical to the faster beats. Well, when you see such a slow rhythm like this, people are tempted to sort of call it possible complete heart block. But in order for it to be complete heart block, none of the P waves should be conducting, and so the ventricular rhythm is actually an escape rhythm. And escape rhythms tend to be very regular, could be junctional or idioventricular, but they should be perfectly regular. And this is obviously not regular. And since the ventricular rhythm is not regular, then this is not complete heart block. Some of the P waves must be getting through. And it's really quite easy to see that because this beat, which comes at a short interval, does indeed have a P wave in front of it. And in fact, the PR interval of that beat appears to be quite short, certainly in the normal range. And when we look at this other beat that occurs after a very short interval, we see the same thing. There's a P wave there with a relatively short PR interval. So the P waves that are there are actually conducting quite normally, and that's really our first clue that AV conduction is actually normal. Remember that bradycardia can either be due to an AV nodal problem or a sinus nodal problem. So what is the sinus node doing? Well, here's where we have to start looking for P waves. We see one here, and that P wave is kind of small, so you have to look very carefully at the baseline to look for P waves. There's obviously no P wave here in front of this beat, but what about after it? Does anybody see a P wave here? Examine the ST segment of this beat and compare it to this. It should be very apparent that there is a P wave right here, just after the QRS complex. Now, would that be a retrograde P? Well, it looks upright to me. And remember, we're looking at lead 2. So if it was a retrograde P wave, then that P would be traveling up from the AV nodal region, away from the feet. So you'd expect a retrograde P to be inverted in lead 2. But this P wave looks upright to me. So now we have this long flat interval, and here's this next beat with no P in front of it. Now we can see that there is an upright bump in front of the T wave. So now we're starting to trace where the P's are, and it would appear that the sinus node is really very, very slow. So here are these two free-range P waves over here. They're like chickens running in the field. And if we measure the interval between them, it's actually 1400 milliseconds. So it's 14 divided by 6, and you see that's a rate of 23 beats per minute. Pretty slow. Now, is that the same interval as this P wave? Well, looks pretty close, doesn't it? Again, you have 7 large boxes or 1400 milliseconds. Now let's look forward 7 boxes just to see if it measures out. So you'd expect the next P wave would be here, and there does look like there's a P right there. But what's interesting in this strip is when you look at the following T wave, it looks like there's a P here. Well, how could that be? Well, regardless of what the AV node is doing and regardless of what the sinus node is doing, this very well could just simply be a premature atrial contraction in the setting of severe sinus bradycardia. Well, if we measure 7 large boxes from this P wave, we see that this one occurs on time, but this one manages to conduct. And then if you measure 7 boxes, you have this P wave that lands on the ST segment. So far, it would appear that the underlying problem is severe sinus bradycardia. And when P waves land at a certain point in the cycle, they do conduct normally. But it's obvious that there are these junctional escape beats running through the whole strip. And these are the beats that don't have P waves in front of them. They look the same as the conducted beats, but they're coming from the AV node. And there's a little bit of variability in the interval that these QRS complexes are occurring at. So the junctional escape beats are not perfectly regular. But just to give you an idea of what's happening physiologically, with this junctional escape beat, the AV node has just depolarized. And so when this sinus P wave occurs, the AV node is still refractory. And so this P wave is not able to be conducted. It's blocked because this junctional beat caused the AV node to become refractory. So this P wave could not get through. But this P wave here was able to get through because it occurred sometime after the last junctional beat. So by this time, the AV node has recovered from refractoriness and is able to conduct very nicely. But now following this beat, there's such a long interval with no P wave that this junctional escape occurs. And that keeps this P wave from conducting because the AV node's busy again. It's kind of like these two pacemaker foci, the sinus node, which is very slow, and the AV node, which is also very slow, are out of sync with each other and firing at different rates. But every now and then, for example, this beat here, and the P wave lands at a point where it is able to get down the AV node and cause this QRS complex to come relatively early compared with these junctional escape beats. What you have here is AV dissociation because the two pacemaker sites are beating at different rates, but this is known as a capture beat. A capture beat is characteristic of AV dissociation and can occur whenever you have a ventricular rhythm that's beating faster than the atrial rhythm, but every now and then an atrial beat gets down normally and causes the QRS to come earlier than you would expect. Well, the rest of the EKG is pretty straightforward. The QRS is isoelectric in lead 3, which gives us an axis of about 30 degrees, and you have T-wave inversion in AVL, although that's fairly normal, especially when the QRS is so small. And the only thing that's notable is that you have a huge amount of negative voltage in V2, and V6 is generous as well, and you have more than 35 small boxes. And so that's marginal criteria for LVH. You don't really have any other manifestations of left ventricular hypertrophy in this tracing. So at the end, we have severe sinus bradycardia with occasional atrial premature beats. You have normal AV conduction, and you have a junctional escape with capture beats and borderline criteria for LVH. Well, I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting rhythm strip that I thought I would share with you. So jumping right into it here, we see some QRS complexes, but they seem to be really quite slow, and they also seem to be somewhat irregular. And here's a continuous strip down here, again very slow and a little irregular. No particular pattern to it. The rate varies continuously, and if we just take this first R to R interval, it's about 1700 milliseconds. So if we take the magic fudge factor of 6 and divide it by 17, or 1700, depending upon how many places you want to move the decimal point over, you can see it comes out to about 35 beats per minute. And that's probably the average R to R interval. This one is nearly 3 seconds long. That gives us a rate of about 20. The QRS complexes look rather narrow, and I did notice that the QT interval is very long. It's about 600 milliseconds, but given the very, very slow heart rate, that's probably not abnormal. So what's the rhythm? Well, when you look in front of the QRS complexes, I don't see any P waves. And you might think that maybe this is a P wave, but it's awfully small, and it's really the only one that I see of all these QRS complexes. And so if there's no P wave, a lot of people will look at this and say, well, could this be a junctional rhythm? Because after all, slow QRS complexes with no P waves in front of them often represent an escape focus down in the AV node, what we call a junctional rhythm that can occur if either the sinus node or the AV node fails and you have severe bradycardia. Then the lower part of the AV node starts to fire because why? Well, what you removed is the overdrive suppression that a normal rhythm provides that keeps the AV node from firing on its own. When you eliminate the overdrive suppression, these lower foci start to fire. And people will look at these and say, well, these look like junctional beats because there's no P in front of them. But that's not the right answer. And the reason it's not the right answer is because it's not regular. You see, an escape focus arising from the AV node or the AV junction somewhere is firing because the overdrive suppression has been removed. Theoretically, there should be no beats coming from above. Something has blocked all those sinus nodal beats from getting to the AV node, and as a result, this focus starts to fire. But an escape focus like that should be a regular rhythm. And this is clearly not regular. And so these QRSs do not act like a junctional rhythm because they're irregular. It's just not physiologic for these QRSs to be so irregular. What must be happening is that some upper rhythm must be affecting the QRS complexes. Something must be getting through and causing the AV node to fire irregularly. But there are no P waves. And despite the fact that you see very little electrical activity in the baseline, you have to assume that this is atrial fibrillation. That's really the only arrhythmia that could cause this irregular QRS complex to occur. And it's just that the fibrillatory waves are too small to see. Granted, it's dreadfully slow, and that tells you that your AV node is not working well at all. Despite the fact that there are extremely slow rates, you don't see any kind of reliable junctional escape emerging. So not only is there poor AV nodal conduction, but I would say that AV nodal automaticity is also disturbed. So this person's AV node is pretty well shot. But the reason it's irregular is because you have atrial fibrillation, and of course you would classify this as having a very slow ventricular response. I thought this was interesting because you really don't see atrial fibrillation conducting this slowly most of the time. Usually, if complete heart block occurs in the setting of atrial fibrillation, you get what's known as regularization of the QRS complexes because even though atrial fibrillation is going on, the ventricular rhythm is actually a junctional escape, and that's what makes it so regular. So when you have atrial fibrillation and the QRS has become regular, then you can say it's a junctional escape and complete heart block is present. Here, you don't have complete heart block. Some of these QRSs are obviously getting through, but you have very severe AV nodal dysfunction, and this is a patient who really deserves a permanent pacemaker. Well, I hope you learned something new with this strip, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is almost like a part 2 because here on the top is the same one that I used last week. The QRS is fairly narrow and it's very slow, but it's irregularly irregular. And there's also a notable lack of P waves anywhere. And we decided that this was a person who had atrial fibrillation, but they happened to have a very slow ventricular response because their AV node is really dysfunctional. So you might want to call it high-grade AV block, but it's not complete AV block because of the fact that the QRSs are irregular. And so something's getting through. This is not an escape rhythm. If it was perfectly regular, we'd call it regularization of atrial fibrillation, which during atrial fibrillation implies complete heart block, but that's not what we have here. It's just very slow. So the AV node is hanging by a thread, essentially. But now we can see that the patient indeed had their permanent pacemaker. This is the same patient. Atrial fibrillation is sort of classified 3 ways. You can have paroxysmal atrial fibrillation, which means that it starts and stops. In other words, it goes away by itself, and the patient spends at least some of the time in a normal sinus rhythm. You can have persistent atrial fibrillation, which pretty much means the patient is in atrial fibrillation all the time, and this is the kind of patient who might wind up having to be cardioverted, using an electrical jolt to restore normal sinus rhythm. But the third category is known as permanent atrial fibrillation. The only difference between permanent atrial fibrillation and persistent atrial fibrillation is in permanent atrial fibrillation, there are no plans to do a cardioversion. And so this patient is essentially in atrial fibrillation indefinitely. Whereas persistent atrial fibrillation, you would figure at some point the patient may wind up getting cardioverted. So the distinction between these two has more to do with your intended therapy or the way you're treating the patient. It's a conscious decision between the doctor and the patient. Well, let's say for argument's sake, this is a person that is not a good candidate for cardioversion for whatever reason, and so this would be considered an example of permanent atrial fibrillation. What kind of pacemaker would you use in a patient with permanent atrial fibrillation? This is really one of the few situations where the best choice would actually be a single-chamber pacemaker, because if you have atrial fibrillation, there's no use for an atrial lead. So the patient did indeed receive a permanent VVI pacemaker. You should be able to see that there are spikes down here, but in the middle of it all, you have this beat right here, which kind of disturbs the regular rhythm. And the question is this normal pacemaker function? Is there something wrong with the pacemaker? What is this FLB? We call it, right? FLB for funny looking beat. And I wanted to just review how you approach a pacemaker strip, because a lot of people really are uncomfortable with pacemakers. The best way to understand pacemakers is to think of a clock. But in the case of a pacemaker, this clock is set for the R to R interval that corresponds with the lower rate limit of the pacemaker. So let's just say, for example, this pacemaker is programmed for a lower rate limit of 60 beats per minute. And so the clock would be set for 1,000 milliseconds. So if this clock is set for 1 second or 1,000 milliseconds, and this is a timing circuit inside. So here's the pacemaker, and the pacemaker lead is in the right ventricle. With every event, whether it's paced or sensed, basically the clock starts. If the clock runs out of time, the pacemaker will send a spike down the wire to capture the heart. On the other hand, if the clock does not run out and the patient has an intrinsic beat, that intrinsic beat interrupts the clock, and what happens is the pacemaker output is inhibited, and then the clock starts running again. So anytime pacing occurs, or if an intrinsic beat occurs, the clock starts running again, and depending upon whether another intrinsic beat occurs or whether the clock runs out, determines whether it paces or it senses. So getting back to our strip, does this all make sense? Here's where calipers come in really handy. Because what you could do is you can take these calipers and find 2 spikes in a row, because 2 spikes in a row will tell you exactly what the clock is set for. That tells you what rate the pacemaker is operating at. So in this case, it looks like it's about 70 beats per minute. If you see that this paced rhythm is moving along and it's perfectly regular at 70 beats per minute, then all is well. But now what happens with this beat here? The pacemaker would have paced right at this moment, and you have no output. So it would appear that this funny looking beat inhibited the pacemaker, whether the next spike occurred on time. To do that, what you do is you put the right hand pin of the calipers on the next spike, and you measure back from that spike to where the other caliper pin lands. And sure enough, shows us that right here in the middle of the QRS complex is when the clock started. And so this funny looking beat here initiated a timing cycle, started the clock, and when the clock ran out, the pacemaker paced appropriately. Well, the only thing left to figure out is, what is this funny looking beat? Is this an intrinsic beat or is it a PVC? It is wide and it looks distinctly different from the underlying QRS complex. But someone might say, well, how do we know it's not aberrant? Given that we already know that this patient's AV node is really hanging by a thread, it's not likely that the AV node was able to pass a signal this quickly, because it's just so refractory. Look at how slow these beats are down here. So I think it would be extremely unlikely that this is a conducted beat because it's too fast. It came too soon after this paced beat. And so I would call this a premature ventricular contraction. So we have normal pacemaker function with a PVC, and remember that you don't see any P waves, so you still should make a comment that it appears that there's an underlying atrial fibrillation. And that becomes important because people with permanent atrial fibrillation need to be assessed for their stroke risk and may need to go on anticoagulation. Well, I hope that was helpful to you, and until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a special rhythm strip that I found on one of the charts in my hospital, and I thought I would share it with you. And remember, the first thing you should do is look at the forest. Look at the whole entire strip. Get a sense of what the rhythm is doing. And so when you look across at the QRS complexes, you can see they're very irregular. And as you glance across, you should be able to pick out that there is a pattern. There's a group of two, and then there's a pause, and then another group of two, and then a pause, and a group of two, and so on. So you have an arrhythmia that is regularly irregular with groups of two, and so we call this group beating. And in between each group of two, there's a bit of a pause here. And if we look at that pause and try to map out where you think the next QRS would land, it looks as if the pause is less than 2 times the previous R to R. Aha! Does that sound familiar? Okay, so the nurse who looked this over actually did us a favor. Maybe. This is what I found written on the strip, and she very conveniently drew these little arrows here to mark out the P waves. And as you can see, it was labeled winky back, second degree type 1. But you need to remember Tulow's law. Tulow's law states that you should never believe anything you read on a rhythm strip unless you wrote it yourself. Okay, so here's a close-up of these groups of two. Here's QRS number 1 and number 2, and then you have this pause, and you have QRS number 1 and number 2, and there's a pause that follows that. Let's scroll over and look at this second group a little bit more carefully. So our P waves are labeled right there and right there. And let's look at the PR interval. So let's grab a pair of calipers, and we're going to resize the calipers, and we'll find the beginning of the QRS here. And let's pick this up and see how long that PR interval is. So starting on a heavy line, it looks to be about 300 milliseconds. And now let's take a look at the second PR interval, and lo and behold, it looks longer. So this is looking pretty good. We'll stretch that out and come up with our PR interval here. It looks like, wow, almost 400 milliseconds. Let's see, about 380. So it went from 300 to 380. And then you have this pause here, and you have this magical arrow. And then it seems to repeat itself here with a shorter PR, and you have a longer PR. And then we'll see what happens after that. But see, what bothers me is this magical arrow here. Because when you look at these P waves, they look unmistakably there. Can't miss them. But I don't see any P here. No P. Well, maybe it's just an artifact. Let's see what happens later on in the strip. Okay, we'll drag it over. And lo and behold, you have our P and our P. And where's the P? Well, there's a little bump there, but it doesn't look nearly as impressive as these other P waves. Okay, let's keep on going. And here again, we have very impressive P, and then I see no P there. So what's going on here? Where is Waldo? You can't just imagine that there's a P there. It's either there or it's not. So where is it? It's right here. You'd say, wait a minute, are you sure? How could that be a P? Well, look at this T wave, how smooth it is, and this ST segment's fairly smooth. But this ST segment is really, really kind of bumpy. Let's go back. We have a recurring theme here. Smooth ST segment, bumpy ST segment. Well, if that's the P, it's certainly not on time, so it's a PAC. But there's no QRS following it. This is a blocked PAC or a non-conducted PAC. And as we go further back in this strip, we see that we have smooth ST segment, bumpy ST segment. You have to be able to pick that out. So let's zoom out a little bit, because sometimes it's easier to see subtle details from a distance. So what this amounts to is a sinus P, a sinus P, and a PAC. And of course, there's a compensatory pause after a premature atrial contraction. And then you have the next sinus P, a sinus P, and here's a PAC. And the thing keeps on going, sinus P, and PAC. Now, why did the PR get longer? Well, that's because you have such a long interval following this compensatory pause, so the AV node kind of perked up a little bit. Remember, the AV node conducts worse at faster rates, but the converse is that it conducts better at slow rates, and this long pause following the PAC represents a slow rate. So the AV node got a little bit better and caused the PR to be a little bit shorter, but then following this P wave, it's kind of back to baseline, which is a first-degree AV block. So what you have have here really is normal sinus rhythm with a first degree AV block, and every third beat is a blocked PAC. So what do we call it when every third beat's a premature beat? We call it trigeminy, but they're non-conducted. So we can call it blocked or non-conducted atrial trigeminy. And you guys need to be able to recognize this. This is not winky back. But the person who read this strip relied on pattern recognition, which is really not a good way to read ECGs. She saw a pattern that she thought she recognized as winky back and then tried to fit the strip into that diagnosis. But that's how you make mistakes. And as a result, patients can wind up with the wrong kind of therapy. This is a really important lesson for you guys. So I'm glad I was able to share it with you. Anyway, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting strip that once again demonstrates the kind of misconceptions that go on a telemetry floor. So let's start with the clinical story. This is actually a 44-year-old woman who unfortunately had a severe car accident and has been struggling with multiple problems related to the trauma, most recently sepsis and intestinal problems related to injuries, scar tissue, adhesions, and so forth. So she's been in the hospital a very long time. And this is one ECG that I grabbed from the records. And we can very quickly see that it is quite regular. It's a little bit fast, maybe 110 beats per minute, with fairly normal PR interval and a QT that's 300 milliseconds. So if we correct for that using Bazette's formula, it's 300 divided by the square root of the R to R in seconds. So we have 560 milliseconds here. Grab our calculator, plug the numbers in. It's 300 divided by the square root of 0.56, which equals 400 milliseconds. So even though it looks a little bit generous, the QTC for the rate is still within normal limits. Looking over the limb leads, we see it's most isoelectric in AVL, so the axis is perpendicular to that vector, and it gives you plus 60 degrees, which is also normal. The precordial leads look fairly normal as well. There's a good R wave progression. All the T waves are normal. There's a little non-specific ST elevation diffusely, but it's less than a millimeter, and I wouldn't even call it in a young woman. One quick notice that remember the P wave has an axis as well, and so in certain leads it's going to be fairly isoelectric. In this case, lead 3, the P waves are almost non-existent because they're isoelectric in that lead. So lead 3 is 60 degrees above the horizontal, and that gives us a fairly normal P wave axis of plus 30. You also have kind of a flat T wave in this lead, but that's normal as well. So everything looks fine so far. And now I'm going to show you a rhythm strip that I came across. So here's the rhythm strip in question. This was on a day when the patient was fairly sick, but all her labs were normal, electrolytes were fine. And when we look at this strip, something seems to have happened right here. We have two different populations of QRS complexes. There's the first 4 beats here, and then 3 on the other side, and then you have this irregularly irregular rhythm in the middle. Well, let's look at the beginning of the strip and see what's going on. We can see these first 4 beats appear to be extremely regular. Remember, this is a patient who has underlying normal sinus rhythm. And in this particular lead, the P wave is so isoelectric that you really can't see it. But when you look at the end of the strip and you look at these 3 beats, again, they're perfectly regular at the same rate as they were before. And so even though you don't see a P wave there, let's just say that under the circumstances, we're going to call this normal sinus rhythm. And so what is this run of irregular rhythm here? Well, obviously the QRS complex changed morphology, and the rate is a bit faster than that underlying rate, and it's grossly irregularly irregular. And so here's another example of when pattern recognition, because what the nurse wrote on the strip was patient had 9 beats of aberrantly conducted atrial fibrillation. I guess she was taught that if it's irregularly irregular, it must be AFib, and if the QRS looks different, then that tells you it's aberrant. Well, here's another example of Tulow's law. Really, instead of looking at pattern recognition, you have to think about the physiology of it. You have to think about what causes aberrant conduction in the first place. And when we talk about aberrancy, we're talking about abnormal interventricular conduction. An aberrant conduction, in this context, refers to a functional aberrancy. What that means is, under certain circumstances, the Purkinje fibers don't function normally. Because after all, if the patient has a bundle branch block, which is a form of aberrant conduction, well, it would be present all the time. So all the QRSs would be wide and atrial fibrillation would look the same as the underlying rhythm. But the fact is the QRSs change here. And so the assumption is that something in the Purkinje system changed the way it functions. All right, so the fancy name for this is functional aberrancy. But what causes functional aberrancy in the first place? It's all about refractoriness. Okay, this is what we talk about in the course. It has to do with the fact that after the cells in the Purkinje system fire, that there's a certain period of time when the cells are inexcitable. There's a refractory period, and it's not until the cells are nearly back to their resting membrane potentials when they are capable of firing a second time. So that if a signal comes in too early, for example here, the cells won't respond because they're refractory. And so in a sense, it's mostly about heart rate and the coupling interval. If two beats are too close together, you're going to have interventricular conduction disturbances. And if the Purkinje system is given enough time to recover from the previous beat, well, then it will conduct just fine. So if we keep that in mind when we're analyzing this strip, it might make a little bit more sense. Because if we just look at this first beat here, you can see that the interval between the normal beat and this first beat is short. So this first beat, assuming it did arise from the atrium, could have conducted aberrantly. And likewise, this next beat is also quite fast, as is this third beat. So these beats are conducting rapidly, and to call this atrial fibrillation with aberrant conduction would make sense physiologically. But as we look at these beats, we can see it's all of a sudden starting to slow down. And this is the red light right here. This is a very long interval, nearly equivalent to the normally conducted beats. But yet this QRS here is still abnormal. How does this make physiologic sense? That this beat, after such a long period of time, is still conducting aberrantly. In my course, I call it the pause that refreshes. The Purkinje system should certainly have had enough time to recover and conduct this beat normally. And yet, that's not what we see. What you need to be able to do is recognize that this does not make sense from a physiologic standpoint, but rather this is non-sustained ventricular tachycardia. It's very, very irregular, but that only means that it's probably coming from some ectopic focus that just decided to fire off a whole bunch of beats for whatever reason. But it also makes sense because the QRS looks so vastly different from the underlying. The normal QRS starts with a negative deflection, a little tiny Q wave, whereas these other QRS complexes start with an upward deflection. It supports the idea that this is a ventricular arrhythmia, not atrial, and it should have been labeled properly. So here again, understanding the way the conduction system behaves under certain circumstances makes all the difference in the world when it comes to correctly diagnosing arrhythmias that we see every day. So I hope that reinforces the idea of not relying on pattern recognition when you're reading ECGs. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip that I saw on my telemetry unit, and it's something we don't see very often, so let's take a look and try to figure out what to call this. We can see the strip starts with a P and a QRS complex, with a PR interval that's a little on the long side, probably about 240 milliseconds. The QRS duration doesn't look all that terribly long, maybe 100 milliseconds. You see 3 beats, and then suddenly what happens is the QRSs seem to disappear. We can actually see P waves marching on through, but they're not followed by ventricular activation. You might think this could be artifact, because sometimes wires can become disconnected. You can wind up with a P wave that's followed by what looks like exactly a flat line, almost like it was drawn with a ruler. And then often that flat line will be suddenly interrupted as the electrical circuit is broken and then reconnects at some point down the road, and then you have the rest of the signal. Now, this kind of make or break artifact is actually pretty common, but that does not look like what we have here. First of all, you do see some tiny bit of electrical noise, this very, very low amplitude artifact. So it makes you think that the circuit wasn't broken, that this is actually the electrical signal coming from the patient. And the other thing, it would be odd to have intermittent make and break that happens to coincide exactly with the P waves. So I have a feeling that truly there's no QRS. So you have 4 P waves that fail to conduct, and then the 5th one seems to get to the ventricle. But what is this signal right here? It almost kind of looks like a T wave, doesn't it? But you have to ask yourself, does it make sense for a T wave to suddenly appear in this location? If you imagine that somehow there was some artifact going on and that there actually was a QRS complex here following this P wave, then the QT interval really would be too long. It doesn't seem likely that it was related to this P wave. This big bump here is electrical artifact, so perhaps the patient actually fell at that point because they had no rhythm here. At any rate, this P wave appears to conduct to the QRS complex with a PR that's kind of similar to the previous PR interval, about 240 milliseconds. And then you can see the next PQRS looks very similar to the original ones. So what do you think this is? What would you classify this as? First of all, how long is the pause? It actually goes on for just about 7 seconds. You could call it ventricular asystole. But clearly there are P waves that are going on and they're failing to conduct. So what's the electrocardiographic diagnosis? Well, a lot of people would call this complete heart block because after all, you had 7 seconds of asystole and the P waves are marching on through. So it looks like you have AV dissociation. But if you said complete heart block, you'd actually be incorrect, because these first 3 beats appeared to conduct normally and the last 2 beats appeared to conduct normally. So some of the P waves are conducting to the QRS complex, and therefore complete heart block, strictly speaking, is not present. Well, if it's not 3rd degree, and it's obviously not 1st degree, it must be 2nd degree AV block. And you'd say, wow, 2nd degree, I'm thinking it doesn't look like anything I've ever seen before. But what you have here is 4 non-conducted P waves, and then the next one does conduct. And so you actually have 5-to-1 AV block, but just transiently. So what do we call it when it's 2-to-1 or 3-to-1 or 4-to-1? We call it high grade. And this, in fact, is a particular syndrome that goes by the term paroxysmal high grade AV block. Paroxysmal high grade AV block is not seen very often. But what happens is the AV conduction is suddenly lost so that you have sequential P waves that fail to conduct, but then the AV conduction system starts working again. And so if the patient is not hooked up to the monitor at this very moment, they might actually have syncope and present with syncope of unknown etiology, and you'd have no idea that they had this condition unless you monitored them long term. Do you remember how long does it take for someone to lose consciousness when cerebral blood flow is cut off, in this case because of ventricular asystole? The median time is 6 to 8 seconds. So at least half the patients who had a pause of this magnitude would suddenly lose consciousness. And there are several electrophysiologic mechanisms that might explain this. One of the more common ones is trifascicular conduction system disease, where the infrahisian tissues, the bundle branches, just give out. And because most idioventricular escape rhythms come from the Purkinje system, in this case you have a very sick His-Purkinje system and there's no escape focus. Indeed, most patients with this kind of a problem do need a permanent pacemaker to protect them against serious symptoms, such as syncope. But as Steve Jobs used to say, there's just one more thing. If we take a pair of calipers and bring it down to the R to R interval, we can see that initially the heart rate was just about 60 beats per minute. And we can see that the next P to P interval is very similar. But what happens with the first P wave that fails to conduct? Now that's interesting. Why did this P wave occur so late? What happens if we look at the next P to P interval? What we see here is that the P to P interval suddenly slows down dramatically. In fact, if we resize our calipers and measure the rate, it's down around 40 beats per minute here. And it stays slow until the end, where as you can see, it starts to pick up again. And so it appears that you have simultaneous dysfunction of the sinus node and the AV conduction system. What could possibly cause that? A transient dysfunction of both the sinus node and the AV node simultaneously. And the only thing that really explains this adequately is that the vagus nerve has a dramatic effect on both structures. And this kind of arrhythmia can be seen in a profound vasovagal reaction. Someone perhaps who's vomiting, or someone who's in extreme pain and having a severe vagal reaction.
The fact is that this can cause high-grade AV block, but if you don't realize that the sinus rate has slowed down, you might leave it out of your differential diagnosis. Someone who has a vagal reaction this severe, who has 7 seconds of asystole, might in fact fall into the category of malignant vasovagal syncope, where people will have loss of consciousness with no warning, or they'll have such a severe vasovagal reaction that they'll fall over and sustain severe injuries. And so even though it's mediated by a vasovagal reaction, this patient might still be a candidate for a permanent pacemaker. You do have to take each patient as an individual, but I just wanted you to recognize this on a strip if you ever see it again. Well, I hope that was an interesting lesson for you. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a fairly basic 12 lead. Now, it has a lot of things wrong with it, but nothing terribly tricky, so let's get to it. Remember, look at the forest first. Here's the rhythm strip down here, lead 2. And as we glance across the strip, we see that it's fairly regular, except there is a wide complex beat here that seems to come a little early. It's pretty easy to pick up that there is a P wave and a QRS complex, and the rate is just under 100 beats per minute. Well, let's turn our attention to the 12 lead first, and then we'll get back to this premature beat. What would the frontal axis be? Which lead is most isoelectric? It looks like AVR is most isoelectric. You can see a huge P wave, but the QRS is so tiny. So if it's isoelectric in AVR, and we know that AVR is 30 degrees above the horizontal, that gives us an axis of minus 60. Now, as soon as you see an axis of minus 60, the red light should go off in your head, and you should be thinking left anterior hemiblock. Now, for those of you who aren't terribly familiar with hemiblocks, they're diagnosed by a marked axis deviation. You're either at minus 60 or above for a left anterior hemiblock, or you'd be plus 120 or greater for a left posterior hemiblock. Now, the neat thing is that those two numbers are defined by the perpendicular to AVR. So whenever you see AVR become isoelectric or positive, that means that the axis is in this half of the circle, you should start looking for hemiblock. Now, in the case of a left anterior hemiblock, you see this marked left axis deviation. But what other things can cause marked left axis deviation? Well, anytime you have absence of electrical activity, for example, in an inferior MI, the axis will suddenly shift leftward because there's no electrical activity going towards the inferior wall. So when you see minus 60, first thing you should do is look at the inferior leads, in particular lead 3. And you want to see if there's an R wave there. Because if the left axis deviation was due to an old inferior MI, then you should have Q waves. In the inferior leads, you would see a P wave and then a QS pattern, no R wave. But here, clearly in lead 3, you have an R wave. And that's why if you read some of the basic textbooks, they tell you that an anterior hemiblock should have a small R and a deep S in lead 3. And that's what they mean, is that you need to see an R wave to make sure there's not an inferior MI. So we can establish that there is a left anterior hemiblock here. What else do we see? The T wave seems to end a little bit past the midpoint between the R to R intervals. So here's a QRS that lands on a heavy line, and that's pretty convenient. So when you see the T wave come back down to baseline, it looks to be about 360 milliseconds. The R to R is just about 600 milliseconds because we're just about 100 beats per minute. Now remember, Bizet's formula is that the QTC is equal to the QT interval divided by the square root of the R to R interval in seconds. So if we get out our trusty calculator, the QT is 360 divided by the square root of 0.6, and we get 464. That's right on the border for a woman, where we consider 440 to 460 to be the upper limits of normal. But in a man, that would definitely count as a prolonged QT interval. We can see these P waves, if you hadn't noticed, are very large, and they have a double bump. Some people call those bifid, and that should make you think of left atrial enlargement or left atrial abnormality. So then you come over to V1, and to check that, you actually do see a small upward deflection and a very large downward deflection as part of the P wave. So we definitely have left atrial enlargement. The QRS is a little bit wide and it has a little bit of notching, but it doesn't look like a classic bundle branch block. The only exception is that if you look here in V2, you have an RSR prime, and a lot of people think that that means you have a right bundle branch block, but you should at least see a prominent S wave in the lateral leads if you're going to call a right bundle or even an incomplete right bundle, and I don't see any prominent S wave here, so I would call this a nonspecific IVCD. We see some nonspecific T-wave flattening in 1 and AVL, where the T-waves are going in the opposite direction from the QRS complex. But given that there is an IVCD, these may just simply be secondary T-wave changes. Couple more things. The R-wave progression is a little unimpressive, and you do have transition in V5, which is a little bit late, but there's no residual S-wave in V6. So some people would call this poor R-wave progression, but a lot of people would just shrug it off, especially considering that you have this left anterior hemiblock. You frequently will get late transition and even sometimes early transition because of the disturbance of the sequence of activation of the left ventricle. All right, well, that pretty much covers it except for one thing. What is this beat right there? Now, a lot of people will look at it and say, well, it kind of looks like a PVC. And you're right, it looks like a PVC, but how do you know for sure that it's a PVC? How can you be absolutely sure that that's a PVC? It is premature, so it could have been an aberrantly conducted PAC, but what you need to do is compare this T wave with the previous T waves and all the other T waves before it and after it, and get a sense if there's a P wave, which would represent a PAC, in front of this QRS. But I cannot say for sure that there is a P in front of it. But there's another trick that you can use, and that's with a pair of calipers. And this trick is sometimes referred to as looking for a fully compensatory pause, which we can sometimes see with PVCs. Now, that's a fancy way of saying that the next P wave occurs on time. But think about what's happening inside the heart. The sinus node is firing, and it's really quite regular, and the next sinus P wave would have occurred right here, right on top of that PVC. That is, if this is a PVC. If it is, it's occurring in the ventricles. So as far as the sinus node is concerned, most of the time it doesn't even realize that that PVC is there. The sinus P wave occurs on time, and the PVC does not disturb the sinus rhythm. So the next P wave occurs on time. Now, how do we measure it? So what I did was I set these calipers to exactly 2 R to R intervals, which is also equal to 2 P to P intervals. Now, if we place one tip of the caliper on the P wave before the PVC, we see that the next P wave does occur on time. And how does that tell us that it was a PVC? Well, if there was a PAC here that resulted in this aberrantly conducted QRS complex, then that PAC, which is in the atrium, would reset the sinus node, and so the next sinus beat would actually occur earlier. So that's an important clue. If you see what's known as a fully compensatory pause, meaning that the next P wave occurs on time, then it's more likely a PVC. Whereas if it's a PAC with aberrant conduction, then most of the time the next P wave will occur somewhat earlier. Now, that rule does not always apply. There are certainly exceptions to that rule. But in this case, it does help us establish that this is a PVC. Well, I hope that was a useful discussion for you. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is yet another episode of In the Trenches. That's right, this rhythm strip was actually sent to me by one of my subscribers, and I thought it was worth going over because it's a little confusing, and some of you may be making the same mistakes, so let's get down to it. The strip actually starts with a normal sinus beat. You can see a PQRST, so that gives you an idea of what the normal QRS looks like. You can actually see the second beat looks exactly the same, but then you have this 5-beat run of a tachycardia somewhere around 160 or 170 beats per minute. And then there's a little bit of a pause, and then the rhythm continues with a QRS complex that's obviously much faster than the underlying rhythm, but the QRSs now look the same as the original beat. So the sense was that this wide complex tachycardia was somehow VTAC, but then it was immediately followed by an episode of atrial flutter. And one of the things that you have to keep in mind is that when a patient goes from a normal sinus rhythm to some sort of arrhythmia, it's best to assume that it's one arrhythmia and not two. Now, granted, it's possible that someone had a run of VTAC that was immediately followed by a run of atrial flutter, but it's more likely to be one arrhythmia responsible for all this stuff here. Of course, there are exceptions to every rule, but let's see if we can tie this all together. Now that we've kind of looked at the forest, let's examine the trees. These 5 wide QRS complexes actually look similar to the underlying QRS complex. So even though they're somewhat different, you wonder, could they be aberrant? And you have to ask yourself 2 questions. Is there a P wave in front of that first beat that you can identify? And is the first QRS premature so that we have a reasonable physiologic explanation for aberrancy? Okay, so let's look at this first QRS, and it's clearly premature. You look at the rate here, it's about 150 beats per minute, so it could be aberrant, but is there a P wave in front of it? And that's where you have to look at the previous QRS complex and very carefully examine the ST segment and the T wave and compare it with the ST segment and the T wave preceding the first beat of the tachycardia. And you might have missed it, but I see on the ST segment right here, there's a high-frequency deflection, and that's a very subtle PAC that occurred right after the QRS complex and conducted with a bit of a first-degree AV block because, after all, it's premature, so the AV node delays the signal. And that's how you can establish that, in fact, this first beat is an aberrant beat. It has a PAC in front of it with a first-degree AV block, and then it must have reached the interventricular conduction system at a point where part of the conduction system was still refractory, and that resulted in a change in the QRS morphology because now it's taking a slightly different route through the ventricle. It takes a slight detour, so this is looking like an aberrantly conducted beat. Well, the other 4 beats look exactly the same, so you have to assume that they are all aberrantly conducted. But now, can we see the atrial signals that give rise to each beat so we can figure out what the atrium is doing? And actually, these arrows that the user pointed to look like the atrial events that gave rise to each QRS complex. And since the rate here is about 170 beats per minute, this looks like a run of atrial tachycardia. But then you have to figure out what happened here and what caused this pause to occur. Because when you look past the pause, you see that there's a QRS complex that now looks like the normal QRS. And the reason it's not aberrantly conducted is because you have this pause that refreshes and the conduction system is able to fully recover from the previous beat, and now it conducts normally. And there is a P wave in front of that beat. And what I see is that this run of tachycardia is considerably slower than the aberrantly conducted run back here in the beginning. But it still looks like there's a P wave here in front of each QRS complex. But it's just that the atrial tachycardia here slowed down enough so that the QRS complexes are conducting without aberrancy. If you take a pair of calipers and bring it down to the R to R interval, that seems to map out with the P to P interval that's going on, but it's a different rate than what we had back here. And so I think what you have is this very irregular looking atrial tachycardia that started out with a rapid burst, and then there was a little bit of a pause in the action, and then it resumed back here at a slower rate, and that allowed the QRSs to conduct normally without aberrancy. I don't think it's atrial flutter, as was marked here, because if that were the case, there would be a flutter wave in between these atrial events, and I don't see one. I see a little bump at the end of the T wave that seems to be consistent here, but does not time out with the flutter waves. If you take the midpoint between these two, it does not coincide with that bump at the end of the T wave. So it looks more like atrial tachycardia with 1-to-1 conduction rather than flutter with 2-to-1 conduction. At any rate, I hope you can see how paying attention to the tiny details, like noticing this PAC in front of the first funny-looking beat, allows you to make the diagnosis of aberrantly conducted atrial tachycardia. And the fact that the atrial tachycardia slowed down at the end of this strip, that allowed the QRSs to conduct normally. Well, until next time, this is Dr. Nick with the ECG Academy. Thanks for watching.
Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a two-parter, actually. The first ECG is from 2 years ago. It's like a baseline ECG for this 95-year-old gentleman who was brought to the emergency room with complaints of weakness. So let's just start with this cardiogram. And we can see that it's fairly regular. The heart rate down here is just above 75 beats per minute, maybe 80. And there does appear to be a P wave in front of each beat here in the rhythm strip, and you can also see in V1 there's a P wave. But if I magnify this image a little bit, just to measure some intervals, okay, we'll take a pair of calipers and we'll find the PR interval first. It looks to be just a little over 200 milliseconds, maybe about 210 or 220 milliseconds. And then if we measure the QRS duration, it's kind of wide. It looks to be about 160 milliseconds in lead 2, just about 4 small boxes. Since the QRS is wide, we have to figure out what kind of interventricular conduction disturbance we have. And anyone with experience in reading 12 leads will recognize right away that this is a left bundle branch block. You have a very wide, deep S waves in V1, V2, V3, and we have a very classic notched QRS in the lateral leads with a very slow upstroke, and you can see the same slurring of the upstroke in V5 and V6. So this is a classic left bundle branch block. Now, the other interesting thing is that when we look at the P waves, it's up in lead 1. The weird thing is it's isoelectric in lead 2 and it's down in lead 3. And you also have negative P waves in AVF. So the P wave axis is abnormal. It's about minus 30 degrees. And even though the rate is physiologic, you have to consider this to be an ectopic atrial rhythm with a first degree AV block along with that left bundle branch block. Obviously, there's some conduction system disease. Okay, now let's get to the current ECG. Aha! Now we know why he's so weak. You see his heart rate is extremely slow. This is just above 30 beats per minute. The QRS is very wide. And in the rhythm strip, it's really hard to see P waves. And initially, I thought this was just marked sinus bradycardia. But if you look at every lead, you can actually see that there are P waves here. And the P waves are going at a rate of about 80 beats per minute. Here they are in V1 as well. That P wave axis is still a little funny, so his atrial rhythm hasn't really changed that much. But what's happened? He's developed complete heart block. And the QRS is still wide, but now it has what looks kind of like a right bundle branch block pattern with an RSR prime, but it's not a typical right bundle. Normally, with an RSR prime, the R prime is taller than the R. But here the R is taller than the R prime, and you also have a very small R wave in V6 with a deep S wave. And you also have a marked left axis deviation. Look, lead 1 is isoelectric, and 2, 3, and AVF are negative. So the axis here is like minus 90. And given the rate of about 30 beats per minute, this really goes for an idioventricular escape rhythm. So if you think about the physiology once again, he had a left bundle branch block, but was conducting down the right. Now the right bundle branch appears to have given up. And what you have is somewhat narrow of an escape focus that has essentially a right bundle branch block and a left anterior hemi-block pattern. So diagrammatically, if you have a right bundle and you have the left anterior and you have the left posterior, and your escape rhythm appears to have a bifascicular block pattern, well, sometimes that can be seen, and it leads you to believe that the escape rhythm is actually coming from the left posterior hemifascicle. Because what happens is, if the escape focus comes from the left posterior hemifascicle, it gets to the ventricle quickly, but then has to go backwards up the conduction system and goes down the other two bundles later. And so it appears that the right bundle and the left anterior hemibundle are later compared with the left posterior, and that kind of gives you this appearance of a bifascicular block, right bundle, left anterior, but it's actually an idioventricular rhythm arising most likely from the left posterior hemifascicle. That's sort of getting into some advanced levels of thought, but for the advanced students who are watching these Chalk Talks, it's kind of cool to think about where exactly in the heart is this escape rhythm coming from. The fact is, if you just called it an idioventricular escape, you'd be right. But this is a patient who had trifascicular conduction system disease and now has developed infranodal block. There's no junctional escape. You have an idioventricular escape, and comes into the emergency room with a heart rate of 30. So he needs a pacemaker. I'm planning to have more detailed discussion about the level of the block and the idea and how you can use His bundle studies to get a better sense of whether there's trifascicular conduction system disease or not. But that's something that you guys can look forward to. Anyway, that's it for this week. This is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a fairly basic strip that I encountered in one of the intensive care units at my hospital. In fact, it triggered a consultation, and I thought it was worthwhile going over it with you. Well, as we look at the big picture here, look at the forest, it seems that there are a couple of normal-looking beats, and then there's this very bizarre-looking wide complex rhythm that goes on for a few seconds until it stops suddenly, and then you're back to normal rhythm again. Well, when we see wide complex tachycardias like this, especially since it looks somewhat polymorphic, it's slower and faster and bigger and smaller, the first thing you should look at is the QT interval, because many people will initially look at this and diagnose torsade de pointe because of the polymorphic nature of this signal here. And look at the overall heart rate starting on this heavy line is 300, 150, 100, 75. So it's a little bit faster than that. We'll call it 80 beats per minute. The PR interval is probably about 160 milliseconds. And the QRS is clearly quite narrow, around 80 milliseconds. Now, how do we measure the QT? Well, if you want to be precise, you can take a pair of calipers, put one pin on the very beginning of the QRS complex, and resize your calipers so that the second pin is on the end of the T wave. And we can move that down to the grid, and we can measure 9 small boxes. So just about 360 milliseconds. So we know how to calculate the corrected QT interval using Bizet's formula. The corrected QT interval is the QT interval divided by the square root of the R to R interval in seconds. So the R to R is about 740 milliseconds, and we know the QT is 360. So we'll take our handy-dandy calculator and put 360 divided by the square root in seconds, so 740 milliseconds is 0.74 seconds. You take the square root of that and then divide, and we get almost 420 milliseconds, and that's clearly normal. So the QT is okay. Well, let's take a closer look at this crazy rhythm. And when I say crazy, I think after you've seen dozens and dozens of episodes of ventricular tachycardia, you look at this and you say, wow, that looks really weird. That's like so bizarre, that's so nasty looking. You have to say, oh my God, either this patient is in really big trouble or this is just artifact, right? You have to always ask yourself the first question, is it real? And looking at the first bit of this, it kind of looks like a very bizarre looking signal. It's almost too wide to be a QRS complex. It's practically 300 milliseconds wide, and it's followed by a couple of other very crazy looking. I mean, is this a QRS? Can a QRS get that wide? I mean, and this almost looks like a sine wave with no QRS to speak of. There's no T waves. It's just, looks like the outer limits over here. Take a careful look and make sure you have a good pair of calipers with you. And we'll take these up here and set them for the R to R interval. And if we look at how this first QRS starts, keep in mind it's very easy to see this P wave and a QRS that has this kind of shape. And the next P wave and the QRS has the same shape. And when we look, we see what looks like a P wave, and then the beginning of this has the same appearance. It's almost like the QRS is still there, but then you have this really wide, bizarre signal that starts with the end of the QRS complex. Now, how can that be physiologically possible? The other thing that's a clue is that this top lead begins to veer off the page and is pinned at the top of the monitor strip here. So it's almost like the voltage kind of went crazy, so high that it basically went off the page, off the scale, and then came down with this really weird looking shape. That's almost always artifact. I mean, the patient probably began to move with this beat, and this crazy triangular signal starts after a normal QRS complex. Now, QRS represents depolarization, and you can't have another QRS complex until after the ventricular muscle has recovered from its refractory period. Remember, you have this QRS and then you have the T wave, and the T wave represents electrical resetting of the ventricle. So you can't really have another QRS complex until after the T wave is nearly finished. So this is a physiologic impossibility. Now, once you've established that, you can take a look at the rest of the strip in light of that. As we take our calipers and we'll mark this QRS complex and then move over, we see that there does appear to be a little bump here. And you might say, well, I don't know, that bump isn't that impressive. But let's move over. We can see that there's actually a little notch right here. And if we move the calipers over from that notch, we see yet another notch right here, because here's another one here. Now, those notches are pretty subtle, but I'm distracting you from key to this whole strip. Look at these signals that are downgoing, and look at how those crazy downgoing signals map out to the exact same interval as the QRS complexes. So what you're actually seeing is here and here and here and here. You can see the QRS marching on through this very noisy artifactual signal. And without the calipers, if you glance across this second strip here, you can see, look at that. There's a funky notch right here, and then this signal goes down deep, and then this one comes down deep. And sure enough, at the very end, there's a QRS complex that looks strangely similar to these initial QRSs. And it looks just like these down here. But what I think is interesting is that this QRS occurs a little bit early and is followed by a little bit of a compensatory pause. So I think coincidentally the patient had a PAC right here that had nothing to do with any of this artifactual junk. But the PAC just caused this interval to be a little bit shorter, and then it was followed by a bit of a pause until the sinus rhythm kind of picked up again. But I hope I've given you a little better appreciation of what you have to do to look at a strip and decide without a doubt that this is artifact and that you should just toss it out. Don't even put it on the chart. If you see artifact like this, just throw it in the trash can. And just make sure you always look at strips like this with a critical eye, and don't be fooled by this because it happens quite often. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a pacemaker problem. And we don't talk about pacemakers too often because that's a pretty advanced topic, but this patient was in the intensive care unit, and I picked up this interesting strip, and I thought I'd share it with you. So these are actually continuous strips, and each strip has 2 leads that we're monitoring. And as we look at the first few beats, we can actually see a very prominent pacemaker spike in front of each QRS complex. So the easy answer is there's a paced rhythm here. But what kind of pacemaker do you think it is? Is it just a single ventricular pacemaker, so-called VVI, or is it a dual chamber pacemaker, otherwise known as DDD? Now, just as a review of this alphabet soup, this is a standard code that we use to describe how pacemakers behave. The first letter stands for the chambers that are paced by the device. So V would be for ventricle and D means dual. In other words, it can pace both the atrium and the ventricle. The second letter is the chambers that the device is capable of sensing. So in a VVI pacemaker, the device is capable of pacing and sensing in the ventricles only, whereas in a dual chamber pacemaker, you can pace and sense in both chambers. The last letter represents the device's behavior with a sensed event. So I means inhibited. In that case, in a single chamber ventricular pacemaker, if an intrinsic beat is sensed, then the ventricular output is inhibited. And it's so-called demand mode for a pacemaker. But a dual chamber pacemaker is capable of being inhibited by an event in either chamber, but it's also capable of triggered behavior. Now, what do I mean by triggered? Well, that means an event in one chamber will trigger another event in the other chamber. And specifically what happens is if a dual chamber pacemaker sees an underlying normal sinus rhythm, but the patient has AV block in the sense of a very long first degree, or in some cases second or third degree AV block, What the device will do is it will sense the atrial events and it will pace in the ventricle in sync with the atrial events. And that's just what's happening here. What you need to notice is that there's actually a P wave in front of each ventricular spike. And so this tells us that this is a dual chamber pacemaker that's pacing the ventricle after every single sinus P wave. And we can see the sinus rate is a little over 100, maybe 110 beats per minute. And the interval between the sensed P wave and the ventricular spike is pretty physiologic. It's pretty normal. Okay, so this is a dual chamber pacemaker that's exhibiting a behavior known as atrial synchronous ventricular pacing. Okay, but what happens here though? That's the problem. Because if we examine these P waves, they seem to be quite regular, and this P wave occurs on time. We can tell that because of the TP interval, the space between the previous T wave and the onset of the P seems to be pretty constant in most of these beats. And that interval right here is about the same. So this P wave is on time, but it's not followed by a ventricular pacing spike. In fact, what we see here is a complete change in the QRS morphology and the development of a very long first-degree AV block. The PR interval here is about 280 milliseconds. So what happened? Well, you have to remember how pacemakers are constructed and how they function. In a dual chamber pacemaker, there are two wires, one that goes to the right atrium and the other goes to the right ventricle. So when there's an intrinsic atrial event, it's sensed by the pacemaker. The pacemaker waits a certain period of time, known as the AV delay, and then it paces the ventricle in order to maintain AV synchrony. So you'll see the sinus P waves followed by a ventricular pacing spike and a wide-paced QRS complex. And this occurs over and over again. So why would you see a P wave without a pacing spike following it? Where is the spike? Where is Waldo? Well, it's possible that maybe there's a broken ventricular wire in here and that the ventricular output just can't get through that point and you don't see any pacing spike. That's one of the possibilities. But the other possibility, and the more likely one, is that the signal arising from the atrial lead is so small that the pacemaker has a hard time sensing it. And if you have atrial undersensing, then as far as the pacemaker is concerned, there is no P. It's kind of like the Matrix. There is no spoon. So going back to that strip, when you see a P wave that should have been followed by a pacing spike, and there's no spike, then the most likely cause is a loss of atrial sensing. And in fact, the rest of this top strip shows that sinus tachycardia at about 110 beats per minute continues, and each P wave is followed by a conducted QRS complex. So these are not paced, these are conducted, albeit with a bundle branch block because you do have this RSR prime pattern, as well as a long QRS duration. And then when we come down here to the second strip, we see that those sinus P waves are still there, and you're still conducting to the ventricle with a very long first-degree AV block until we get to this last beat that's conducted, and then suddenly the pacing spikes come back again. It's almost like the pacemaker suddenly realized that there are actually P waves, and it said, oh, there's a P wave, I guess I better pace in the ventricle. And so now those P waves are being sensed appropriately, and they're each followed by a ventricular pacing spike. Sometimes we say that these P waves are being tracked by the pacemaker. So granted, one of the possibilities is that there's an intermittent break in the ventricular lead and you have loss of ventricular output. And that's one possibility, but the leads are usually pretty reliable in the long term. So it's rare to see one fail, and it's especially rare to see one fail intermittently like this. It's possible that you have an intermittent fracture of the ventricular lead, but it's much more common to have intermittent atrial undersensing. So when you see something like this, you should recognize it as evidence of pacemaker malfunction, and you should let the cardiologist know that the pacemaker needs to be evaluated. Well, I hope that was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is another episode of In the Trenches.
That's right. Actually, this ECG comes from one of my subscribers, and it looks a little bit distorted, but still, it's a usable tracing. And he was arguing with the cardiologist because the cardiologist felt that the patient had frequent PACs. So let's take a look and see what we actually find. First of all, as we glance across at the forest, we can see that it certainly looks irregular. You've got shorter intervals and you've got a bunch of longer intervals and then short. And when we look carefully at the QRS complexes, most of them are fairly narrow, but every now and then, like this one here, looks a little bit wide. But as we look at the trees and start figuring out what's going on with the rhythm, paying attention to the space in front of each QRS complex, there does appear to be a P wave in front of each QRS, with a fairly normal PR interval, maybe 160 milliseconds or so. But certainly these premature beats, these short-coupled beats, seem to have a P wave in front of them. So you can see why the cardiologist thought the patient was having PACs, because you'd see one beat here, and this could be a PAC because it is early and it does have a P wave in front of it. And in fact, you'd look at the next QRS here, it's got a normal P wave in front of it, and this FLB, this funny looking beat, has a P wave in front of it as well. And the PR interval looks similar, but the QRS looks a little bizarre, so this very well could be labeled a PAC with aberrancy. It's basically a rate-related IVCD. But perhaps the cardiologist failed to notice that following these premature beats, there's a very obvious P wave here. And even following the normal beats, there appears to be P waves that fail to conduct to the ventricles. And it's starting to look like the P waves are actually marching through, regardless of where the QRSs are landing. Let's take a pair of calipers and see if that really maps out. So we'll bring our calipers up to a pair of P waves here, and let's grab a quick rate. You can see the rate here is actually about 130 beats per minute. Using these calipers, you can move them across and see that every single P wave appears to be at the same rate. These P's are regular, and they do not look like premature atrial contractions. So the idea of it being a PAC doesn't hold water. Well, if that's the case, then you have some P waves that are conducting, and some P waves are clearly blocking. And this is conducting and blocking. Conduct, block, conduct, block. So what does that tell you? That you actually have second-degree AV block. Now, we know second-degree AV block comes in 3 different flavors. You have type 1, where the PR interval gets longer and longer prior to the dropped beat. You have type 2, where the PR remains fixed. And then you have high-grade or advanced AV block, which is in a separate category and includes 2-to-1 block and 3-to-1 block and so forth. So remember that 2-to-1 block is not the same as type 2. It's in a separate category. That's a common misconception. Anyway, let's try to figure out which of these we're dealing with. And to do that, we have to get a little more up close and personal with this cardiogram. So let me enlarge it a bit. So let's take a look at the PR interval of the beat following the pause. And we'll resize these calipers and measure the PR interval. And we can pick it up and measure that about 150 milliseconds. But now if we place the calipers on top of the PR interval of the second beat, it looks very similar. It certainly doesn't seem longer. Now let's kind of go down the strip a little bit and see what else we notice. If you haven't already realized, you have 2-to-1 block. This one conducts, this one blocks, this one conducts, this one blocks. And so every other P wave fails to conduct, and that's really consistent with 2-to-1, or advanced or high grade second-degree AV block. So you can't tell if it's type 1 or type 2 in this section right here. But let's measure the PR of this pair of beats. Okay, again, you have a PR of about 150 milliseconds. And then this next PR, again, appears to be similar. So it does not look like the PR is getting longer. If you're not sure about the PR measurements, there's one more way that you can confirm that this is type 2 second-degree AV block. The length of the R to R interval during the pause should be exactly 2 times the previous R to R interval. You see, in type 1 second-degree AV block, the PR interval following the pause is shorter than the PR interval before the pause. And so that moves this QRS complex
to the left and shortens the R-to-R interval of the pause itself to the point where you can measure this R-to-R interval being shorter than 2 times the previous R-to-R. I mean, that's sort of part of the whole Winkie-back periodicity thing. But in type 2 second-degree AV block, if the P-to-P interval is regular and the PR interval doesn't change, then the pause should be exactly 2 times the previous R-to-R. So let's see. If we resize the calipers to the R-to-R interval and then move them over, you can make a little mark here, and then move them over again, and look at that. And that just proves that this is type 2 second-degree AV block because the R-to-R is exactly 2 times the previous R-to-R, and that just confirms the fact that the PR intervals are not changing. And that's really helpful if you have a hard time measuring the PR interval of the second beat. So in fact, it looks like we have type 2 second-degree AV block with occasional beats that do conduct aberrantly, and clearly there are periods where you have 2-to-1 or high-grade AV block as well. And that can be very worrisome. It might indicate that the patient has severe trifascicular conduction system disease, especially when you have a rate-related aberrancy at a rate that's not that fast. Well, I hope this was a useful discussion, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead, but it's fairly basic, and I just wanted to go over the approach that you should take when you're examining a 12 lead ECG. So this is a slightly different format. You have the 12 leads in the first 3 strips up top, and then down below you have 3 rhythm strips running continuously, V1, lead 2, and V5. And remember, look at the forest first, and if you just look at the first rhythm strip V1, we can see that the QRS complexes look to be fairly regular as you scan across, and the rate's about 68 or 70 beats per minute or so. And if we look in front of each QRS complex, there does indeed appear to be an atrial signal in front of each QRS. The PR interval looks quite long. It's probably about 280 milliseconds. And so it's looking like there's at least a first-degree AV block, but none of the P waves fail to conduct. Now let's take a look at the limb leads and see what the axis looks like. The most isoelectric lead looks to be lead 3, and so lead 3 goes down into the patient's right, and therefore the axis would be perpendicular to that, and that would be plus 30. So that's a normal axis. If we look at the precordial leads, we can see a normal-looking V1. V2 has got a little bit of an R wave, and then the R wave grows normally. V3 is the transition point, and 4, 5, 6 look okay. All the ST segments appear to be isoelectric. The T waves are all going in the right direction, and pretty much everything looks okay, except for one thing. That if you look at lead 2, the P waves appear to be inverted, and that's also true in AVF. So the P wave axis is kind of bizarre. In fact, here it is, it's up in AVR, so we know that that's a crazy P wave axis. It's heading away from the feet towards the right side, and so the cardiologist that read this ECG read it as an ectopic atrial rhythm with a first-degree AV block, and otherwise the ECG looked fairly normal. So he clicked on the computer and looked at the next one. But when I do conferences with the residents, I always teach them to think about their answer. What else could it be? And that's where you have to start really looking carefully at the trees. So if we take a much closer look at V1, the only way to pick up subtle abnormalities is to take a snapshot of that beat in your head and then compare it with the next one. And so you have P and you have QRS and you have T. And now here's where we play that game, Where's Waldo? Because when you look at the next one, you have P, QRS, and T, and most people won't even realize that these 3 beats look completely different. Okay, this QRS has a little tiny R and a very deep S wave, but this QRS has a little tiny R, a deep S, and then a little tiny R prime. And then you're back to a small R, deep S, but no R prime. Does everybody see that R prime right here? I'm going to draw a big dot right over it. That R prime is not in either of the other QRS complexes. The other thing to notice is that this T wave appears to be biphasic, This T wave goes down entirely, and this T wave appears to be only up without a negative deflection. So, what could be causing all these little minor variations in the QRS and the T wave? Have you figured it out yet? Well, these little minor variations are not part of the QRS and they're not part of the T wave because those should be consistent from beat to beat. No, in fact, if you haven't noticed that at the tail end of this T wave, there's an upright bump, and then you have that R prime signal, and then you have what you thought was the P wave, and you can admit to yourself that there's actually an atrial flutter going on. That sometimes the flutter wave lands right in the middle of the QRS complex, but sometimes it comes just a split second later and it shows itself as this upward signal at the tail end of the QRS. We call it an R prime, but it's really not. It's really not part of the QRS. It's actually part of the flutter wave. Well, if you want to figure out what the atrial rate is, look at the ratio. You basically have 3 flutter waves for every QRS complex. So you have 3-to-1 atrial flutter, and the ventricular rate's about 70, so the atrial rate is about 210 beats per minute. It's a relatively slow flutter circuit, which is why it doesn't pop out at you with big, giant, juicy, sawtooth flutter waves. This is known as an atypical flutter, because here in lead 2, you have these negative flutter waves, but then you have a flat segment in between the flutter waves. So there's a relatively isoelectric segment in between flutter waves, and the flutter waves are quite small, and that's consistent with atypical flutter, which may be focal and not necessarily related to reentry. So this was a pretty sneaky one, wasn't it? I would say that most cardiologists would probably get this wrong unless they were really tuned into arrhythmias and took their time to examine this ECG carefully. Well, I hope you learned something from this discussion. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk came from one of the telemetry units. It's a kind of strip that I see on the chart all the time, but half the time it gets mislabeled, so I thought I would go over this. It's pretty basic, though. Remember to always look at the forest first, look at the entire strip and get a sense of what the rhythm could be doing. And we can see the QRS complexes right away. They seem to be fairly regular, and if you try to get a heart rate, it's convenient sometimes to find a QRS that lands on a heavy line like this one right here. And in this case, I'll measure back and see that they're a little bit more than 2 large boxes. We like to count off 300, 150, which have a little bit more than 400 milliseconds separating the 2 QRS complexes. So the rate's going to be a little less than 150, maybe 145 or 140. But then there appears to be a little bit of a pause here before the rhythm picks up again and becomes regular at around 145 or 150 beats per minute. You can see these QRSs are exactly 2 large boxes apart from each other, which would be about 150 beats per minute. So now that we have a sense that it's mostly regular, except for this one little pause, let's start looking for P waves. The best place to look is right in front of the QRS complex, and there does appear to be a large bump that's consistently in front of each QRS complex. Both in the front part of this strip as well as in the tail end of this strip is a very consistent, sharp signal in front of each QRS complex. And a lot of people would be tempted to think that these, in fact, are P waves and label this as sinus tachycardia. But with a rate of 140 or 150 beats per minute, sinus tachycardia would be unlikely unless the patient was septic or febrile and very young, because most patients really can't reach that kind of a heart rate under normal circumstances when they're just lying in bed on telemetry. So let's take a closer look at these atrial signals. When you have a regular tachycardia like this, sometimes the answer lies in the pause, because when the QRSs are so close together, it's sometimes hard to tell what the atrium is doing. But now you have 2 QRSs that are further apart, and so what we see is not a straight line. We see a very complex signal that appears to represent the atrial activity. It's really a crazy looking squiggle here, and some people would be tempted to think that this might be atrial fibrillation. But that doesn't make sense either, because the the QRS complexes are really much too regular for this to be atrial fibrillation, since atrial fibrillation is usually irregularly irregular. Now, but if you use your imagination just a little bit, you can start to see that there's actually a complex sawtooth pattern that's going on here. And if you time these upgoing bumps here, here, and here, you can see the next one deforms this T wave, and the next one is here. And we have a regular atrial signal that's going about twice the rate of the QRS complexes, which means that the atrial rate is 300 beats per minute, and we do have this sort of sawtoothy appearance in this one little part of the strip. And so really, it's not atrial fibrillation, it's atrial flutter. It's mostly 2-to-1, so these sharp deflections in front of each QRS are just one of the flutter waves. The second one is actually located at the tail end of the QRS complex. And you can tell it's there because if you compare this QRS complex, it has kind of an R, a deep S, and then kind of a little bit of an R prime. But that looks quite a bit different from this QRS complex. That R prime is missing, and it's really the fact that the second flutter wave is kind of moving around in the QRS, and sometimes you see it. But here, the AV node was not able to keep up with that 2-to-1 conduction, and you had one cycle of 3-to-1 flutter, which allowed us to see actually what the atrium is doing. So this was a pretty basic strip. I think most people would get this right. Just don't make the mistake of looking at this pattern and calling it sinus tachycardia. When you see heart rates in the range of 150 beats per minute, one of the most common causes for this is 2-to-1 flutter. Always try to look for those flutter waves, because if you don't look for them, they might not pop out at you. Well, until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a pretty basic 12 lead, and I just wanted to go over how you approach interpreting these just for practice. So we always start at the rhythm strip just to get a general sense of what the rhythm is doing. And if you kind of just look at the whole entire rhythm strip down here, it looks really quite regular. There appear to be normal beats with a P and a QRS complex, and when you concentrate on the individual beats, they all pretty much look the same. We can calculate a rate, and it's easiest if you look for a QRS that lands on a heavy line, and then you could use the count-off trick. It would be 300, 150, 100, 75, 60, 50. So it's a little slow, faster than 50 beats per minute, but there does seem to be a very slight amount of irregularity, because even if you look at this interval, it looks fairly long, but this one behind it looks a little bit shorter. We'll count off this way in the other direction. Here it looks more like about 56 or 57 beats per minute. So you have a slight variation, but it doesn't really change more than about 5 beats per minute. Well, let's make sure that these are sinus beats. If we come up to the limb leads and take a look at lead 1, it's upright, and lead AVF, it's upright. So that tells us that the P wave is going down and to the patient's left. It's in this quadrant somewhere. So it would appear to be a sinus rhythm, but it's less than 60 beats per minute, so we'll call it sinus bradycardia with a normal degree of sinus arrhythmia. Well, let's take a quick look at the limb leads and see if our intervals appear to be all right. Okay, we can get a sense of where the P wave starts. It looks like it starts pretty much on this heavy line, and the QRS starts just to the left of the following heavy line. It's maybe about 10 milliseconds short of 200. So we can call this 190 milliseconds, which is still normal. And the QRS ends on the second dot, so that gives us about 90 or 100 milliseconds for the QRS duration. And then we'll take a look at the QT interval. It comes back to the baseline right about here, so we'll round it off and call it 480 milliseconds. If we look midway between the R to R intervals, we see that the QT does not extend past that point, and if we use Bazette's formula, and that's equal to the measured QT over the square root of the R to R interval in seconds. So what's the R to R interval? Well, this would be 1 second, so it's about 1.1. So if we grab our calculator and put 480 divided by the square root of 1.1, we get 457 milliseconds, which is at the upper limits of normal, but it looks to me like this QT interval is okay. Let's see what our axis is. If we find the most isoelectric lead, it looks like it's probably lead 2. We know that lead 2 goes down into the patient's left at 60 degrees above the horizontal, and 3 and AVF are negative, so it has to be going away from the feet, and the perpendicular that goes away from the feet is going to be minus 30. So I think we can call left axis deviation. Is there anything else that stands out on the limb leads here? If you look anatomically, there's a little bit of ST elevation that's in lead 3, and there's a little bit of ST depression in 1 and AVL, and you wonder, where are those ST changes coming from? Well, if you haven't noticed by now, the voltage in lead AVL is really pretty enormous. You have an R wave that's nearly 20 millimeters high. That would indicate left ventricular hypertrophy. So then think in your mind, what are the other criteria for LVH? If you have a really tall R wave in 1 and a really deep S wave in 3, it adds up to more than 25 millimeters. That's a pretty reliable criterion for LVH. 5, 10, 15, and then obviously we have nearly 20 here. So we definitely have more than 25 millimeters. Well, LVH does cause deviation of the ST segments in the opposite direction from the QRS complex. Well, the old-fashioned term for this was a strain pattern. So we would call this LVH with strain. And it's pretty consistent that if the QRS is down, the ST is up a little bit, and it has this kind of a slopey appearance. It slopes up when the QRS is down, and it slopes down when the QRS is up. And we also see that in the precordial leads. Here in V1, we see a little tiny bit of ST elevation that slopes up, V2 as well, and V3. But then when you come down to V6, we can see that, well, in this case, the ST is kind of isoelectric, but the T wave is inverted. So another term for this is LVH with repolarization abnormalities. Now, it's interesting that you see the R wave progression is kind of lagging. So even though we would consider this poor R wave progression, it's very commonly seen in LVH. And a lot of times the computer would read this as sort of cannot rule out an old anterior MI. I think most cardiologists would not read that. We don't exactly have LVH criteria in the precordial leads. We only get about 30 or 32 millimeters out of that. And the other thing that's very commonly seen in LVH is the presence of left atrial abnormality. You expect to see a biphasic P wave, but the second negative phase of the P wave should be at least 1 box deep and 1 box wide. It's not terribly impressive, but some people would read this as borderline for left atrial abnormality. So to summarize, we have sinus bradycardia with a normal degree of sinus arrhythmia, left axis deviation, and borderline left atrial abnormality, together with voltage criteria for LVH and repolarization abnormalities, or the so-called strain pattern from the LVH. Well, I hope this was helpful. It was pretty basic, but I wanted to just show you how a cardiologist approaches a 12 lead in an organized fashion. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting arrhythmia, and you can see it every now and then, but most people don't recognize it for what it is. So let's get to it. It looks fairly normal on first glance, but if we come down to the rhythm strip, you see that there is a slight irregularity with some shorter RRs and then longer RRs. And then, let's see, here's a short one and a long one, and you get the sense that there's actually a pattern with alternating short and long intervals. The other way to look at this is that there's group beating. Is a group of 2 and a group of 2 and so forth. So when you think about group beating, the first thing that comes to mind is some sort of AV block. So let's take a careful look at the PR intervals and see what's happening. So it looks like there is a P wave in front of each of these QRS complexes, and all the P waves appear to look the same. And if we look at the PR interval, it looks fairly normal. It's maybe 160 or 170 milliseconds, and there does not appear to be any change in the PR interval. So what you have is group beating, but a fixed PR interval, and the P waves don't seem to change. One other way of looking at this long, short pattern is to call it a bigeminal rhythm, because you have one impulse that seems to follow a longer R to R, and then this one is somewhat premature. And then you have a normal beat and a premature. So there's lots of different ways to look at this type of alternating long and short. And you have to think about the different kinds of arrhythmias that can result in this sort of pattern. Well, one of the things that you consider, think about maybe this premature beat is a premature atrial contraction. But if that were the case, you would expect that P wave to look at least a little bit different than the so-called normal sinus P waves. So the fact that there's no change in the P wave and the fact that this P wave is not terribly premature means that to call them PACs, and of course in this case, since it's every other beat seems to be premature, someone might call this atrial bigeminy. But I don't think that's the best answer because there's no change in the P wave morphology. One of the things that I've showed you in plenty of prior chalk talks is that a bigeminal rhythm like this, you have to figure out what's the reason for this pause in the rhythm. And at times what you'll find is somewhere buried in the T wave is a blocked PAC. And so you have to do your best to look at this T wave and compare it with the previous T wave and see if you can appreciate a difference. There's that Where's Waldo approach to looking for the blocked PAC that resulted in the pause. But if you look very carefully at these two T waves, they appear to be identical. And of course, you can look at some of the other leads, like here's lead 1, and you could look at V1, and there really is no difference from one T wave to the next, and no evidence of any blocked PACs. You might look for second degree AV block, but again, what you'd expect to see is a third P wave that lands on time and fails to conduct to the ventricles. But these P waves are only slightly off, and there's clearly no third P wave here. So we are left with a regularly irregular rhythm that just looks like sinus P waves. Of course, they're upright in 1 and AVF. So there's sinus P waves that just seem to be irregular, but in this pattern of long, short, long, short. And this is an example of sinus arrhythmia. That's right, there are no P waves that block, so it's not AV block. It is due to an irregularity in the generation of the sinus nodal impulses. In the advanced course, I talk about SA exit block. I touched on this in the basic course and talked about how sometimes the sinus node may fire, but the signal does not get out to the atrium. And that can result in sudden pauses where you may have a sinus rhythm that's fairly regular, and then there's a pause with no visible P wave, but the next sinus P occurs on time. And if you measure these P to P intervals, you would have expected one right here, but the next one occurs on time. And this is a manifestation of problems with the sinus nodal signal getting out into the atrial myocardium. Milder problems of SA exit block can result in this kind of marked sinus arrhythmia. The rest of the ECG is pretty boring. Your axis is isoelectric to lead 3, and so that gives us plus 30 degrees. There are no pathological Q waves in the limb leads, and the STT segments are all fine. The R wave progression in the precordium appears normal, and there aren't any abnormalities there. So this ECG doesn't look that bad, but I wanted you to be able to recognize this as sinus arrhythmia, most likely as a manifestation of a mild degree of SA exit block. Well, that's it for this week, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is fairly basic, but not really. It's kind of tricky, and that's why I decided to put this up as a Chalk Talk. This is a rhythm strip that came from an ECG, and I thought it was really interesting. Now, I always tell people to look at the forest first, look at the whole entire strip to get a sense of whether there's some kind of irregularity or whether things are regular or not. And it kind of strikes me that as you look across at the QRS complexes, there's a slight irregularity, but not much. It's a little bit faster in here, and there are a couple of little pauses here. But once you focus on the space in between the QRS complexes, you start to see P waves here that are kind of all over the place. Here's one here, and here's one here, and there's one here in front of this beat. And what you have to do now is figure out what the relationship is between the P's and the QRS complexes. Well, first, grab a pair of calipers, and you need to figure out if the atrial rhythm is regular or whether you're just seeing a bunch of PACs all over the place. So I put it on the first pair of P waves, and we could figure out the rate over here. We can count off 300, 150, 100, 75, so it's about 80 or 82 beats per minute. Well, now let's bring it down to the next P wave, and we can see, look at that. There's a P wave here on the ST segment that you may not have even noticed. But if we bring the calipers over, we see that sure enough, that is on time because the next one is at the same interval. And as we move the calipers over, we see indeed that the atrial rhythm is regular. It's somewhere around 82 beats per minute or so. But the QRS complexes are clearly slower. Significantly slower. None of these QRSs appear to be at the same rate. So since the P waves are all over the place and the QRSs are a lot slower, a lot of people initially would wonder if complete heart block is present. Remember, AV block is divided into first degree where all of the P waves conduct. It's just that the PR interval is a little longer since it's taking longer to get through the AV node. Second degree AV block where some of the P waves conduct, but some fail to conduct, some are blocked. And then third degree or complete heart block where none of the P waves conduct. Well, if none of the P waves conduct because complete heart block is present, then where do the QRS complexes come from? Well, in that case, the QRSs come from some kind of escape rhythm. It's often a junctional escape or an idioventricular escape. Now, in the case of AV block, escape rhythms arise from someplace below the AV node. Now, since the AV node is blocked, none of the impulses are getting down, and so nothing interferes with the escape rhythm. That's why escape rhythms tend to be very, very regular. That's the key. In third degree AV block, the QRSs have to be regular. And obviously they're not here. So what that means is some of these P waves are getting through the AV node and conducting to the ventricles, and so they're influencing the ventricular rhythm. And that tells you right off the bat that you actually have second degree AV block. Okay, so remember, second degree AV block is divided into type 1, type 2, and high grade, which includes 2 to 1 and 3 to 1 and so forth. So let's figure out which it is. The best place to start is following a pause. Like, for example, here, the R2R interval is longest, and sure enough, we see a nice P wave right here, very clearly, and the PR there is a little bit long, maybe it's 280 milliseconds, but what happens with the next P wave? We now see the QRS following that is associated with a slight prolongation in the PR, and it's starting to look like type 1 AV block or Winky back, isn't it? When we look carefully, this P wave appears to conduct with a very long PR interval, and then the next P wave, which is here, appears to be the one that fails to conduct because following it, the PR gets shorter again, and then the whole thing seems to repeat over and over again. Sure enough, on the left-hand side, we have a very long PR, we have a super long PR, and then this P wave that lands on the ST segment is the one that blocks, and then the PR shortens again. So this is really consistent with type 1 second degree AV block. What's unusual about it is that some of these P waves conduct with such a long PR interval that the pause that occurs because of the blocked beat is not that long. You sort of expect to see a situation where the PR is short and then it gets longer and then you have a block, but the pause is really much more impressive than this pause. And this pause is not that long because this QRS complex, because it's associated with such a long PR interval, was moved over to the right, sort of shortening the interval between that beat and the following one. But it does follow the rule that the pause is less than 2 times the previous R to R interval. That's a typical pattern of Winky back. If you take the previous R to R interval, it's quite obvious that this pause is less than 2 times the previous R to R interval. In fact, it's only just slightly longer than the previous R to R. So that's why this strip is sort of deceptive, because it almost looks regular because the pauses are just not that impressive. But when you take it apart beat by beat and keep the physiology in mind, it becomes much easier to make the diagnosis. Well, I hope that was helpful to you all. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip from the telemetry unit that I work on, so let's get to it. So if you look at the whole forest, get a sense of what the rhythm is doing, you see sort of a flurry of activity here and here, and you get the sense that there's this very, very irregular rhythm that's going on. And the QRS complexes are fairly narrow. They're only about 80 milliseconds from here to here. And so a lot of people would be tempted to immediately look at this and call it possibly atrial fibrillation. But when you start to look at the trees, you can see that there are two different QRS complexes. There's the one that you see mostly, but then you have this very narrow, normal-looking QRS complex, and it has a P wave in front of it. Well, it's very difficult to have both atrial fibrillation and a sinus rhythm at the same time. So what's going on? Could we have paroxysmal atrial fibrillation or, well, let's start from the beginning. You have one of these normal sinus beats here, and then you have a fairly long interval, and then you have one of these FLBs, funny looking beats. And if you notice that there's no P wave in front of it, what could this beat be? Well, if the QRS complex looks distinctly different from the underlying beat, it's either a PVC, a premature ventricular contraction, or there's some sort of aberrant interventricular conduction disturbance. The thing is, if it was aberrant, you would expect it to be premature because aberrancy occurs because of a beat that encounters refractoriness in the bundle branch system. So it should be premature, but this is not. And so it's hard to explain aberrant conduction, so it seems more likely that this is a PVC. All right, so here's this next sinus beat, and now you have 4 beats in a row that are of this different QRS morphology. There's no P in front of the first beat, but here's what's really important to notice, is that there seem to be retrograde P waves behind each of these beats. These retrograde P waves are absent on this beat, probably because this beat came so late. So just remember, if you have a PVC that arises from the ventricle someplace, that about 1/3 of patients have intact retrograde conduction up the AV node, and you can wind up seeing these retrograde P waves after a PVC. And in this case, it looks like it's consistently 1-to-1 retrograde conduction up the AV node to give you these retrograde P waves. Well, that kind of goes along with this being a run of non-sustained VT, ventricular tachycardia, because the atrium is not driving the rhythm. You don't have a P in front of the first beat. The ventricle is driving the rhythm, and you have P waves that are following the ventricular events. Now, to really clinch it, take a look at this beat right here. This beat is a very interesting beat because, look, it has a P wave in front of it, but the QRS does not look like the normally conducted beats over here, but it doesn't look exactly the same as these other beats. It's kind of in between. Not only that, but even though there's a P wave in front of it, the PR is shorter than the underlying beats. So you have a P wave, but a short PR. So that tells you that this is a PVC because this P wave couldn't have conducted down the AV node in that shorter period of time, but the QRS got deformed slightly. And so this P wave did penetrate part of the conduction system. So imagine you have a normal sinus beat that starts to go down the AV node a little bit, and at the same time you have a PVC that occurs, and the two sort of meet halfway, where it's mostly PVC, but a little bit of the conduction system was captured by this conducted P wave. So what is this? What do we call it? It's a fusion beat. And fusion beats imply that you have contributions from both an atrial beat and a ventricular beat, and essentially that clinches the diagnosis that these are PVCs. Well, here's the next PVC, and notice that there's a retrograde P after that. And then down here, you've got this run of very, very irregular beating, but essentially they're all ventricular beats. They all have retrograde Ps behind them. It's just extremely irregular. And then look, there's even a very long pause. And after a long pause, you have another PVC, but this time we don't see the retrograde P. In fact, this little bump here very well might be the sinus P wave kind of trying to peek out from behind the QRS. But after all this stuff, you have two sinus beats, which confirm that this is indeed a sinus rhythm, but this very, very irregular run of non-sustained ventricular tachycardia. If I show you what was written on this strip, you'll be surprised to see, or maybe you won't, that the telemetry staff interpreted this as 2 seconds and 6 seconds of aberrantly conducted atrial fibrillation. And here you have more notations of 6 seconds of aberrantly conducted AFib. And so I remind you of Tulo's law, and that is, don't ever believe anything you read on a rhythm strip unless you wrote it yourself. Because now that we've proven that this is non-sustained VT, I want to make sure you understand that just because it's irregularly irregular does not make it atrial fibrillation. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead that I came across while I was reading cardiograms for the hospital. It has a couple of interesting findings, and I wanted to share it with you. So when we look at the big picture, initially you get a sense that there's some irregularity going on. It's a lot slower in the beginning, and then it kind of speeds up a little bit. But even from beat to beat, there's an irregularity with no specific pattern to it. And when we start to pay attention to the QRS complexes and looking for P waves in front of the QRS, we really don't see any discrete P waves anywhere in the rhythm strip. And even if we look up in V1, which is a great place to look for P waves, we don't get the sense that there's definitely a sharp deflection that would make us think of a P wave. Over here on the left side, where it's very, very slow, there's no visible P waves, and some people would be tempted to call this some sort of junctional rhythm. But the fact that it's irregular tells us it's not a junctional rhythm, but it looks more like atrial fibrillation. We have this chaotic, low-amplitude electrical activity and the baseline in between these irregular QRS complexes. So it looks like atrial fibrillation with a moderate ventricular response. Well, when we looked at V1, you need to be able to recognize right away, and anyone with any experience will look at this RSR prime and suspect that there's a right bundle branch block. And sure enough, when we look in AVL, which is a lateral lead, we see this wide S wave that corresponds with the right ventricle depolarizing late. Remember, the reason a right bundle branch block looks the way it does is because the right ventricle is depolarizing late, and the right ventricle is on the front side of the heart. So you have these late electrical signals that are moving towards the front, which is why you have this very large upgoing deflection in V1 and V2, because V1 and V2 are in the front of the chest, and since you have signals going towards those leads, it registers a very large positive deflection in these leads. But this S wave in the lateral leads, 1 and AVL, are pointing in this direction. So what you have are late signals that are going away from the lateral leads, and that's why you have this negative S wave that's very characteristic of a right bundle branch block. So that's an easy diagnosis to make. Once you see this a few times, you'll recognize it right away. But what's interesting is when you compare this R and a deep S wave in lead AVL, and you look for the same finding in lead 1, you don't see it. I mean, these are both lateral leads. They're both pointing towards the left side. So where is the S wave? It almost looks like this beat and this beat look entirely normal. And in fact, when we look at lead 2, we can see that these two QRS complexes, number 1 and number 2, look distinctly different than all the rest. All these others appear to be wider because of the presence of the right bundle branch block, but these first two beats look rather narrow. So you have to try to figure out why you have these beats that are wide, but these two first beats are narrow. I mean, can a right bundle branch block just go away like that? Can it be intermittent? But what you have to remind yourself is the physiology of the bundle branch system. Remember, these are sodium-dependent fibers with a fairly long action potential duration. This gets back to the basic physiology of the cardiac conduction system. And so these cells have to kind of reset themselves. They have to go back to the baseline resting membrane potential before they're able to fire a second time. And so there's a certain refractory period where the cells just won't fire, they won't conduct. And the right bundle branch, which goes to the right ventricle, and the left bundle branch, which goes to the left side, may, at times, have different refractory periods. And when you have bundle branch disease, the refractory period will often get longer. So that means the tissue won't conduct when the signals occur one right after the other. But if you give a little bit extra time, the refractory period will be over and the tissue will conduct. So that's a sort of a fancy physiologic way of describing a rate-related bundle branch block, otherwise known as functional aberrancy, because it's related to how the bundle branches function. So let's go back to the tracing. These wide beats are all preceded by a short R to R interval. And so when beat number 3 comes down the AV node, remember we have atrial fibrillation, and so all these signals are going down the AV node, and the AV node is what determines how fast the heart rate is. But when beat number 3 comes down the AV node, there's only a short interval, and it appears that at that point in time, the right bundle branch had not yet recovered from its refractory period. And so the signal went down the left, but had to get to the right ventricle through slow intramyocardial pathways. However, these first 2 beats were both preceded by long intervals, plenty of time for both bundle branches to recover. And so these 2 QRS complexes are narrow because the signal was able to get down both bundles at the same time and give you these narrow beats, which means that both sides of the heart depolarized simultaneously. Just because you see a right bundle branch block doesn't necessarily mean that the bundle is indeed completely non-functional. It just means that the R to R interval is shorter than the refractory period of the bundle that blocks. So understanding this concept of a functional bundle branch block becomes very useful when you have irregular rhythms where some of the beats are wide and some of them are narrow, because what you'll usually find is that the wider beats are at faster rates and the more narrow beats are at slower rates. Well, I hope this was a helpful review of the basic physiology of the conduction system. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is pretty simple and straightforward because I've been doing a lot of advanced tracings and I wanted to do a Chalk Talk for some of my beginning subscribers. So this is a kind of arrhythmia that you'll see on telemetry all the time, but it helps to learn how to classify these things because many people will mislabel it. I tell people to look at the forest first, and what you see in this strip as you scan across with your eyes is that it starts out pretty slow and then suddenly gets very fast, and then it's all of a sudden slow again. Now, as we start looking at each and every beat, it looks like a fairly normal rhythm in the beginning with a P and a QRS. And the rate here, if we count off, is 300, 150, 175. So it's a little faster than 75, about 80 beats per minute, with nice juicy looking P waves here. And so it looks like a normal sinus rhythm in the beginning, but the rate of the rapid rhythm here is more like about 150 beats per minute. It's about 2 large boxes across, and then suddenly goes back to a normal sinus rhythm again. Now notice that the QRS complexes of this rapid rhythm look the same as the QRS complexes when the heart's in a normal sinus rhythm. So it's a safe assumption that this arrhythmia came from the atrium somewhere. It's some kind of supraventricular arrhythmia. It's not coming from the ventricles. Well, the one thing it clearly isn't is sinus tachycardia, because sinus tachycardia exhibits gradual changes in heart rate. It's also known as physiologic tachycardia. And so you see slow changes in heart rate, not something quite so sudden as this. And even though you might see sinus arrhythmia, generally those R to R intervals don't change more than about 20% or so with each beat. But this is a very rapid, sudden acceleration in heart rate, so it's not sinus tachycardia. But you want to ask yourself, where are the P waves? And that's where you have to start looking at each individual tree. So we can see these P waves are very sharp and spiky, that this QRS complex comes a little bit early. If we take a pair of calipers and we set these calipers up to span the R to R interval, we can see that the R to R interval looks pretty regular, except that this beat here clearly comes early. So you have to ask yourself, where did that QRS complex come from? You have to try your best to find the P wave that resulted in this QRS. And the best place to look, obviously, is right in front of it. But we don't see a nice tall P wave like we did back here. What we see is a short P wave with what looks like almost a double bump. So this is the first P wave of this arrhythmia. It's not a sinus P wave. It came from someplace else in the atrium, and that's why it looks different than the normal sinus rhythm. So essentially it came early and it looks different, and we'd classify this simply as a PAC, but it's really the first beat of many. Well, that's where you have to start looking at the T waves, and remember that T waves and ST segments, they tend to be very smooth with slow changes in voltage, whereas P waves tend to be very sharp and spiky. And so when a P wave is superimposed on a T wave, the voltage adds up and you get a very sharp point, or if it's an inverted T wave, you get like literally a bite taken out of the T wave. And that's how you could recognize P's superimposed on T's.
So if we look at these T waves here of the second beat and the third beat, you see they look very smooth. Even this one looks pretty smooth. And when you look at the T wave of this first QRS complex, look at how tall and spiky it is. And that's because there's a P wave superimposed on the T. That's the second P wave, and it is clearly followed by the second QRS. A lot of people won't notice that P wave because the T's look, pretty unremarkable, but they're all tall. That's because the atrial events, the P waves driving this arrhythmia, are superimposed on the previous T. You have a tall P here, but now it's starting to slow down a little bit. In fact, these two QRSs are a little bit slower than these QRSs. These are about a little bit faster than 150. Now it's slowing down, it's about 145. And then the tachycardia obviously breaks, but notice that this T wave is back to being short again. So there's no P wave here. You have separate distinguishable P waves at a rate of about 150 beats per minute, and each one is followed by a QRS complex, so you have one-to-one AV conduction. So what do we call this? Well, classifying arrhythmias are mainly dealing with the atrial rate, and we know that atrial rates over 350, generally atrial fibrillation, those are also chaotic. Rates between 220 and 350 we classify as atrial flutter, and those tend to be very organized, where every atrial signal looks the same. But when you're less than 220 beats per minute, we classify it as atrial tachycardia. So think of it this way, is that your normal sinus beats are coming from the top of the right atrium. But in this case, what we have is an ectopic focus somewhere else in the atrium. Could be on the right side, could be on the left side. And it starts firing rapidly, and so the P wave changes direction. And that's why the P wave looks different than the normal sinus beat. So we see this all the time on the telemetry unit, and it's clearly abnormal. But try to look for these P waves to establish that the atrial rate is actually 150 and you have one-to-one AV conduction. And that's what really gives you the correct diagnosis. Well, I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a basic strip, but it's got a little twist to it. So let's take a look and see what's happening. Looking across at the whole strip, you see 3 normal-looking beats, and then suddenly the heart rate seems to get pretty slow. So why did the rate change? Why the sudden bradycardia? Well, let's start looking at individual beats. There look to be 3 normal beats right here at a rate that's roughly 56 or 58 beats per minute. And this QRS happens to land on a heavy line. It's pretty convenient because you can measure back and look at the PR interval is really pretty long. It's about 280 milliseconds here. And we can see all these beats have a similar PR interval. And then with this long R to R interval, you need to try to figure out, is this a sinus pause? Is this AV block? Or could there be a blocked PAC? That's the third reason for pauses like this to occur. So now take out the calipers of your mind and look at the P to P interval and try to guess where the next P wave would occur. And it looks like there's a P wave here that's not followed by a QRS complex. And the next one seems to occur on time. And if we continue to look to the right, we can see another P wave here that appears to block, and then this P wave conducts. So it's beginning to look a lot like AV block. Well, if we want to get a little bit more information, let's grab a pair of calipers. And we'll set these for the P to P interval, and then drag it on across. And there's a little bit of a difference in the P to P. This seems to be just a little bit slower, and this, of course, is a little bit slower as well. And so the P to P is slowing somewhat. There's a bit of sinus arrhythmia. But clearly, these are not premature beats. They're not PACs. If anything, there's a little bit of slowing. So we do seem to have AV block, but some of the P waves are clearly getting through and some of them are not. So we have second degree AV block. Well, that's what the person wrote on the strip. It says start of about 10 seconds run of second degree AV block. Well, strictly speaking, what we have is 2-to-1 AV block because every other P wave is failing to conduct. And so you can skip right to the top of the class and call this high grade or advanced AV block. But that doesn't really tell us whether this is intranodal or block within the AV node, or whether this is infranodal or block below the AV node, which has serious consequences on the prognosis and the potential need for a pacemaker. So you have to take a closer look at the PR intervals to see whether they are changing or not, because intranodal block tends to be associated with progressive prolongation of the PR interval, in other words, type 1, whereas infranodal block usually is associated with a fixed PR interval and often a bundle branch block, which we call type 2 second degree AV block, and that has a much worse prognosis. What we don't see in a bundle branch block here, the QRS looks fairly narrow. And if we grab our calipers again and resize them, we can see our PR here, the first beat is about 280 milliseconds. With the second beat, look at that. It seems to grow a little bit. It's now closer to 300 milliseconds. With the third beat, it stays about 300. And then following the pause, it seems to shorten up again, but only by about 20 milliseconds, maybe a half of a box. So it seems like the PR is changing a little bit, but not much. It's very hard to figure out if this is intranodal or infranodal. Well, there's a part 2 to this chalk talk. And this is what happened when the patient was asleep. So you have a conducted P wave, and then you have a blocked P wave, and then you have a conducted P wave, and then look at that. There's 1, 2, 3 P waves that fail to conduct. And then this one clearly conducts with really no visible change in the PR interval. It's still second degree AV block, but now you have 4-to-1 block. So 4-to-1 is very impressive, but some of the P waves are still getting through. Interestingly, the person labeling the strip wrote complete heart block versus ventricular standstill. So ventricular standstill, we don't really use that term when dealing with arrhythmias because it doesn't tell you why. And complete heart block is not correct because clearly some of the P waves are getting through. So remember Tulow's law, don't believe anything you read on a rhythm strip unless you wrote it yourself. This is still high grade second degree AV block, and 4-to-1 is impressive. If we look at the length of ventricular asystole here, it's about 4.5 seconds. And we know that on average it takes about 6 seconds for a person to lose consciousness if they develop asystole. So this is getting pretty close, and these kinds of pauses can lead to a sudden drop attack where somebody loses consciousness without warning and goes crashing to the ground. So this patient would appear to be a good candidate for a permanent pacemaker. Anyway, this Chalk Talk is actually a two-parter, so stay tuned for next week because I'll show you what happened after the patient got his pacemaker. And until then, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is another edition of In the Trenches. This is a Holter monitor report that was sent to me from one of my subscribers, and he wasn't really sure what to make of it. Unfortunately, many ECG recording devices are of very low resolution, and resolution has a lot to do with electronic sampling rate. Now, this is a fancy way of saying that digital instruments like ECG recorders will take an analog signal like the ECG, and it will basically slice it up into time segments at a number of samples per second. And at each time segment, it looks at the voltage, and it records that voltage as a digital number. And it stores those digital numbers, but when you want to display that digital signal, it tries to reproduce that curve, but it only has single numbers to work with. And so you wind up with a digital representation of what the signal resembled, but it doesn't always look exactly like the signal. Now, better systems simply sample at a faster rate, and if you sample fast enough, you can actually reproduce a very smooth curve. But that explains why when you look at some of these recordings, it looks very stair-steppy. That's what we kind of refer to it. It's not a smooth signal because it's actually a digitized representation of a smooth signal. As a result, sometimes there's so much digital noise in the signal that it's hard to tell exactly what's going on. You have to contain your enthusiasm about what exactly is a real signal and what isn't. But at any rate, this patient developed a wide complex tachycardia, and it's even hard to tell exactly how wide the QRS is. The onset is very easy to see because it has a very rapid upstroke, and it looks like the onset here starts almost on top of this heavy line. But where does the QRS end? It's very difficult to tell. If you look from beat to beat, there seems to be a change in the slope of the signal right about here, where you see it's like a little knee right there that is probably where the QRS ends and the ST segment starts. So it's about 120 or maybe 130 milliseconds long. But then what happens is the QRS complex becomes narrow. Now you have a narrow complex tachycardia with a QRS duration of barely 80 milliseconds. It's pretty easy to see that the QRS ends and it's about 2 small boxes wide. Now we do see this on occasion, and the question is, what's going on? And there are 2 different possibilities. It's possible that there are 2 different tachycardias. For example, this is VT, and then you wind up with some kind of SVT or sinus tach on the other side. But it's also possible that it's the same tachycardia, and the reason that this is wide is because you have aberrant conduction that, for whatever reason, goes away over here, and you're left with a narrow QRS complex. Sometimes it's easy to figure this out, and I'll show you one way that you can. If you happen to have a pair of calipers, there are a couple of different things you can do. First, let's figure out what's the rate of the wide complex tachycardia. So we'll resize our calipers, and you can measure the rate by taking the 1 pin on the heavy line, and you can see it's faster than 150 beats per minute. It's perhaps close to 180, but here's where you might want to pull out your calculator and figure it out. The R to R interval is about 340 milliseconds, so let's take 6 divided by 340, and you get 176 beats per minute. Just ignore the decimal point. So this is 176 beats per minute. But if we move our calipers to the narrow complex tachycardia, we can see that the rate is virtually the same. So that's one clue that it may very well be the same tachycardia. Now, sometimes there are beat-to-beat variations in the R to R interval. Here it seems to be very, very steady. But one trick that electrophysiologists like to do is to measure 2 R to R intervals. So if we take 2 R to R intervals and we start on the left side, we can see that these R to R intervals appear to be quite regular. Notice that this QRS complex right here is almost like a transition point. It almost looks like a fusion beat because it's halfway between the narrow beats and the wide beats. It's a little shorter than the narrow beat, but it's a little taller than the wide beat. So if this is a fusion beat, it makes you think that there's a focus in the ventricle that's firing on one side and a focus in the atrium firing on the other side, and you have one QRS complex that sort of comes from both. So finding a fusion beat like this suggests that perhaps these are 2 different tachycardias and that you just transitioned from one to the other. But if we take our calipers and we move over one more QRS complex, we see something interesting. That fusion beat is on time. It occurs at the same moment that you would have expected it to if it was the same rhythm. And if you move over one more, it appears that the second beat of the tachycardia is on time as well. If that's the case, then this beat here, this first beat, maybe has partial aberrancy. Most of the aberrancy resolves, but maybe one little branch of the conduction system is still just a tad slower than the rest and a kind of a variable degree of aberrant conduction. Well, just one last trick. If you don't happen to have a pair of calipers, just take a piece of paper and try to precisely mark where the QRSs fall. But once you have these marked on the paper, move the paper over and see how the QRSs line up. And you can see that even if you move it to the onset of the QRS complex, this maps out precisely. The fact is that it's absolutely regular and makes me think it's some sort of SVT. Now, it could be atrial tach with one-to-one conduction. It could be PSVT like AV nodal reentry tachycardia. And the aberrancy is occurring below the AV node, so it doesn't affect the rate of the tachycardia. It doesn't affect the rhythm or the cadence or the timing of the QRS complexes. I think 2-to-1 flutter is a little less likely because there tends to be a little bit more variation in the R to R intervals with atrial flutter, just because the AV node is trying desperately to keep up with a very rapid atrial rate. Well, I hope you picked up a couple of tricks in this Chalk Talk, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is another episode of In the Trenches. Well, that's right. This is an ECG that's not exactly high fidelity, but you'll be interested to know that this recording actually came from an implantable cardiac monitor. So let me give you a little bit of background.
This is a very active 75-year-old woman who has a history of hypertension, and she was on diltiazem for that. And she started to complain of episodes where she felt like she was going to pass out. She would get very lightheaded and her vision would fade away, but then within a few seconds, she would feel better again. She never lost consciousness, she never fell, and despite wearing a 24-hour Holter monitor and even a 2-week event monitor, we could never catch any of these episodes. She even underwent a tilt table test to see if she was having problems with low blood pressure, but that was normal as well. So we implanted a cardiac monitor. This is an insertable monitor. It takes about 5 minutes to implant with a local anesthetic, and within a month or so, she had an episode of lightheadedness, and this was the recording that the monitor automatically captured. And it's pretty obvious that there's this area here that looks like her heart stopped. So I want to analyze this together with you. Just like last week, this is a digitized recording, and so there's a fair amount of digital noise that's buried within the signal. So you kind of have to look past the noise and try to figure out, number one, is this real or not? And number two, what is the nature of the rhythm problem? So we can see a regular rhythm here on the left side, and if you look carefully, there does appear to be a P wave in front of each of these QRS complexes with a PR interval that's at the upper limit of normal. And then it looks like a pause here, and these are continuous strips. And this measures about 4.7 seconds, and then there seems to be a QRS complex here, and there's another pause that's just a little over 3 seconds. And finally, the heartbeat seems to pick up again after another QRS complex, and then you have a resumption of a heart rate of about 80 beats per minute. Well, do you think this is a real pause, or do you think just that this is a fault of the monitors, is a technical fault? And even if it was an intermittent problem, you would not expect to see the QRS morphology change. Look at how these two beats look different than the underlying beats. They're missing the initial Q wave. The STT waves are a little bit distorted compared with the other beats. They seem a little bit wider. And so the change in morphology makes you think that these are actually true escape beats and that this is a real pause. Of course, an implantable monitor is in contact with the patient's tissue and is not subject to having a wire fall off. So when you see a pause like this, you really should try to figure out what's causing the pause, because bradyarrhythmias can occur in one of two locations. It can be a sinus pause, where the sinus node gives out, or it can be due to AV block. And the question is, are there P waves in here or not? Did the sinus node fail to fire, or are the atrial signals failing to get through the AV node? So when you look at this pause carefully, there does appear to be a little deformity that suggests that there might be P waves that are not conducting. If you grab a pair of calipers and get a sense of what the atrial rate is, you can move these calipers across and see if it maps out. And sure enough, that P wave does appear to land on time, and these P waves do appear to map out. If that's the case, then this arrhythmia falls into a very special category known as paroxysmal high-grade AV block. This is a specific diagnosis because it's not really complete heart block, since these P waves obviously conduct, and following this pause, we can see that conduction resumes. And so this is an episode that comes and it goes. It's paroxysmal, and we have multiple P waves that fail to conduct, so it's high grade. And that's where this arrhythmia gets its name from. And we have two escape beats that we pointed out before, and then eventually AV conduction resumes. But the first question for this patient is, could this be due to diltiazem? We know that diltiazem affects AV node conduction, but this appears to be more likely due to block below the AV node, because it is behaving like an all or none sort of infranodal level of the block, as you would see with trifascicular conduction system disease. Usually, if the AV node is the location of the block, you get prolongation of the PR interval, and you get kind of a type 1 or winky back pattern of a variable PR interval. But this is more likely due to trifascicular block below the AV node, and pharmacologically, calcium channel blockers like diltiazem affect the AV node itself. They don't really have much effect on the tissues below the AV node. So this patient eventually received a permanent pacemaker, and she's been free of symptoms ever since. But I wanted to share this recording with you and help you learn how to best classify pauses that you might see on an ECG as either sinus or AV block, and to appreciate this diagnosis of paroxysmal high-grade AV block, because you will see it every now and then, and I wanted you to be able to recognize it.
So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a very basic strip. Now, you might say, wait a minute, these Chalk Talks are never basic. Can't you give me something simple to practice on? And the truth is that you can find normal strips at work, and you can find normal strips in the textbooks. What I'm trying to do is teach you how to look at ECG rhythm strips in a new light. Be able to analyze them. These Chalk Talks are always a little challenging. They show you things that you won't see in the textbook because I want to make you an ECG expert. So let's get to this. This is lead 2, and I always teach people to look at the forest first before looking at the individual trees. So as your eyes scan across this electrocardiogram, what sticks out pretty obviously are the QRS complexes. And if you just kind of eyeball them, they seem to be fairly regular. So the next question to ask is, are there P waves associated with each QRS complex? When you look right in front of the QRS complexes, it looks really quite flat. So it might take you a little while to realize that perhaps this bump right here, which seems to be consistently in the same place, might actually be the P wave. Well, of course, if that's the case, the PR interval would seem to be very long. But are we sure those are the P waves? I mean, it comes right after the T wave. So we have QRS complexes and T waves, but don't we sometimes see something called a U wave? Did you ever hear of a U wave? It's an electrical wave that can sometimes even fuse with the T wave, and it can indicate electrolyte problems or other issues. So how do we know that this is a P wave and not a U wave? T waves and U waves are basically connected to each other. The U wave is part of the repolarization process. And so if you have a U wave, it's going to always land in the same spot compared with the T wave. So if we now look at the trees very carefully, if we look at each and every one of these bumps that follow the T wave and see if they are consistently attached to the T wave, we find that they're not. Look at every single one, and now look at this one and compare it with this one. You may have to get out a pair of calipers, but you should train your eyes to see that the distance between these two waves is shorter than the distance between these two waves. You see that? So that tells you that it's not a U wave. It's not part of the repolarization process. It's not connected to the T wave. And so that supports this actually being the P wave. So, wow, look at that. The PR interval really is long, isn't it? So now let's try to measure some intervals and rates and so forth. So since the QRS complexes are fairly regular, the easiest thing to do is find one that lands on a heavy line. You happen to have one here. And there are lots of different ways to calculate the rate, but the easiest way is probably to count off boxes the way I do in the basic course. So starting from that heavy line, we have 300, 150, 100, 75, 60. So it's between 60 and 75. Then you can kind of guesstimate that it's about 68 beats per minute. There are more precise ways of calculating the rate, but it's really not that important. One way is to actually measure the interval and then use a calculator to divide that into 60,000. So that's about 900 milliseconds. So you can take 60,000 and divide that by 900 and you get, there you are, 67 beats per minute. So now let's try to figure out what is the PR interval. And here it helps to find a QRS that actually starts on a heavy line because then you can measure backwards. So right here, this QRS starts on a heavy line. So where does the P wave start? The P waves do seem to have a sort of a gradual onset and then they drop down more quickly. So I would say that the PR interval probably starts around here. When you're first starting out with ECGs, it can sometimes help to use calipers. So you would take a pair of calipers and place one pin at the beginning of the P wave, and then resize the caliper so that the other pin is at the beginning of the QRS complex. Now you pick up the calipers and put one pin on a heavy line, and we're measuring just about 400 milliseconds. And you can go from one beat to another and see if it's consistent, and pretty much it is. It might be a little bit shorter depending upon where you think the P wave starts, but the difference is only maybe one small box. So we can clearly say that the PR interval is probably 360 to 400 milliseconds long. So longer than normal, anything over 200 milliseconds is considered first degree AV block.
All the P waves are conducting, the PR seems to be fairly constant, but it's just taking a little too long to get down the AV node to the ventricles. The other two intervals you have to concern yourself with is the duration of the QRS complex and then the QT interval. This QRS complex that lands on a heavy line is handy because you can take a look at the duration and you can actually see that it's just a little bit more than 3 small boxes. So I would call this QRS complex about 130 milliseconds. The upper limit of normal for the QRS duration is 120, so there's some kind of interventricular conduction disturbance. Now, the last thing to measure is the QT interval. This QRS that starts on a heavy line, it makes it easier to measure everything. And so the end of the T wave is right about here between 2 small boxes. That makes it about 460 milliseconds. So if the QT is 460, is that normal? Well, you have to really correct it for the heart rate, because the faster the heart rate is, the shorter the QT interval should get. And we use Bizet's formula to correct the QT interval. Bizet's formula is that the QTC, or the corrected QT interval, is the QT that you measured divided by the square root of the R to R interval in seconds. So we know the R to R interval is 900 milliseconds, so that's equal to 0.9 seconds. So we'll grab our calculator one more time and take the QT that we measured, 460, divided by the square root of 0.9, and you get 484. Now that's a little bit long. The upper limit of normal for males is 420 to 440, and for females it's 440 to 460. So the QTC is 484, and that's a little bit long. So that's how you dissect a strip like this. This is a little bit more challenging than just a plain old normal sinus rhythm strip, but you really have to do this over and over again and see all different kinds of strips before you get to be really comfortable with this. So I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes compliments of one of my colleagues in Austria. Thank you, Dr. T, for sharing this with us. And it's pretty obvious to see that on the left-hand side you have what looks like a normal sinus rhythm with normal intervals and a P wave that's upright in 1 in AVF, and you have a rate of just under 75 beats per minute. And then what happens is you have this sudden onset of a wide complex tachycardia that's grossly irregular. It gets very, very slow in here, and then it gets fast and slow. So it's irregularly irregular. People who are trained in the school of pattern recognition would generally look at this and say, well, it looks like VTAC, so it's probably VTAC. Except for one thing, somebody told me that if it's irregularly irregular, then it must be AFib with aberrancy. And I think if you showed this to 10 telemetry techs, you get 5 people who'd call it VTAC and 5 people who'd call it AFib with aberrancy. And what I've always said is that if you rely on pattern recognition alone, you're going to be wrong half the time. Unfortunately, I think you get the same result if you ask 10 physicians. So how do you analyze this tracing and come up with the right answer and be able to prove that you're right? Wide complex tachycardias are either atrial with aberrancy or they're ventricular. And so you have to approach this from a physiologic standpoint. Why does aberrancy happen? And is the tracing consistent with aberrancy occurs when part of the conduction system in the ventricle is refractory? And so instead of the signal going down both sides of the heart at the same time, somewhere in the conduction system you have a branch that's refractory, so the signal has to take a detour, and that's why it takes longer to get around the heart. So aberrant conduction causes the QRS to widen, and it causes the morphology to change. So most of the time, there is a rate-related or a functional aberrancy that you have to try to sort out, telling whether it's ventricular tachycardia or not. There are things that can sometimes be helpful, like the width of the QRS, the rate of the tachycardia, and whether it's expected or not. But regularity is really not a very helpful observation in trying to figure out if it's ventricular or not. So just because it's irregular does not necessarily mean that it's atrial fibrillation. You can certainly have irregularly irregular ventricular tachycardia. So that's an old wives' tale that I'm happy to dispel. The other thing that can be very helpful is the morphology, or the shape and the axis of the QRS complex. And ultimately, the most important finding is the presence of of AV dissociation, which remember is defined as the ventricular rate is faster than the atrial rate, and that means you have more ventricular events than you see atrial events. If you find that, then the diagnosis is indisputable. Okay, so let's take a closer look at this. Let's just zoom in a little bit and move it over. If we try to find a QRS complex that lands on a heavy line, here's one right here, and you can see that it lasts about 3 small boxes. So the width here is about 120 milliseconds. So it's not terribly wide. Now, initially, when you look at this rhythm, it seems to start right here with a wide QRS, and all the QRS complexes kind of look alike. And when you look at this first interval, you see that it's clearly premature. And what if we said that if the beat is early, then it could be aberrant? In other words, this first beat, number 1, we'll label it, if it came from the atrium, it could have landed at a point when the conduction system was refractory, so it might be supportive of aberrant conduction. But if that was the case, what should you see in front of that first beat? You should see a P wave. Because if it's aberrant, it needs to have started in the atrium. And you have to look very, very hard at the segment in front of that first beat to look for a P wave. And it helps to compare the previous ST-T wave with this ST and T wave. Even if you look at multiple leads, I cannot convince myself that there's a P wave right there. But one thing I can see, if you look very carefully at this QRS complex, is it actually looks different than the underlying QRS complexes. And you can appreciate this by looking at all the leads. Look how this is tall, very positive. Now it's getting smaller. Now it's halfway down, and then it becomes negative. Look at lead 2, very, very tall, and then it's a little shorter, and then the QRS becomes very small. This QRS is more negative than positive, but then it becomes more positive than negative, then it's very positive, and during tachycardia it's very positive. So what's happening is there's a gradual change in the QRS complex from these conducted beats to the wide complex tachycardia. And that tells you that this beat right here is actually a fusion beat. It's called a fusion beat because it came partly from one source and partly from another source. In this case, it has a P wave in front of it, so it came partly from the atrium. But because it's a fusion beat, it suggests that it came partly from the ventricles. And the proof of that is if you look at the PR interval of this beat, it's shorter than the PR interval of the normal beats. You can see that the QRS complex starts immediately after the P wave. There isn't even a PR segment like you see in these first couple of beats. So this is starting to look like a ventricular tachycardia. The first beat of the tachycardia is probably out here because this is a kind of a very, very vague fusion beat, very, very small amount of change in the QRS complex that suggests there might have been a PVC that starts to deform this one. And then clearly the tachycardia starts with this beat. Fusion implies AV dissociation because the ventricular rhythm is starting to overtake the atrial rhythm. Now, we talked about morphology, and when you look at morphology, you can see the QRS complexes during the tachycardia are completely different from the QRSs during the conducted beat. Look at lead 1. During tachycardia, lead 1 is completely negative. That means the axis is going this way, and that's such a bizarre axis, it's almost always going to be ventricular. But again, the best thing to do is to look for AV dissociation, and that's where you have to look for beat-to-beat variations in the appearance of the R waves, the ST segments, and the T waves. So if we look at that ST segment and T wave and compare it with the next one, well, I see a little bump there, a little bite that's down going, and it's midway down the ST segment, but in this beat, it's a little bit higher. So it's not part of the T wave, it's not part of the ST segment, it's separate, it's moving around, and that must be the P wave. These very well must be retrograde P waves because remember, about 1/3 of people have intact retrograde conduction up the AV node. So if they get ventricular tachycardia, it's able to be conducted up the node to the atrium and you get retrograde P waves. But in this case, look at the third beat here. That rapid deflection, that little bite is gone. But in the next beat, it's back again. And then it's gone, and then it's back again. Some of the QRS complexes are followed by a retrograde P wave, and some of them are not. So there are more QRSs than Ps, and what's happening is the AV node sometimes lets the signals go through up to the atrium, and sometimes the signals block. So you have intermittent retrograde conduction, but clearly AV dissociation is present, and so this is definitely ventricular tachycardia. So instead of using pattern recognition and being right 50% of the time, understand the physiology and look for these little subtle details, and then you'll be able to prove that your diagnosis is the correct one. Well, I hope this was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a fairly basic 12 lead, and we'll go over how to approach these things in an organized way. So first, take a look at the rhythm strip and get a sense of what the rhythm is doing. We can see it's a very regular rhythm at a rate of just under 100 beats per minute. Now, there's an FLB here. We know what that is, funny looking beat. And it looks wide and bizarre, but make sure you look in front of that beat to see if there's a P wave there, because it could potentially be an aberrantly conducted PAC. If you compare the T waves of the previous beat with the T wave in front of this wide beat, I do not get the sense that there is a P wave in front of that beat. And there also seems to be a little high frequency signal at the very beginning of the ST segment. And the last thing is, if you take a pair of calipers and you resize them to cover 2 R-to-R intervals, we can come down here and demonstrate that indeed the next P wave comes exactly on time. So this is known as a fully compensatory pause, meaning that the sinus node was not disturbed by this wide beat, and all of this points to this being a premature ventricular contraction. Now, just to make sure, the P waves are indeed upright in 1 and AVF, so I think it's fair to say that this is a normal sinus rhythm with one isolated PVC. The PR interval appears to be normal and the QRS looks quite narrow. But if we look at the T waves, we can see some abnormalities here. In the limb leads, at least, the T waves are inverted in the inferior leads. And we can also see that in the precordial leads, V3 through V6, there are very deep, bizarre, symmetrical T wave inversions. The QT interval in most of these leads measures about 400 milliseconds. And if we apply Bazet's formula, we get 400 over the square root of the R to R in seconds. And if we round that off to about 600 milliseconds, that's 0.6 seconds. Grab our calculator, take 400 divided by the square root of 0.6, and that's quite long at 516 milliseconds. Now, it's conceivable that these T-wave inversions represent some sort of ischemic event, but it seems to be a little too diffuse for that. You'd expect that to be limited to one anatomical location. But you have anterolateral here in V3 through V6, but you also have inferior T-wave inversions. So it's more diffuse. And you can see this kind of deep symmetrical T-wave inversion and QT prolongation in people with metabolic disorders, or even in people who've had a central nervous system event like a stroke or a subdural hematoma. So you kind of have to read this as being diffuse nonspecific T-wave abnormalities with QT prolongation. But there are no pathological Q waves, no ST changes to suggest acute ischemia. Just to be complete, you want to make sure that the voltage is appropriate, and it does appear to be. The P waves are normal. There's no atrial abnormalities. The axis appears to be normal. It's up in 1 in AVF. It's most isoelectric in 3, which gives us an axis of about plus 30. But otherwise, this ECG seems to be okay. So try to approach cardiograms in an organized fashion. But when you start to see abnormalities, pick up on it. Noticing those initial inferior T-wave abnormalities leads you into this T-wave diagnosis that you don't want to miss. And once you do a few hundred of these, you start to notice those abnormalities immediately. Well, I hope this was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk comes from one of my subscribers in Egypt. He sent me this photograph of a cardiogram, so I'm sorry it's a little distorted, but I tried to straighten it out as best as I could. Now, your interpretation of this rhythm strip actually depends on how much experience you have. So let's first look at it from a beginner's standpoint. You can see QRS complexes that seem to be pretty regular. In fact, if we count off the rate, it's 300, 150, 100, 75, 60, 50. Now, it's about 45 beats per minute. And when you look at some of these beats, there does not appear to be a P wave in front of them. But when you come down to one of the other leads, you can see a P wave, but the PR interval looks extremely short. And your first guess is maybe this is some sort of junctional rhythm. But then the PR interval gets a little bit longer, and it does seem to vary because here it's shorter again. On this beat, the PR interval is practically non-existent, meaning the QRS and the P wave occurred nearly simultaneously. Looking back, you can see the same thing, is that the PR interval is changing, and at times, the Ps and the QRSs are occurring at the same time. The bottom strip isn't quite so helpful, but you can see little tiny P waves in the bottom strip as well. So if you know the basics, you'd say that this PR interval is too short for the P wave to have conducted. And the fact that it's changing means that the QRSs must be arising on their own. And that makes this a junctional rhythm because it is narrow and it's slow like a junctional rhythm. The P waves are not driving the rhythm. The P waves are occurring separately from the QRS complexes. Now, if you have a little bit more experience, you realize that the atrial rate and the ventricular rate are nearly identical. You have this junctional rhythm going at 45 beats per minute, and the P waves are going at more or less the same rate, but you know that they're not related because the PR is changing. So the Ps and the QRSs are going at the same rate, but they seem to be dissociated. And so there's a name for this, and it's known as isorhythmic AV dissociation. Iso meaning the same. So the two rhythms are going at the same rate, the atrial rhythm and the junctional rhythm going at the same rate, but they're not associated with each other. They're firing independently of each other. And so you feel pretty good about making that diagnosis, except for one thing. Experienced electrocardiographers know that they should always think about what else could it be. They don't get distracted by the obvious. They start looking for tiny details. And so if you have any experience at all, you'll start to wonder what this bump is and what this bump is. And you'd say to yourself, well, it's following the T wave, so could it be a U wave? Because it seems to pretty consistently follow the T wave. You can even see it in this lead up here. You see a large T wave and what you think might be a U wave. But you really need to consider in your mind, could that be another P wave? Could we be dealing with 2-to-1 AV block? So first, take out a pair of calipers. Let's shrink these down to see if that bump maps out. So if you take the top of these two bumps and you move this over, it doesn't look like it maps out exactly. Maybe it does, maybe it doesn't. It's kind of hard to know. See, now this came a little bit later. So let's stretch our calipers out a little bit the way we would do it in real life. And now move that over, and maybe that's a little bit longer too. And you know, we're really not convinced whether these are really P waves or not. Because if I stretch that out a little bit more, then it doesn't seem to map out this way either. Well, there could be some sinus arrhythmia going on, but how do you know for sure? How can you tell if this is a P wave or is it a U wave? Here's where the experts can figure it out. If it's a U wave, it should always land exactly the same position after the T, because it's part of the repolarization process in the ventricles. Now, if you look really carefully, you can look at the time between the T wave and this second bump and compare this beat with this beat. It looks a little different, doesn't it? And now compare it with this beat. Aha! That's how you can tell that this bump is not part of the TU complex. It's not part of the repolarization process. It's separate and distinct from the T wave. And so, therefore, it must be a P. So the term AV dissociation is reserved for situations where the ventricular rate is greater than the atrial rate, and the QRS kind of overtakes the P wave and begins to fire independently. But what do we call it when you have many, many more atrial events than ventricular events? And there's no definitive relationship between the Ps and the QRSs. We call this complete heart block. And that's what this is. It's third degree AV block with a junctional escape rhythm, but just by coincidence, the junctional escape rhythm is going around 45 beats per minute, and the underlying atrial rate is about 90 beats per minute. And so your escape rhythm is going at a rate exactly 1/2 of the sinus rate. and it gives you the appearance that they're almost kind of sort of related, but they're not. Because the QRS complexes are perfectly regular, you know that it's coming from the AV junction. None of these P waves are actually conducting, because otherwise the QRSs would be irregular, and the PR interval would be normal. And so what I would call this is pseudo-AV dissociation, because it doesn't strictly meet the criteria for AV dissociation, even though they are dissociated. What it really boils down to is complete heart block. Yes, they're dissociated, but we don't use this term. When the atrial rate is faster than the ventricular rate, we call it complete heart block with a junctional escape that just happens to be 1/2 of the sinus rate and gives the appearance of AV dissociation. So I thought this was really cool, and I thought I would share it with you guys. So until next week, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is pretty basic, but this is such an important topic. I wanted to review a couple of important principles you need to use when looking at a strip like this. So remember what I always say, look at the forest first before you start looking at the individual trees, and you can see that there are 2 fairly slow beats in the beginning. They look like normal sinus beats. The rate's just under 60 beats per minute. And then you have 4 FLBs, right? That stands for funny looking beats. They're pretty wide, about 160 milliseconds in duration. The initial deflection goes in the same direction as the normal QRS complex, but the T waves are obviously disturbed because the ventricle is obviously being depolarized abnormally. It's very irregular. It starts out at a rate of about 80, and then it just accelerates slightly before stopping, and then you're back to a sinus bradycardia again with a rate just under 60 beats per minute. So what we have is a wide complex tachycardia here. And the 2 most common things that cause this are either some sort of atrial or supraventricular arrhythmia with aberrant conduction that would explain the wide QRS. And the other possibility is that you're dealing with non-sustained ventricular tachycardia. Now, there's a common misconception out there, and a lot of telemetry techs and nurses believe that when you have a wide complex tachycardia that's irregularly irregular, that it must be atrial fibrillation. Non-sustained ventricular tachycardia is supposed to be regular. If you look and see what the nurse wrote on this strip, it says 4-beat run of aberrantly conducted AFib. But remember Toulo's law. Never believe anything you read on a rhythm strip unless you wrote it yourself. So let's look at this strip critically. If we consider this to be beat number 1, where did it come from? A QRS complex has to come from somewhere. If it started in the atrium, atrial fibrillation, by the way, does not come out of thin air. It's usually initiated by some kind of visible atrial event, like a PAC. If this first beat came from the atrium, then where is the P wave? If you're going to say that it's supraventricular, you need to be able to see some atrial event that resulted in this first QRS complex. I see no P wave here. So you can't just imagine that there's a P. If there's no P and the QRS is wide and bizarre looking, regardless of whether the initial part of the QRS goes in the same or a different direction than the underlying QRS complex, it's wide and bizarre with no P wave in front of it, and therefore it's ventricular. Well, if this first beat is a PVC, then they all must be ventricular, because they all look the same. And sure enough, you really don't see any atrial activity anywhere. And so really your only choice is to call it non-sustained ventricular tachycardia. It doesn't matter that it's not regular. There are 2 electrophysiologic mechanisms that can cause non-sustained ventricular tachycardia. There may be a scar on the heart from an old myocardial infarction, and then what can happen is there may be some slow conduction in the border zone of the scar tissue, and that causes the electrical signal to scoot around in a circle. It's known as reentry. And reentry is the cause of that scary monomorphic sustained VTAC that can kill people. And reentry is quite regular because the signal is traveling around and round in a single pathway. But the other mechanism that can cause ventricular ectopy is a focal source, known as a disturbance of impulse generation. It can be an automatic focus, or it can be due to abnormal calcium currents, something called triggered activity. But regardless, it's basically one spot in the heart that starts firing, and the waves just travel across the heart and cause an abnormal QRS complex. But these
these automatic foci, this focal ventricular arrhythmia, can certainly behave in a very erratic fashion. And so most likely this ventricular arrhythmia, this non-sustained VT, is due to some sort of automatic focus and not due to reentry, just by virtue of the fact that it's irregular like this. So certainly VTAC can be irregular, so don't make the mistake of assuming that anything that's irregular must automatically be atrial fibrillation. This is an important lesson because you have to remember that not all VTAC is the same, and not all VTAC is life-threatening. The last point is this. Aberrant conduction generally occurs because the signal is premature. Remember, you have multiple branches of the conduction system. You've got left anterior, left posterior, maybe you got a right bundle branch, and they may recover at slightly different times. And so if a premature beat comes down the AV node and encounters a His-Purkinje system that's only partially recovered, some of the branches are willing to conduct, but some may not have recovered and they may be blocked. And that's what causes a functional or rate-related bundle branch block. And so you're dealing with a rate-related phenomenon. And so by definition, an aberrantly conducted beat should be early. It should be premature. It should be sort of like right on top of or just after the T wave. Because remember, it's during the T wave where the ventricular repolarization occurs. And if you recall, the action potential defines a refractory period, so that if a signal comes down at a point where the cells have not recovered, it will not elicit a response. Let's say if another part of the conduction system recovers a little quicker, then that same signal may elicit a response in that part of the conduction system. So you have the purple that fired and the blue that blocked, and that's why you get these rate-related bundle branch blocks, but the beat has to be premature. This first beat of the tachycardia is not early, so there's absolutely no reason why that beat should have conducted with a bundle branch block. If you understand these principles, you'll be able to diagnose any wide complex tachycardia that comes your way with a logical, physiologic approach. You'll always arrive at the right diagnosis. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting rhythm strip that I came across on one of the intensive care units. So this is 3 rhythm strips, but they're actually continuous. And when you look at the forest, you can see a couple of quicker beats here and then some slowing, and it's a little bit irregular down here. But then in the bottom strip, it's really very, very slow. So let's try to figure out what's happening with this irregular rhythm. If we look at the space in front of each QRS complex, we can see a very sharp deflection here that looks like a P wave. This first PR interval appears to be a little bit long, maybe 240 milliseconds. And as we look in between these two QRS complexes, we see a very similar high-frequency jiggle right here. Looking at this PR interval, it seems to be a little bit longer. How can we tell? Well, pay attention to the PR segment. That's the flat spot between the P wave and the QRS. Here, it seems to be relatively short, but this PR segment appears to be growing longer. And sure enough, with this P wave, we can see a very long PR segment. So the PR interval in total appears to be getting very long. And the next thing we see is a P wave that is not followed by a QRS complex. So it appears that this P wave failed to conduct to the ventricles, and then this P wave is associated with shortening of the PR interval. So this looks pretty straightforward up here, don't you think? We have what looks like a regular atrial rhythm at a rate here of about 75 beats per minute with type 1 second degree AV block because the PR interval is getting longer, and then finally this P wave fails to conduct and the PR gets short again. So this is actually a pretty basic strip. Let's see what happens after that. We have the PR was short, then it gets longer, and this P wave looks like it gets longer still, and then we have another non-conducted P wave. And in this case, what you have is 1, 2, and 3 QRS complexes, but there's always one more P wave in type 1 second degree AV block, so this works out to be 4 to 3. All right, so you're thinking, well, what's the big deal? So no problem. Well, let's keep on going. Now the P seems to be short again, but it looks a little bit weird because now the PR didn't really get very long. This P fails to conduct, and then you have a short PR, then this P blocks,
and a short PR and this P blocks. And you're thinking, wow, it looks like 2-to-1 block now. So we went from a fairly benign looking type 1 second degree 4-to-3 winky back, and now we're looking at maybe 2-to-1 block here with a very slow ventricular rate. It's about 40 beats per minute. And so if you label this as 2-to-1 block or a so-called high grade second degree AV block, you'd actually be wrong. You say, wait a minute, why? There's twice as many P waves as there are QRS complexes, so doesn't that make for 2-to-1 block? Well, that's true if you're dealing with a normal sinus rhythm. What struck me is that the P waves don't all look alike. These sinus P waves kind of have a sort of a down, up, down appearance to them, but this P wave actually just goes down. It's completely negative. And when you kind of, with your eyeballs, map out these P waves, wouldn't you have expected one to land here? And why was this one late? So when you're not sure, pull out a trusty pair of calipers, and let's set them for the sinus interval here. So this is pretty good from P to P. It looks pretty regular. We can march these on through, and everything's fine. But what about down here? This P to P is exactly the same as all the others, but look at that. That's actually a PAC. It looks different than the sinus P wave, and it comes a little early. So if this is a PAC, that explains why the next P wave appears to occur a little late. Because what happens is this PAC may arise from somewhere down here, causing the P wave to go away from the feet, so that's why you have a negative deflection in lead 2, which is one of the inferior leads. But that signal is able to get into the sinus node and then reset the sinus node so that the next sinus impulse comes a little bit later. If we mark where this pin lands, and then drag our calipers over, we can see that the following P wave occurred a little bit later, because this PAC here took a little time to travel back to the sinus node and then reset it, so that the next P wave was a little bit delayed. Then if we take our calipers to this sinus P, we can see that there's another PAC here. So this beat right here that blocked is actually a PAC. We know that if premature atrial beats occur shortly after the AV node conducted a beat, then it may find that the AV node is refractory because it came so quickly. Okay, now that I've explained that, take another look at this bottom strip. Is this actually 2-to-1 block? Now you can see that this is a sinus beat, and this is a PAC, and this is a sinus beat, and here's another PAC. And so what's happening is that every other beat is a premature atrial contraction, and these PACs are occurring in a bigeminal pattern. And that's why this is not 2-to-1 block per se. It's actually non-conducted atrial bigeminy. It's obvious that the AV node in this case is not functioning properly, since you have wanky back block at a rate of 75, which is a pretty low rate, and this particular patient wound up going on to have a permanent pacemaker. But when you're the one who's putting a label on a rhythm strip, I want you to make sure that the label is accurate. Don't rely on pattern recognition. Examine strips carefully and understand why the ECG looks the way it does. Well, that's it for this week. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting 12 lead. It took me a couple of minutes to figure it out, and I wanted to share my thoughts about this to kind of give you a sense of what does a heart rhythm specialist think about when he's looking at a crazy ECG like this one. It's a slightly different format with the limb leads on the left side and the precordial leads on the right. So when we glance at the whole strip, we can see that it looks fairly regular for the most part. You see the heart rate is a little bit faster than 100 beats per minute. It's maybe about 110 or maybe 115. But I see a P wave in front of every QRS complex. Kind of looking at other leads, we can see in the inferior leads they're going up. Lead 1, it's upright as well. So my first thought was just sinus tachycardia. It looks to be a normal P wave axis, but the P wave does look a little funny, and the PR interval appears to be short. It starts on the heavy line, and the QRS starts over here, so it's only about 110, or maybe at tops 120 milliseconds, so I would say that this PR interval is on the short side. If we look at the precordial leads, V1 looks very interesting because the P wave has a very large negative deflection and a slight positive deflection initially and then a big negative, so that's consistent with left atrial abnormality. But the QRS also looks kind of odd because it has an RSR prime pattern. It looks like the right ventricle is depolarizing late, so if I see a wide S wave in the lateral leads, then I would call it an incomplete right bundle branch block. However, I don't see a wide S wave here. I'm really not that impressed with lead 1. So, given that this is actually a 34-year-old man, I would probably just label this as a right IVCD, or right-sided interventricular conduction delay, but not necessarily an incomplete right bundle branch block. I know that's kind of splitting hairs, and some people would read the incomplete right bundle, but in young patients, you can sometimes see residual right-sided forces like this, and it's still considered a normal variant. In fact, some readers wouldn't even mention it. They would just call it normal. QRS has a normal transition, looks like V4, and the T waves all look normal. Switching back to the limb leads, it looks most isoelectric in AVL, so if that's the case, AVL is 30 degrees above the horizontal, and that gives us an axis of plus 60, which is, of course, normal. Looking at anatomical regions, starting with the lateral leads 1, AVL, V5, and V6, there are no pathological Q waves or ST abnormalities. The T waves are all going in the right direction. The inferior leads 2, 3, and AVF all seem to be normal. I don't see any evidence of inferior infarction. These Q waves, by the way, are not deep enough or wide enough to be pathologic, so they don't count. It really kind of looks like a fairly normal tracing, other than the fact that you have sinus tachycardia with a short PR interval and this right-sided IVCD. But it got me thinking, why is the PR interval so short? Because normally at faster rates, doesn't the AV conduction get worse? Shouldn't the PR interval be a little bit longer? I said to myself, well, could this be 2-to-1 conduction? Because the rate of 110 would be consistent with maybe a slow atrial flutter at 220 beats per minute and 2-to-1 conduction. And if we look for a second atrial event, right in between those two, it would kind of land on this T wave. So the question is this atrial tachycardia with 2-to-1 conduction? And is the second P wave buried in the T wave? I mean, could it be in there? Usually T waves are large and they can hide a lot of things. But T waves have an axis too. You can see that sometimes the T waves are a little smaller, sometimes they're much bigger, but there should be one lead where the T wave is fairly isoelectric. And in this case, it's AVL. Well, let's take a close look at AVL. We can see that the T waves are fairly flat in AVL, aren't they? So they're not getting in the way. But what's important is you have to figure out what does a P wave look like in this lead. And we can see a fairly distinct P wave. It kind of has an M shape. It's very consistent, and it's there in front of every QRS complex. And sure enough, if we figure out what's midway between, it should be here someplace, and I sure don't see another P wave. It's not over here either, so that pretty much disproves that this is 2-to-1 conduction. So I think the best explanation for the short PR interval is just that the patient's catecholamines are revved up, his sympathetic nervous system is on overdrive, and that's just simply enhancing AV conduction and causing the PR interval to be on the short side of normal. Now you have to remember that if you measure the PR interval of a bunch of normal people, you'll find a curve that looks like this. It's called a normal distribution curve. And they established normal values of 120 to 200 based on the fact that those values include roughly about 95% of the normal people. But there are going to be 5% or so of people on both ends of this curve. These are normal people, but they have PR intervals less than 120 milliseconds or greater than 200. You can't use those numbers as an absolute cutoff between normal and abnormal. What if somebody has a PR interval of 119 or 202? That's why I don't stress measuring exact intervals and reporting slight changes in the PR interval when you're following someone on telemetry, I mean, you kind of have to look at the big picture. So in this case, it very well may be a normal ECG for a 34-year-old gentleman whose sympathetic nervous system is revved up for whatever reason. Now, granted, there's a little left atrial abnormality here. Otherwise, this electrocardiogram looks a little funny, but I wouldn't be surprised if the patient's heart is, in fact, normal. Anyway, I hope that was helpful. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip that came off of a telemetry unit. And it's a basic strip, but we don't see things like this too often. So let's take a look and see what happens. Now, this is a continuous strip, so there are 3 parts to it. The first part up here, when you first start analyzing what's going on, is that there seem like 4 normal-looking beats with a P wave, and a QRS, and a T wave. And if you want to calculate the rate, at least initially, this QRS is right in the middle of these heavy lines, so we can still count it off. 300, 150, 100, 75, 60, 50. So the PR interval looks fairly normal, but it starts off with a sinus bradycardia at 50 beats per minute. The next one looks a little bit slower, I would say, just eyeballing it. This would be 50, so it's a little bit slower than that, but we're still looking at normal PQRSTs. And now what's starting to happen is it's starting to slow down. The rhythm is starting to decelerate. All of a sudden, you have a very long P to P interval, a very long pause here. This is nearly 2 seconds. So we're talking about a rate of just about 30 beats per minute. And this is a continuous strip. You can see you have one more very slow beat, and then you have what looks like asystole here. Now, of course, the first rule is to ask the question, is it real? Could the wires have fallen off? And I would say no, for a couple of reasons. First of all, this is not a perfectly straight line. It doesn't look like it was drawn with a ruler. It sort of starts a little bit lower, and then it kind of moves up a little bit, and then kind of goes down. It's sort of a little bit, tiny bit wavy. And you can also see little tiny jiggles of electrical noise that make you think it's still getting the signal. What also goes against this being a make and break artifact is that deceleration of the sinus rhythm here, where it starts to get slower, and then you have this long pause. How long is it? It's just about 5 seconds. And it looks like there's a P wave here, but the PR interval here is very short. It's practically non-existent. And this QRS complex is really wide. It has a notch in it. And so I believe that this is a sinus P wave, but I don't believe that P was able to conduct to the ventricles. So what we have is a wide QRS that occurs after a long pause. So it's an escape beat. And because it does not look like the normally conducted beat, then therefore it's not a junctional escape. It must be lower than that. I would call this an idioventricular escape. But right after that, I see on top of the T wave, there's a little bit of a bump here. The T doesn't look smooth. It's got a double bump, and that conducts to the ventricles. And it really does look like you had a couple of fast beats here that interrupted this profoundly long sinus pause. Now, the fact is it's over 3 seconds. And so strictly speaking, it's known as a sinus arrest. But it's very quickly followed by a couple of rapid atrial beats that conduct to the ventricles, and then the sinus rate is much faster here. It's initially about 64 beats per minute, and now it's going about 75 through the rest of the strip. And so the electrocardiographic diagnosis here is sinus bradycardia with rapid deceleration followed by a sinus arrest of about 5 seconds that rapidly resolves to a normal sinus rhythm. Pretty basic. But one of the things you should do when you're looking at strips like this is try to figure out why. Why did this occur? And so you have sinus node dysfunction, but you'd like to think about what actually caused it. They're broadly grouped into intrinsic sinus node dysfunction and extrinsic sinus node dysfunction. And what's the difference? Well, intrinsic means that the sinus node itself is having a problem, and we generally denote the diagnosis of sick sinus syndrome in that case. Extrinsic sinus node dysfunction occurs when something else causes the sinus node to slow. It can be related to sudden increases in vagal tone. It could be metabolic. So, for example, if someone is in renal failure and they're acidotic or they're hyperkalemic, or someone who's profoundly hypothyroid can wind up with sinus node dysfunction that's based on an extrinsic mechanism. In this case, it's not likely to be metabolic or thyroid because it occurs suddenly. and it resolves very rapidly. In fact, it's kind of unusual to see this behavior in someone who has sick sinus syndrome, because usually sick sinus doesn't occur so rapidly and then resolve so immediately. It's almost like the sinus node is responding to some external influence. And let's say, for example, if this was a young patient who is having waves of nausea and maybe even vomiting, or someone who is in pain, this could very likely be just a vasovagal episode with profound bradycardia and a long pause. If the person is standing up, in fact, a 5-second pause could possibly even lead to syncope or fainting, just sudden loss of consciousness when the brain doesn't get any blood flow for 5 or 6 seconds. We can also see this in someone who has obstructive sleep apnea when they become profoundly hypoxic, and we can see gradual slowing of the sinus node. It could be that, but after all, it was about 8 o'clock at night, so the patient's not likely to be sleeping. So you do have to look at the patient from a clinical standpoint, evaluate their age, the presence of underlying heart disease, whether they're on any medications that could affect sinus node function, and what they were doing at that moment. I would have a strong suspicion that this was a vasovagal episode, just because it resolves so quickly, and rapid changes in sinus rate are usually mediated by profound fluctuations in vagal tone. I hope that gives you some insight into what you should think about when you're analyzing a strip like this. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk covers a basic concept that we need to go over every now and then. So these are 2 rhythm strips. They are continuous. They came from a telemetry unit at my hospital. And remember, look at the forest first. And the first thing you should notice is that it's very messy. It's kind of noisy on this side. And then you have what looks like a very rapid, narrow, complex rhythm over here that seems to continue into the next strip. Now you should take notice of what the telemetry tech wrote on the strip. It says possible run of SVT. So whenever someone uses the word possible, it means they're really not sure. And I hate to say it, but you have to kind of assume that they're wrong. Remember, Tulow's law. Never believe anything you read on a rhythm strip unless you wrote it yourself. So now let's start analyzing this strip closely, taking a look at the trees. At the very beginning, there seems to be a QRS complex right here. Again, it's narrow. It has an equal-sized R wave and S wave, but it's preceded by a very rapid electrical signal, and those of you who have any experience might assume that perhaps we're dealing with atrial fibrillation. But following this QRS complex, we see that there is an enormous amount of movement on the baseline here. Very tall, jumpy signals, very deep, crazy signals that really just kind of looks like noise, like a very, very noisy baseline with perhaps some motion artifact that the patient's moving around or the wires are being shaken. As we come over here, this next QRS complex looks the same as the first one, and we can figure out the rate here. It's just a little above 60 beats per minute. And after the second QRS, it still looks pretty noisy, but then you have a very sharp signal right here. Now this looks different than the first 2 signals. It's primarily a QS pattern, but it's still fairly narrow. Following that, you still have a little noise in the baseline. And then you have a much larger signal that has a little bit of an R and a much deeper S. And then one of these QS patterns, and then the QS signal, very narrow, seems to take off now at a very rapid rate, just about 250 beats per minute. If you measure the time between these 2 signals right here, it's about 6 small boxes. That's 240 milliseconds, and that's equal to 250 beats per minute. And this signal seems to be pretty regular right here. And the next one's over here, but what I'm not sure about is this signal right here. What is that? Is that just the motion artifact? Did the patient move the wire again? Maybe, but let's keep looking and see what happens after that. So this rapid, narrow QRS complexes seem to be pretty regular, but you get this nagging feeling that this signal here looks a lot like this signal here. Why is that? Well, those of you who have any experience in telemetry units should have the answer already. If not, then this is a perfect Chalk Talk for you, and I'm going to show you why. First, let's grab a pair of calipers. Let's drag them over here and flip them over and take a look at this R to R interval right here. Now, if we move this over, we see the interesting thing is that this large signal here occurs at the same rate as the first two QRS complexes. Now, you wouldn't expect that with this QS signal in between, unless it was a coincidence. But just for fun, let's move these calipers over, and we see something interesting, that this weird squiggle is at roughly the same rate, and if we move it over again, we see that corresponds with this funny squiggle. And if we keep moving the calipers, we see a signal right over here that also corresponds with that same rate. And then one last time when we move it over, we see a very similar signal that has that RS in equal proportions right here. Now, how can that be? You have to realize that this is physiologically impossible, because if you look at these signals, you cannot have two QRS complexes that are only 80 milliseconds apart. And the same thing over here, you cannot have three QRS complexes all fitting in here, because that would correspond with a heart rate of over 500. The ventricles take a while to recover from their refractory period. And here, these two signals are practically occurring at the same time, and these are occurring at the same time. So what is this? Well, you have to recognize this as artifact, but not the way you thought. Yes, these little squiggles on this side are artifact, but we were thinking that this QRS in the middle was artifact because the patient moved, but in fact, it's these rapid signals that are the artifact. This so-called SVT doesn't really exist. The electronic system is picking up a very rapid signal. But these purple beats here are the true QRS complexes. And when you come down here, your task is to pick out the real QRS complexes. Well, here's one right there. And when you look across and ignore these rapid artifactual signals, you see a very sharp jiggle here. It's almost like a double signal, but one of those is artifact and one of them is real. Now over here, the real QRS complex seems to get lost a little bit, but here's one that you can clearly pick out, and then here's the next one. And if you move your calipers down, still a very similar rate here. It's not exact because there's probably some sort of sinus arrhythmia going on, and so the real QRSs are a little bit irregular, but you have to understand that you cannot have QRS complexes this close together. It's just not physiologically possible. And so that right there is your biggest clue that you're dealing with a signal that's not real. One of them is not real, and you have to figure out which one. And given the fact that these purple signals are marching through at the same rate as what you had in the beginning, that's how you can tell that it's the rapid signals that are artifactual. So when you're at work and you see something really crazy like this, don't be fooled, because the first question you should really ask yourself is it real? So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a very interesting 12 lead that I came across, and I thought I would share it with you. So this 12 lead was done about 7 p.m. on a patient who was admitted for a non-cardiac reason. So if we come down here to the rhythm strip and kind of look across, we can see that the rhythm appears to be regular. The rate is somewhat fast. We can find a QRS that lands on a heavy line, count off 300, 150, 100. So the rate looks to be about 115. Each QRS appears to be preceded by a consistent P wave. So let's come up to the limb leads. We can measure some basic intervals. If we choose this QRS, the Q wave lands on a heavy line, so the PR interval is about 120 to 130, so it's in the normal range. The QRS appears normal. The QT interval is about 320 milliseconds. We can use Bazette's formula and take 320 divided by the square root of the R to R interval in seconds. So it's about 540 milliseconds, so we'll take 0.54, take the square root of that, and that gives us 435 as a corrected QT interval. So that's normal. The QRS axis appears to be most isoelectric in lead 3. So remember, lead 3 goes in this direction. So the perpendicular to that would give us an axis of plus 30. And when we look at anatomical regions, we can start with the inferior leads. There's a little tiny Q wave in lead 2, but it's not significant. There is a Q in lead 3, but the Q in AVF is not significant either. It's not greater than 1 box wide or deeper than 1/3 the QRS. So there's no old inferior infarction. The lateral leads appear to be normal. And when we look at the precordium, we can take a look at the P wave in V1, so there's no atrial abnormalities. The precordial progression appears to be normal, the transition points in V3. And the only thing that I would say is that the STTs look a little funny in V3. They're just a little flat in V4 and V5. And there's just less than 1 millimeter of ST segment abnormalities. So I would consider this nonspecific STT abnormalities. So a pretty unremarkable cardiogram. But the interesting thing is that 2 hours later, they decide to repeat the cardiogram. And this is what it looks like now. Okay, so here's before. And if you look at the limb leads, here's after. And it looks quite a bit different. It still looks like the same heart rate, but the P waves have almost disappeared. They seem to be upright in 1, but they're sort of flat, if anything, a little negative in 3. The axis is almost indeterminate. It's nearly isoelectric in 1 AVL, lead 3, and lead AVF. And the crazy thing is that the QRS complexes in lead 2 essentially have disappeared. Now we have Q waves in 3 and AVF, and pretty much the precordial leads look about the same. So what just happened? In the course of 2 hours, it appears that we've lost a huge amount of voltage. Our axis has shifted. It now looks like we have an inferior wall infarction that wasn't there before. And in fact, lead 2, which, points in this direction, which should have the largest signal, is essentially gone now. Here's before, and here's after. I'll put them side by side. Okay, so on the left-hand side are the limb leads 2 hours later, whereas here's the baseline. Look at those big juicy R waves that have essentially disappeared. So what happened? Well, you really need to be able to recognize this, and you don't see it too often, but this is what happens when someone puts the limb leads on the wrong limbs. Remember Einthoven's triangle? You have lead 1 that goes from right arm to left arm. You have lead 2 that goes from right arm to left leg, and you have lead 3 that goes from left arm to left leg. But people have 4 extremities. So in the United States, the black electrode goes on your left arm, the white electrode goes on your right arm, the red electrode goes on your left leg, and the green electrode goes on your right leg. But wait a minute, 2 seconds ago we talked about Einthoven's triangle, and triangles have 3 points, and we have right arm, and left leg. So what's the right leg for? Well, the right leg is a ground. It's a ground electrode that allows the ECG machine to kind of filter out noise. Well, here's where things can go wrong. If the person attaching the ECG machine accidentally switches the right arm electrode for the right leg electrode, then what happens is the right arm becomes the ground, and essentially the right leg is exchanged for this point of the triangle. Okay, you with me so far? So now what happens is the ECG machine goes to record lead 2, and so it looks for signals from the right arm to the left leg. But what it's really measuring is the right leg to the left leg. Keep in mind that the heart is all the way up here, and electrical signals are being generated up in the chest. And the ECG machine is looking at electrical differences. But since the right leg and the left leg are both far away from the heart, essentially there's no electrical difference between the 2 legs. The signals from the heart reach the 2 legs simultaneously, and so that records virtually no signal in lead 2. You get it? You can even see it in the rhythm strip. It's practically a flat line. You can see little tiny QRS complexes, but it's practically nothing compared with the real lead 2. So when you see virtually no signal in lead 2, it means the ECG machine was attached incorrectly, and that renders the tracing uninterpretable. It should just go back and repeat it. Sometimes the wire is actually attached to the wrong plug on the ECG machine, and you'll see a whole bunch of cardiograms coming out of the same machine looking like this. So you have to call the ECG department and have them figure out which machine it is so that they can correct the technical problem and keep it from happening again. Well, that's it for this week's Chalk Talk. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12-lead challenge. That's right. There's a lot of things wrong with this, and wanted to get you guys used to reading more difficult tracings. So if we look at the rhythm strip down here, we can see that the QRS complexes look to be fairly regular at a rate of somewhere around 70 beats per minute, and there's just one wide complex beat, an FLB, we like to call them, funny looking beat. We'll figure out what that is later. And looking for some clues to figure out the rhythm, we do see a very sharp deflection right here, and it seems to be consistent, and it's a sharp deflection that looks like a P wave. We can look at other leads. Here in lead 3, we see it as well. But of course, if that's the P wave, then the PR interval is extremely long, about 400 milliseconds here. Now what happens with that wide complex beat? The P wave appears to occur in the same place as it should be, but this QRS complex starts much, much earlier with a very short PR interval. And the QRS looks distinctly different from all the rest of the beats. And so even though the QRS itself isn't that wide, it's only maybe 110 milliseconds in duration, we have to call this a PVC. When you have a P wave that lands right in between the two QRS complexes, one of the things that you have to consider is whether there could be a second P wave buried in the middle of each QRS. In other words, could the atrial rate in fact be 140 beats per minute? And you're just seeing 2-to-1 conduction, and the PR is very long because it's a rapid atrial rate, and with that the PR gets long because the AV node is taking a while to conduct the impulse. And so the P wave in the middle of the QRS must be blocking, and this one is conducting. And that's something that you really do have to consider. But I chose this ECG specifically because it has this PVC. And the cool thing is that the PVC allows us to look at the point midway between the two P waves. So if we look for evidence of a second P wave, we don't see it in this lead, and I don't see it in the precordial leads either. So this PVC allows us to establish that the atrial rate is not 140, we don't have 2-to-1 conduction, that this is simply a normal sinus rhythm with a very long first-degree AV block. Okay, but when the P wave lands in between the two QRS complexes, you have to ask yourself, why is the PR so long? And consider whether the atrial rate is actually twice as fast and that the second P wave is buried in the QRS. If we look at the limb leads now, QRS complex does seem a little bit wide, and the axis is very bizarre. Look at this, it's isoelectric in AVR, and it's negative in 2-3 in AVF, so it's going away from the feet, isoelectric to AVR, and that gives us an axis of minus 60. Ignoring the PVC, look at the conductive beats in the precordium, and we see what looks like a Q and then an R prime pattern. And we see a Q wave in V2 with really no S wave. There's no negative component to either V1 or V2. V3 has a Q wave as well, and V4. So we only have R waves in V5 and V6, and we have a very negative S wave in V5 and V6 as well, along with this R prime over here, and that's consistent with a right bundle branch block. But it doesn't look like your typical right bundle. It doesn't have an RSR prime. There's really kind of no S wave at all. So it's a very bizarre looking precordial progression. And when you're missing S waves in V1 and V2, when it's predominantly positive, you have to think about an old posterior MI. And then you have these Q waves in V1 through V4, which is also consistent with an old anteroseptal MI. Well, then to complicate matters even more, if we go back to the limb leads, we can see that 2-3 and AVF are very negative, and it kind of looks like there's a Q wave. So could this be an old inferior MI as well? Well, a lot of cardiologists would read it this way, but there's one other thing to consider. If you look very carefully at the inferior leads, and I'll magnify them right now, it turns out that those are not Q waves, that there's a little tiny upward deflection at the beginning of each of these QRS complexes. You see that? How the QRS goes up just slightly before it heads down. And you can even see that here in AVF. So some people refer to this as a micro R wave. And that suggests that this is, in fact, not an old inferior MI. But given the fact that you have an axis of minus 60 degrees, it makes it consistent with a left anterior hemiblock because you have a little tiny R and a deep S in lead 3. And if we go up to lead 1, we have a tall R and a small S wave. And that goes along with the left anterior hemiblock. So this is a patient that has some pretty severe conduction system disease. They've got a long first-degree AV block. They've got a right bundle branch block, a left anterior hemi block. That could actually indicate trifascicular block, but that could also explain the really bizarre precordial progression. I think if I was reading this, I would sort of hedge my bet and say either cannot rule out an old anteroseptal MI or possible old anteroseptal MI in the face of a right bundle branch block, left anterior hemi block. But I've seen patients like this when you get an echocardiogram and you see that their LV function is actually normal, and that this actually represents just a very severe trifascicular conduction system disease. What's also interesting is that the PVC actually looks more narrow than the conducted beats, which I just think is a cool finding. So this actually represents one of the more difficult tracings that I've shown you, and I think different cardiologists would actually read it differently. But the point is not to miss anything and to always consider all the different possibilities and to take an organized approach to analyzing this kind of difficult 12-lead tracing. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi there, this is Dr. Nick with the Ecg Academy, and this basic strip came from a Holter monitor. Looking at the entire strip, we see a pretty regular rhythm with a rate that's just under 100 beats per minute. It appears that there's a P wave in front of every QRS complex, and if we measure the PR interval, it's a little over 200 milliseconds, probably 240. The QRS seems fairly narrow, and the QT interval looks okay. T wave seems to end right around the midpoint between the two QRS complexes. So it would appear that you have a normal sinus rhythm with a first degree AV block until we get to this beat right here. So how do we figure out what that beat is? Well, it's obviously wide and bizarre, but the best way to figure out if this is atrial with aberrancy or ventricular is to see if it was preceded by a premature P wave that we can identify. So it's often helpful to pull out a pair of calipers. The easiest way to set this up is to set it for the R to R interval, and we can check to see if it's regular or not, and then we can look and see if that corresponds with the P to P interval, and it does. And then we come down here to the P wave prior to the wide beat, and if we place the calipers at the beginning of that P wave, we can actually see that there is a P wave that seems to occur on time immediately in front of this QRS complex. And if we bring the calipers over one more time, we see that the next P wave occurs exactly on time. So it would appear that the atrial rhythm is marching on through and is not affected by this wide QRS complex. Not only that, but this PR interval is way too short for this QRS to have conducted normally, and so everything would indicate that this is a premature ventricular contraction. The fact that this P wave comes on time means that the pause following this premature beat is what's known as fully compensatory. You know, sometimes after a premature beat, you do get a pause that follows it, but the fact that this P wave occurs on time, we can then refer to this pause as fully compensatory. When that occurs, it essentially means that the atrial rhythm was not affected by the wide beat, and that's consistent with a premature ventricular contraction. The reason we can say that is if the sinus node is firing on a regular basis, and you have a premature atrial contraction that, let's assume, comes very, very early and conducts aberrantly, well, what you might see is a wide premature beat, and of course we're looking for the P wave that resulted in that beat, but sometimes we don't see it. We may be monitoring just one single lead, and the PAC may be isoelectric in that lead, or it may land on the T wave at a point where we just cannot see it, but we have this wide beat now because it was conducted aberrantly. But here's the point. If it's a premature atrial contraction, then most of the time it winds up penetrating the sinus node and resetting the sinus node. What I mean by resetting is that the impulse causes the sinus node cells to fire, to depolarize, so it affects the timing of the next sinus impulse. With the PAC, the following P wave usually does not occur on time. If the sinus node gets reset, it may actually occur early, and if the PAC penetrates the sinus node and suppresses it, that P wave may actually occur later than it should. So the pause following the premature beat is often not fully compensatory with an atrial premature beat, but with a PVC here, in this case, it is fully compensatory. So I hope that helps to explain this somewhat confusing concept, that a fully compensatory pause usually indicates that the beat is ventricular. There are exceptions to that rule, however, because sometimes PACs are so precisely timed that the next P wave may occur on time and could make it seem like the pause is fully compensatory. Conversely, if a PVC occurs early enough, it may conduct retrogradely up the AV node, and that retrograde P wave could reset the sinus node. That can result in all sorts of bizarre long pauses, so just because it's not fully compensatory does not rule out a PVC. Well, I hope this was an interesting discussion for you. It's pretty basic, but the next Chalk Talk will actually be somewhat of a continuation, and I think you'll find that one to be an excellent review of the physiologic principles that we use to approach these strips on a daily basis. So until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a continuation of last week's Chalk Talk. It's actually the same patient, and I'm showing you the same strip as last time. If you watched it, you remember that we have a normal sinus rhythm with a first-degree AV block, and then here we have a ventricular premature beat, and the P waves actually march through the strip, and this one occurs on time, giving us what we called a fully compensatory pause, with the idea being that the sinus node fires at about the same time as a PVC occurs, and the PVC does not make its way up the AV node, and so the next sinus nodal impulse comes down exactly on time because the PVC did not have a chance to interfere with it. A fully compensatory pause suggests that you're dealing with a PVC, mostly because atrial premature beats usually wind up penetrating the sinus nodal complex and reset the sinus node, so it affects the timing of the next sinus nodal impulse. In that case, the following P wave is not on time, but can be earlier or rather later. Now, if you didn't watch the last Chalk Talk, I suggest you go back and review that if some of this is unfamiliar to you. Now, having said that, I want to show you the second part of this tracing, which is the same patient, but just a few seconds later. It looks like in the beginning of the tracing we have a normal sinus beat here, just like we did before. But now we have this wide complex tachycardia. It's a little irregular, but it has a similar morphology to the PVC that we saw before. Notice that there is a P wave in front of the first beat, and the fact that it's irregularly irregular and has a P wave in front of it, a lot of people would make the mistake of calling this a fib with aberrant conduction. But don't you make that mistake. The first piece of evidence that this is ventricular tachycardia is the fact that the QRS complex looks very similar to the PVC that we saw in the other tracing. It's isoelectric, deeply down, and mostly up. So here we have isoelectric, deeply down, and mostly up. So if it looks like a PVC, it's probably ventricular. The second piece of proof is that, bringing back our calipers, we see that this P wave in front of the first beat occurs on time. So if it occurs on time and it's not premature, why should this QRS complex conduct aberrantly? Remember, aberrant conduction occurs when a beat comes down the AV node and encounters refractoriness in the interventricular conduction system, the His-Purkinje system. But in order for that to happen, it has to be premature. So to call this aberrant conduction doesn't make physiologic sense, because it's not premature. The third piece of evidence that this is ventricular is the fact that this PR interval of the first beat is significantly shorter than the intrinsic PR interval. So that tells us that this first beat did not come from that P wave. It must have arisen from the ventricle. Point number 4 is, again, that this first beat, it came from the ventricle, but it looks a little bit different than the next beat. And the fact that it has a P wave in front of it and looks a little bit different tells us, in fact, that this first beat is a fusion beat, because it mostly came from the ventricular ectopic focus, but this P wave may have come down part of the conduction system and contributed slightly to the QRS complex, so you have a little bit of a different morphology compared with the rest of the run. And finally, the icing on the cake, or should I say the hallmark of ventricular tachycardia, is the presence of AV dissociation. You have a dissociated P wave here that was not present here. And sometimes we can actually map those dissociated P waves out. So one would have occurred right in the middle of this QRS complex. The next one gives us a little bump in the front of this QRS. The next one here looks pretty obvious. Well, now that I point it out to you, You might not have seen that before. So right here is one dissociated P wave. And if we keep on moving, we see there's a bump at the end of this QRS complex. And that corresponds with the bump on this ST segment. So that's the next dissociated P wave. And you see this one there? So look how easy it is for us to demonstrate that the atrium is doing its own thing and is completely unaware of the fact that the ventricle has been taken over by this VTAC. And we can see that the next P wave occurs exactly on time. And if we keep on going, we can see that this P wave occurs on time, but there's a PVC as well. Now the question for those ECG experts is, why did this P wave block? Why did it not conduct to the ventricles? And the answer is concealed conduction up the AV node. So you have a PVC that arises here, and it's able to enter the His-Purkinje system in a retrograde fashion, and it partially penetrates the AV node, but is not able to exit the AV node and conduct backwards to the atrium, but it leaves the AV node refractory. Since the AV nodal cells just fired, when the next sinus P wave comes down, it encounters refractoriness within the AV node. And that's known as concealed conduction. It conducted into the AV node, but we didn't see it except that it left the AV node refractory. And the evidence of concealed conduction is failure of this P wave to get down the AV node. So this was a great strip. It brings out a lot of advanced physiologic principles that you should use every single day when you're analyzing strips like this. Because you'll be surprised at how many people don't pay attention to this stuff, and as a result, they incorrectly interpret these strips. Well, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a rhythm strip, and I have two leads here, lead 2 and lead V5. And when we look across, it looks, well, in a word, slow. And the QRS looks a bit wide, so we have 3 very slow wide beats, and then we have a couple of other beats that look a little bit different, and then we're back to slow and wide. Now, what separates these 2 beats from the rest of them is not just the fact that the QRS looks a little bit different and that they're a little bit faster, but they also have P waves in front of them. Isn't that interesting? If you measure the PR interval, it looks really quite long, probably about 320, and this second PR interval looks about the same. When you see bradycardia, you either have a sinus node problem or you have an AV node problem. You can have both at the same time. As a chronic illness, in other words, a person can have diffuse conduction system disease with both sinus node dysfunction and AV node dysfunction, but most of the time it's either one or the other. So if we can figure out what the atrium is doing, that'll give us a clue as to whether we're dealing with a sinus node problem or an AV node problem. Well, we've already seen these 2 P waves, and if you look back at roughly the same interval, you see that there's actually another P wave right here. But the atrial rate is pretty slow. If we count off from this P wave, we have 50 beats per minute in this direction, and a little bit faster in this direction, we have about 55 beats per minute. But where are the rest of the P waves? We don't see one in front of this QRS complex. We do see one in front of this QRS, but it seems to be just kind of hanging there with nothing in front of it or following it. So the atrial rate seems to be slow, but also very erratic. So we can figure that these 2 beats are conducted, but then where is the P wave here, and where does this beat come from? Well, one of the things that could be going on is that you could have a blocked PAC somewhere superimposed on this T wave, which could result in a pause. But if you look at this T wave and compare it with the previous one and do the same with the second strip, I don't see a PAC there. What I do see is a little bump in front of this QRS complex, and I suspect that that's the next P wave. Well, maybe calipers would help. And we'll just set it for this P to P interval right here, stretching those out. Okay, so if we move forward, we don't see a P there, but if we move backward from this P wave, we see one there. And if we move backwards here, that P lines up pretty well. But going back, I don't see a P on this ST segment. I do see one here, but there's nothing that lands there. So what we have here is very erratic sinus rate with marked slowing of the sinus node. And so it's beginning to look like the problem here is a sinus nodal problem. But then the question is, what are these beats here? Let's grab our calipers again and see if they're regular. We'll just stretch these out, and we see that that's very regular. And if we figure out the rate So this interval actually measures 1500 milliseconds. But that's an interesting number, because if you take 60,000 and divide it by 1500, you get exactly 40. And if you look very carefully at the onset of these QRS complexes, you'll see something very, very important. I'm going to magnify that image a little bit. And what you can see is this very, very small deflection in front of the QRS complexes that are going at exactly 40 beats per minute. So can you guess what that is? It's a pacemaker. You could have thought that maybe this is a wide QRS complex and that it was perhaps an idioventricular escape in the setting of marked sinus bradycardia. But the fact that it's exactly 40 beats per minute and that we have those little tiny spikes there, it makes more sense to call this a demand ventricular pacemaker. We can even see that little deflection at the beginning of this QRS complex. So it turns out that this patient has an implantable cardioverter defibrillator, and it's a single chamber ICD. But single-chamber ICDs, by convention, are generally programmed for a ventricular pacing at 40 beats per minute. We see ventricular pacing at 40 beats per minute for 3 beats, but this P wave comes at such a time where it's capable of going down the AV node, and so this is a conducted beat with a first-degree AV block that inhibits the output of the pacemaker. It inhibits it because that beat came sooner than the pacemaker would have fired. If I bring my calipers down to this ventricular pacing spike, the next V-paced event would have occurred here, but instead the P wave occurred at such a point when it can go down the AV node, but it does get down to the ventricle before the pacemaker had a chance to fire, and it inhibits the pacemaker output. But how do we know that the pacemaker is working normally? Well, we take our calipers and we place it on the pacemaker spike of this beat, and we can measure back and see that the pacemaker must have sensed this conducted beat right at this moment, and that started the pacemaker timing cycle, and then right here, the pacemaker timing cycle ends and it paces in the ventricle. So we have normal VVI pacemaker function at 40 beats per minute with sinus bradycardia and sinus pauses with a very unreliable sinus rate. And on top of that, we also have first-degree AV block. But we see no P waves that fail to conduct, so we do not have second or third-degree AV block. Some people would look at this strip and see these P waves marching all over the place and mistakenly identify this as complete heart block. But make sure you look for those little tiny pacemaker spikes, because some people might miss those, and then you might label this strip incorrectly. If you'd like to learn more about pacemakers, there are a couple of videos in the intermediate course, but there's a more detailed discussion in the advanced level on Ecg Academy. Well, I hope you enjoyed this discussion, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12 lead that I thought I would share with you. And it's fairly basic, but it's good to go through this exercise to figure out what's happening. So remember, the first thing to do is look down here at the rhythm strip lead 2 and get a sense of what the rhythm is doing. And it may be hard to pick out the QRS complexes, but this looks like one. Very sharp deflection, and then there's a T wave here. And here's the next one, and here's the next one. So the QRSs seem to be regular, but slow. But where are the P waves? Now, it's hard not to see P waves because they seem to be everywhere. Here's one, and you can see another one here. Here's one also. And if you notice, this T wave has a bump in it and here. So it kind of looks like the P waves are marching through. So it's pretty obvious that the ventricular rate is a lot slower than the atrial rate. And so if your atrial rate is faster than your ventricular rate, you have some degree of AV block because some of the P waves are not getting through to the ventricle. Remember that if your ventricular rate is faster than your atrial rate, that's a different situation, and that's referred to as AV dissociation. And that usually indicates some acceleration of a lower rhythm. You can see this with ventricular tachycardia or an accelerated junctional rhythm or some other reason why the ventricular rate is faster than the atrial rate, and the lower focus is what's driving the rhythm. In this case, however, what we have is AV block, and we can measure some heart rates with a pair of calipers. We can bring this down to the ventricle, stretch it out to the R to R interval, and measure the rate by placing the pin on one heavy line. So it's below 50 beats per minute, probably about 46 or 48 beats per minute. And the question is whether it's regular or not. And that's really an important question. and I'll tell you why. If the ventricular rate is perfectly regular, then that tells you that none of these P waves are conducting, because a regular ventricular rhythm indicates an escape focus. In this case, the QRS looks pretty narrow, so it looks like a junctional escape, and the rate of about 46 to 48 beats per minute is consistent with a junctional escape rhythm. Well, if the ventricular rhythm is perfectly regular, indicating an escape rhythm, it tells you none of the P waves are getting through. And when none of the P waves are getting through, you have third degree or complete AV block. Let's resize the calipers and see what our atrial rate is. Come on down here and make sure those P waves are regular. And they do seem to be. This one's on top of the T wave, and this one comes through. So the atrial rate is actually about 120 beats per minute. Well, if the atrial rate is 120, you have to wonder if it's some kind of atrial tachycardia. I mean, it could be sinus tach, but we have to look at the P waves specifically and see if they look like sinus P waves. Well, they are up in 1, and they're very up in 2, and they're up in AVF as well. So the P wave axis appears to be normal. And if we look in the precordium, it's negative in V1 and V2, but it becomes positive in V3, and that's kind of consistent with the sinus P wave as well. So I think most likely what you're dealing with is sinus tachycardia with complete heart block. Now, why would the atrial rate be so fast? Well, if your heart rate is only 46 because of the presence of complete heart block, it might not be enough to provide sufficient blood flow to your vital organs, like your brain. And if that's the case, what happens is the sympathetic nervous system gets turned on, your brain tries to increase cardiac output, and that causes your sinus node to beat faster. Unfortunately, those P waves don't get through to the ventricles, so it's often an ineffective physiologic reflex, but that explains why your atrial rate is so fast. So in this case, it looks like sinus node function is normal, but the AV node is completely blocked. Well, the QRS complexes are still conducted because if we assume it's a nodal rhythm, we can still read the rest of the cardiogram. And if we look at the limb leads, we can see the most isoelectric is lead 2. And so that gives us a little bit of a left axis deviation of minus 30. In the precordium, you have poor R wave progression. So some people would read possible or cannot rule out an old anterior MI. But you also have to consider that with a nodal rhythm, sometimes you can get interventricular conduction disturbances. And looking a little bit more carefully, the QT interval seems to be a little long, but considering how slow the ventricular rate is, I think corrected for the rate, it's normal. And otherwise, there don't seem to be any glaring abnormalities in the QRS complexes. So the main point of this cardiogram is that you have sinus tachycardia with complete heart block, but always make sure that the ventricular rhythm is perfectly regular, and that tells you that none of the P waves are actually conducting. So that's it for this week. And until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this Chalk Talk is another 12 lead with another crazy rhythm. I just happened to come across it while I was reading ECGs for the hospital. So sometimes it helps to look at the entire tracing to kind of get a preview of what's to come. And the one thing that should strike you is that the voltage is kind of low in the limb leads, but the precordial leads look okay. But it does look irregular, and on the rhythm strip, there does not seem to be any particular pattern. You've got some fast beats, and you've got a couple of pauses here. But the pauses are a good place to concentrate on because often you can see what the atrium is doing. And the common thread that runs through this strip is that the pause has a very flat segment, and there's clearly a P wave in front of the first QRS. And likewise, here you have a flat interval before the P wave, but the rest of it is all crazy, isn't it? If you just concentrate on this middle segment, it almost looks like there's atrial fibrillation going on with rapid irregular atrial signals. But how can you have atrial fibrillation and P waves? Well, the answer is that the atrial fibrillation seems to stop. And then you have this quiet part of the rhythm before you have a sinus beat, and then another run of what looks like an irregular atrial flutter, perhaps. You know, the rate here is a little slower here, maybe 240, but here it's a little bit faster. So it's almost like you've got bursts of very rapid atrial activity causing this irregularly irregular QRS complex to occur. Same thing at the beginning, you have what looks like perhaps atrial fibrillation, and then it just suddenly stops. So we don't see this too often. Usually, paroxysmal atrial fibrillation goes on for at least several minutes or even hours before it stops. But here what you have are these very brief bursts of atrial activity. And when you think about rapid atrial arrhythmias, you should always think about mechanisms. And there's two main mechanisms for tachycardia. You have disorders of impulse conduction, and you have disorders of impulse generation. The difference is that disturbances of impulse conduction refer mainly to reentry, where you have a signal that's stuck going round and round in a pathway. And one example of that is typical atrial flutter with those very regular, consistent sawtooth flutter waves. Disorders of impulse generation, on the other hand, occur when a focal area in the atrium starts firing rapidly, and the signals spread as if you throw a rock into a pond and the waves gradually make their way across the surface of the pond. Of course, the atria generally conduct very rapidly, but the point is that you have this focal source of electrical activity, and we often call this an arrhythmogenic focus, and a lot of times on a cardiogram you'll see an atrial ectopic tachycardia occur that's very regular with a P wave that clearly doesn't look like sinus, and the AV node acts as a bystander, passively conducting the impulses to the ventricle. Usually atrial tachycardias are at rates of 120, perhaps up to maybe even 200 beats per minute. But this rate is much faster. It exceeds 300 at times, and it almost looks like atrial fibrillation. So can we have focal atrial fibrillation? Well, we know that atrial fibrillation most commonly arises from the pulmonary veins, particularly patients with paroxysmal atrial fibrillation. And that's why atrial fibrillation can sometimes be treated with catheter ablation. And specifically, we perform a procedure known as pulmonary vein isolation, or PVI. So this could be a focus somewhere in the atrium that's firing very rapidly. But the odd thing is that it stops and starts and stops and starts. So recognize this as most likely a focal source of tachycardia. These flutter waves are irregularly irregular, so it's not typical atrial flutter. But patients will frequently present with palpitations that come and go, and their pulse seems to be irregularly irregular, so they can be mistaken for atrial fibrillation. As far as the rest of the cardiogram is concerned, we have low voltage in the limb leads, and if we look carefully at the QRS complexes, we see that the axis is a little rightward. Notice that lead 1 is more negative than positive. So in fact, it's got to be in this half of the circle. And with 2, 3, and AVF being positive, the axis is probably here someplace. So it's a rightward axis. And anatomically, there are no pathological Q waves, there's no T inversion. The precordial leads all seem to be progressing properly. The QT interval is normal. Everything else is fairly normal, except for one thing, and it may be a clue. If you notice in V1, there's one sinus beat that we can examine, and that P wave shows a biphasic deflection with a very large negative component, and that's consistent with left atrial abnormality or left atrial enlargement. So maybe that's a clue that this person has an enlarged left atrium and irritable pulmonary veins for whatever reason, and has now developed these very short paroxysms, these bursts of atrial fibrillation. But don't just call it atrial fibrillation. Notice that there are sinus P waves every now and then, and recognize them for what they are. This is just one of those odd findings that I came across and I thought I would share with you. Anyway, until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting rhythm strip, and I thought I would share it with you because you don't see it too often, and I wanted to just step through what's happening on this rhythm strip so that if you see something like this in the future, you'll recognize it. First, a little background. This is an 82-year-old gentleman who is in a nursing home. He has a history of coronary artery disease. He had a myocardial infarction in the past with an ejection fraction in the range of 25%. He also has a history of atrial fibrillation. He received an implantable defibrillator a couple of years ago, but his dementia got the better of him, and now he's on several medications, including Namenda and Effexor, and someone placed him on amiodarone for his atrial arrhythmias. He's somewhat confused, so you can't get a history from him, but he's being monitored on the floor, and this strip occurs. This is one continuous rhythm strip, and in the beginning you start to see what looks like QRS complexes that are fairly consistent and irregularly irregular. And there are also other QRS complexes of a slightly different morphology. But then what happens is, because of the nature of atrial fibrillation being irregularly irregular, there is a little bit of a pause that occurs here, and then you have a sudden increase in heart rate. The first QRS looks a bit different from the rest of them, but then after that, the QRS complexes begin to change radically, both in their width, with these first couple being very wide and this one being very narrow, and also the axis seems to change, with the first 4 beats going up, and then you have a bunch of QRSs going down, and then it becomes isoelectric again. So this sort of looks a bit like a particular polymorphic ventricular tachycardia. Most people will recognize as torsade de pointe. But what happens after that is the QRS starts to stabilize a little bit, and then beginning around here, where all the QRS complexes look very similar. Initially, there's a little bit of notching, and then the notch disappears, but the QRSs mostly look the same, and they're going at a rate of about 190 beats per minute. But this goes on for about 15 seconds. Each one of these strips is 10 seconds worth. You can tell that from the time. And then right here, there's a huge signal, and the rapid heartbeat stops, and you have a couple of wide beats, and then we're sort of back to where we were before. You should be able to recognize this, and I gave you a clue that the patient has an implantable defibrillator. So this is an ICD shock that occurred in response to this wide QRS tachycardia. After the shock hits, the QRSs kind of go back to the way they were initially. But then down here, you have a very slow, wide QRS. In particular over here, these beats are very regular, and they're occurring at exactly 60 beats per minute. And so this must be ventricular pacing from the ICD. In someone with atrial fibrillation, you would generally program the lower rate limit of the ICD to about 60 beats per minute. But then you have a couple of other QRSs down here that look to be conducted because they look very similar to the ones up top. A couple more paced beats. This is probably a fusion beat. And then we're back to conducting at a relatively slow rate. So how many of you think that this is definitely ventricular tachycardia and not SVT with aberrancy? Well, it's almost certainly VTach, because you have to remember that during atrial fibrillation, the AV node is what conducts the signals to the ventricle, so the AV node controls the heart rate. And the AV node behaves fairly consistently from 1 second to the next. Over the course of maybe 10 or 20 seconds, the AV node can speed up or slow down because of autonomic influences on the AV node, but you have an average rate down here of about 100 beats per minute, and then you have suddenly 180 beats per minute. And it would be very unlikely for the AV node to be able to conduct one-to-one at that rate in this patient who is already into his 80s, and you wouldn't have a sudden change in AV conduction. To say that this is atrial with aberrant conduction means that suddenly the AV node starts conducting at a blistering rate, and that's just not likely. Of course, after the ICD shocks the patient, this ventricular tachycardia is terminated, and we're back to atrial fibrillation with ventricular pacing. Now, when you see torsade, what you should always do is check the QT interval. Come on down here to the bottom of the tracing, and I think that there's an ST segment and a very large T wave with an extraordinarily long QT interval. It measures somewhere in the neighborhood of about 0.6 seconds. So you have a markedly prolonged QT interval. Why? Well, you have amiodarone, you have Namenda, and you have another agent, I believe it was Effexor, which all can contribute to QT prolongation. It turns out the patient's potassium level was 2.9. So that really is what tipped him over the edge, since hypokalemia can cause QT prolongation as well. So you have someone with atrial fibrillation with a moderate ventricular response, with a very long QT interval, who develops torsade, But the interesting thing is because he has an old myocardial infarction, this torsade triggers a reentry monomorphic ventricular tachycardia arising from the region of the myocardial scar. And since the monomorphic VT is stable and somewhat faster than the torsade, it takes over as the predominant rhythm until the ICD recognizes it, charges up, and delivers the shock, terminating the ventricular tachycardia. And then you just have a few conducted beats here and there, but mostly ventricular pacing, until his AV node kind of wakes up again, and then he starts conducting again at the very end. So I hope this was helpful for you, because sometimes you see these strips and you're not really sure what to make of it. In particular, with patients with implantable defibrillators, you don't always have a chance to actually see the thing in action. So until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is an interesting 12 lead because it has a few things wrong with it, and some of them are not exactly common. So looking at the rhythm strip, there doesn't seem to be much going on. All the QRSs look the same. If you count off the rate, it's about 75 beats per minute, and each QRS complex appears to have a single P wave in front of it. The P waves are upright in 2, and if we come up to the 12 lead, they seem to be upright in 1 and AVF, so it looks like we can simply call this a normal sinus rhythm. So let's take a closer look at our intervals. It's convenient to find a QRS complex that starts on a heavy line, so you can measure your PR interval easily. And this QRS seems to land on a heavy line right there, and the PR interval seems to be just about 200 milliseconds, so it's just at the upper limits of normal. The QRS seems to be quite narrow, and this lead only about 60 milliseconds, but it looks quite a bit wider here in lead 3. So it just looks like in lead 2, the tail end of the QRS complex appears to be isoelectric, and that's why the QRS seems to be more narrow in lead 2, but it actually extends out to here, which would give us about 100 milliseconds or so. Now what about the QT interval? If we take it from this heavy line and look at more than one lead, we can see the QT interval extends more than 400 milliseconds. It's around 460 milliseconds, which seems a little bit long, especially when you consider that the midpoint of the R to R interval is right around here, and the QT is at least that long. So let's take our calculator and figure out what the corrected QT interval is. If we take 460 divided by the square root of the R to R interval in seconds, 200, 400, 600, 800 milliseconds, and it's a little bit longer, maybe 820. So let's take the square root of 0.82, about 0.9, and then divide, gives us a little over 500, which is clearly long. Normal QTC should be about 460 milliseconds in females and 440 in males. So we definitely have a long QT interval. All right, the next step would be to look at the axis. And if we look at the limb leads, the most isoelectric lead looks to be AVR, and that, of course, is abnormal. AVR is 30 degrees above the horizontal, headed towards the right arm. So that means the axis is either markedly left up here at minus 60 or markedly right at plus 120. The inferior leads are upright, so that means the axis must be headed towards the feet. And that means that, in this case, it is plus 120. Now, as soon as we see AVR as isoelectric, we should immediately think about a hemifascicular block. In the case of a marked right axis deviation, we have to consider a left posterior hemiblock. So you should look at lead 1 and make sure that you see an R wave, because a marked right axis deviation can also occur because of an old lateral myocardial infarction. But since you have an R wave there and not a Q wave, that tells you you don't have a lateral MI, and therefore this is a left posterior hemiblock. Now, isolated left posterior hemiblock in the absence of a right bundle branch block is actually quite rare, because the right bundle branch is very thin, the left anterior hemifascicle is relatively thin, but the left posterior hemifascicle is the largest of the branches and is really quite resilient. It doesn't generally fail first. That's why of all the hemiblocks, it's really the least common. If this doesn't sound familiar, you should go back to level 2 and review the videos in section 20. Anyway, one of the things that you have to think about is, could this be a limb lead reversal? In other words, if the right arm and the left arm were accidentally reversed, then lead 1 would look upside down. So instead of looking like this, it would actually look like this, which is kind of what we have. But the thing is that with limb lead reversal, the P wave would get reversed as well. So instead of a normal upright P wave, you would see an inverted P wave. So if you see an inverted P wave with the appearance of a marked right axis deviation in lead 1, you have to think limb lead reversal. But in this case, the P wave is upright. So it looks like the limb leads are on correctly. And that's just additional proof that you have a left posterior hemiblock. Now, along with the limb lead axis, you should look at the precordial progression. And here it's kind of abnormal because you have only a little tiny R wave in V2, V3, and V4. And the transition point where the R wave grows greater than the S wave is in V5, which is a little delayed. The transition point should normally be either V3 or V4. So you have a late transition, and you also have a residual S wave here in V6, which doesn't belong. And it's common to see abnormal R wave progressions and abnormal transition points when you have a hemiblock. It's also possible that this patient has had an old anterior MI, and maybe that is what's causing the conduction system abnormality. So depending upon the cardiologist, some would say cannot rule out anterior MI, but it wouldn't be surprising to find that this patient has normal left ventricular function. There aren't any significant Q waves, and the T waves all appear to be normal. Same thing with the inferior leads. There's no evidence of ischemia or infarction there either. So, in summary, what we have is a normal sinus rhythm with a borderline PR interval, but most people would not call this as a first-degree AV block. There is a long QT interval, which you absolutely need to mention. And there's a left posterior hemiblock, which in this case is kind of an unusual finding. With poor R wave progression and the possibility of an old anterior MI, but depending upon the cardiologist, they may or may not read it that way. Well, it's just practice makes perfect, and you have to have an organized approach when you're evaluating 12-lead ECGs. I hope this was helpful, and until next time, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is a 12-lead with an interesting finding. Of course, all my Chalk Talks are interesting, aren't they? We'll take a look at the rhythm strip down here, and these first couple of beats, the QRS is sort of small, and you might conspicuously notice that there's no P wave in front of it. And then this beat, for anyone with ECG reading experience, has a nice healthy pacemaker spike here. So I'm giving away part of the answer. There's another pacemaker spike, and then there's a beat here that looks like the first couple. So there must be two different kinds of beats here. There are conducted beats without a pacemaker spike that have gone down the normal His-Purkinje system, and then you have beats like this one that are paced because they have this obvious spike and the QRS is wide and bizarre, with these secondary T-wave abnormalities where the T-waves generally go in the opposite direction from the QRS complex. And then there's a couple of normally conducted beats at a slightly faster rate, and another conducted beat here, and again there's no P wave. And if you look very carefully, you might have a sense in some of the leads that you've got atrial fibrillation as an underlying rhythm. So this atrial fibrillation seems to be conducting with a relatively slow ventricular response. These beats are at about 80 beats per minute. But what's the pacemaker operating at? How do you know what the pacemaker is programmed for? And how does it seem to be behaving? Well, if you find two spikes in a row, that will give you a major hint. Because let's just look at the rate here between these two spikes. This one lands between two heavy lines, and counting off it's exactly 1 second, we get a rate of 60 beats per minute. So it looks like we have atrial fibrillation with a moderate ventricular response and a pacemaker programmed at 60 beats per minute. Well, is that your final answer? Well, you really should analyze this a little further. The problem is that reading this 12-lead ECG is limited to the conducted beats because pace beats originate from a completely different part of the heart. The conducted beats come down the AV node and travel down the His-Purkinje system through the bundle branches, and so you can look for things like bundle branch blocks and hemi blocks. but the pacemaker lead is going to wind up being down here in the right ventricle someplace. So paced beats are going to have a QRS that's following different pathways within the heart, usually slower intramyocardial pathways, which is what makes the QRS wide, because it takes longer for a paced beat to get around the heart since it's not using the rapidly conducting, efficient Purkinje system. So the QRS duration is going to be longer. And remember, since the sequence of depolarization is disturbed, then the sequence of repolarization is going to be disturbed, and that's what gives rise to the secondary T-wave abnormalities. Okay, if you treat those as two different types of beats, you can draw some conclusions. For example, if you take a look at the paced complex here in V1, V2, and V3, it resembles a left bundle branch block, predominantly negative even out to V3. So that kind of tells us that we're pacing the right ventricle, since the left ventricle is depolarizing very late, just as if the left bundle branch were blocked. Well, some pacemaker systems are known as biventricular pacemaker systems because the left ventricle is also stimulated, generally by a lead that's inserted into the coronary sinus, which empties into the right atrium. So if you have a left ventricular lead and a biventricular pacing system, you don't get that classic left bundle branch block appearance. In fact, what may happen in V1 is you'll have significant positive components in the QRS, depending upon the location of the left ventricular lead and the time delay between the two leads. It would look much more like a right bundle branch block pattern. So it looks like this is just a plain old right ventricular pacemaker, not a bi-V pacemaker. And it's also supported by the fact that lead 2 is negative. So remember, lead 2 is going in this direction, and that tells you that the pacemaker is located somewhere near the apex, and the electrical wave of depolarization is traveling towards the head. So that gives us an idea of where the pacemaker lead is located. All right, so let's get back to the conducted beats. If we look at the conducted beats, they're upright in 1, it's slightly negative in AVF, and it's isoelectric in lead 2. So it looks like there's an underlying mild left axis deviation, but I don't see any inferior Q waves. And the one thing to note is that there's T-wave inversion in 2, 3, and AVF. Given the left axis deviation, that's sort of considered a nonspecific finding. But the other thing is that we can actually see T-wave inversion on all of the precordial leads as well. And so that does raise the possibility of ischemia because it's not exactly diffuse, it's not affecting the lateral leads. You see 1 and AVL have upright T waves, but these are symmetrical T inversions, and the person reading the EKG might want to bring up the possibility of ischemia. Now, there is a phenomenon known as myocardial memory. The term myocardial memory refers to temporary T-wave abnormalities that occur as a result of pacing, but sometimes those T-wave abnormalities persist even when the pacemaker is not pacing. Well, I hope that was a fun chalk talk for you, and next time I hope to be able to bring you even more insights into this tracing. But until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, it's Dr. Nick with the Ecg Academy, and this week's Chalk Talk is the same tracing that I had last week, but I had a few other things to mention about it, and I just ran out of time. So if you recall, this is atrial fibrillation with a moderately slow ventricular response, and there's a single-chamber ventricular pacemaker operating at 60 beats per minute. The underlying conducted QRS complexes do exhibit diffuse T-wave inversion, which we decided was nonspecific, but some people would read it as possible sign of ischemic heart disease. I mentioned that there were paced QRS complexes, but some of them are very wide, but these two are not so wide. And when you look at this beat, it has a pacemaker spike in front of it, but the QRS looks much more like a conducted beat than it does a paced beat. So you should be able to recognize these beats as fusion beats. So now what's happening is the signal is getting down the normal conduction system, but at the same time, the pacemaker stimulates the right ventricle. So the ventricle is being activated from multiple wavefronts, partly through the conduction system and partly from the pacemaker. And the QRS complex has an appearance that is sort of midway between a normally conducted beat and a fully paced beat. So if this is fully paced and this is conducted, then these are fusion beats. And this is a fusion beat, but there's more conducted contributing to the QRS than there is paced. So a fusion beat can vary in its appearance depending upon the timing of the ventricular pacing spike. If it's early, then it looks more like a captured beat, and if it's late, it looks more like a conducted beat. Now here's a question. What do we call this beat here, where there seems to be a pacing spike, but the AV node let a beat down at the same exact time, and the QRS really doesn't look substantially different than the conducted beat? It's almost like the pacing spike is there, but it's not contributing anything to the QRS complex. And an even more impressive example of this phenomenon is this first beat here. But look at that. The pacing spike occurs after the QRS starts. So it's almost like the pacing spike is in the middle of the QRS complex. Isn't that crazy? Now, does that tell you that there's maybe a sensing problem? Well, no, it doesn't, actually, because this pacemaker is not sensing the QRS complexes. It's only sensing the local activation of the endocardium right next to the pacing wire. So the conduction system may get activated and part of the ventricle may depolarize before the signal gets to where the lead is located. And so the pacemaker doesn't see the QRS until the QRS is already half finished. So it's really a wasted spike. And so this beat here, and especially this beat here, it looks like fusion, but it's not, because the pacing spike is not contributing anything. And we call this pseudofusion. Pseudofusion is a very common finding, but people don't recognize it as such. Sometimes they'll mislabel it as pacemaker malfunction or undersensing. But just remember, the pacemaker doesn't see the QRS until the endocardium right at the tip of the lead fires, and so that electrical signal is acknowledged immediately by the pacing circuitry. But until that time, it doesn't realize the QRS is there, and so it's going to pace no matter what. Well, pseudofusion represents a problem because it's a waste of energy. And in this case, when you have an irregular rhythm, such as atrial fibrillation, it's kind of hard to prevent pseudofusion from occurring. But a lot of times what you'll see is in someone with a normal sinus rhythm, and they're conducting normally, but yet there's a pacing spike in front of the QRS. So this is a case where a dual chamber pacemaker is tracking the P wave, but the AV node is conducting normally. So you really don't even need to pace under those circumstances. In that case, the pacemaker just needs to be reprogrammed to wait a little longer after the P wave before delivering the pacing spike. And what that'll do is save a lot of energy and help the battery last longer. Now, there's one other special case is when you have a right bundle branch block. So in V1, if there is an RSR prime, what that tells you is that the left side of the heart is depolarizing normally, but the right ventricle has to depolarize through very slow intramyocardial pathways. And so the moment at which the right ventricular pacing lead sees the signal is going to be somewhere during this R prime. Because remember, the R prime in V1 represents right ventricular activation, since the right ventricle is an anterior structure and V1 is in the front of the chest wall. And since the signal is going towards the front of the chest wall, it registers a positive deflection. So the R prime is equivalent to right ventricular activation. But since the pacing lead is in the right ventricle, the moment at which the pacing lead actually sees this QRS may be all the way out here someplace, or even later. So it's not uncommon for pacemaker patients who happen to have normal AV conduction, but they have a right bundle branch block. If the pacemaker is not programmed properly, you might see a pacemaker spike all the way out here someplace, because the pacemaker didn't see the right ventricular activation until after that point. So the programmed AV delay is what we talk about as the moment of atrial activation initiates the AV delay. And if the AV delay timer expires before the QRS is sensed by the pacemaker, it will pace in the ventricle. In essence, what will happen is this repeating pattern of an RSR prime with a big tall pacemaker spike that really doesn't belong there. The idea is to prolong the programmed AV delay so it waits a little bit longer, and so it's able to sense right ventricular activation, inhibit the ventricular pacing output, and thus help the battery last a lot longer. So this is a complex tracing from a pacemaker standpoint, but you should be able to recognize this when you're out there on the units. Well, I hope that helps, and until next time, this is Dr. Nick with the ECG Academy. Thanks for watching.